Incident happened in Karnataka. The doctor was my teacher. He was alleged that he injected snake bite to his wife and killed. Later, at some point of time, I think that wife and had killed her, and it said that snake had bit her. So and stings also, insect stings. So this is why all these things has to be documented or medically legally documented. It may be a OPD. Patient can come with a small wound telling that a small knife fell from the attic and fell here. But if it is suspicious, you are not supposed to treat it. Time and again, the health and family welfare keeps sending such intimations to all practitioners. A postmortem. This duty ends when he sends the intimation to the police. Our duty is to inform the police that such a such thing has happened. Duty to inform. Rest you solve it in the police station or court. You go to court, police station, you sit with them. If you don't want, they will send the intimation back. What happens practically is, you send the intimation, police also don't want to put it on their head. They will call us, sir, intimation cancel ಮಾಡ್ಬಿಡಿ. So that also is not possible. That is to save their back. Once the police intimation is signed, it is like a fire. So if you have gone to the police station, you might be seeing, FIR is a first information report. The first information report, if it is filed, you cannot tear it, you cannot scratch it. It is done, it's done. So once you have sent the intimation, don't take it back. MBBS level doctors who are not involved in the patient care. They were not involved in the patient care. It was the emergency people, physicians who are taking the patient care. When the snake bite is happening, the treatment of the snake bite is done by the physician. The length of the snake was taken by the CMO. It was like that. Okay? But it depends on the medical institute. If you are treating the patient yourself, if there is no other one to do it, it is the patient, doctor himself, the physician only records, physician only goes to the court. So when I was working in Mysore, it was a tricky situation. I didn't want to write this intimation because the critical care part is getting delayed. So what I used to do was, trauma patient comes, if it is a little bit of legal value, I used to take care of it. If it is more litigation prone, I used to tell the orthopedician to take care of it. And he was very cordial because it is a corporate hospital. They also want more cases under them. So opinion is different, observation is different. So as a person who is treating it, your duty is only to observe what is there. What is the length of the injury? You cannot comment on what is inflicted by a weapon or by a rod. Okay, that is a work of the forensic guy. So preservation of evidence and chain of custody. So emergency physician documents facts, he shall not give an opinion. So must include exact words of the patient, time, place, police intimation number, injury description. So the next one is consent and refusal. Refusal of admission, investigation, DAMA, LAMA. This DAMA and LAMA itself is a not a right word. It is not a proper abbreviation. Sorry for that. And high risk consent. All these things has to be documented. So if you are refusing admission, you have to document it. If he is refusing investigation, you have to document it. Discharge against medical advice, leaving medical advice. There's another called RAMA also. Refusing against medical advice. High risk consent for thrombolysis, documentation. These things have to be documented. So critical care documentation is area intervention, intubation details, drug dose, monitoring, handover notes. These things have to be documented at every step. Death and end of life, time of death, who pronounced the death, relatives informed, body handed over to whom. So documentation in death and CPR, time of collapse versus arrival, CPR start, ending time, drugs with dose and time, who declared death, informing relatives, police intimation when required. This is a very tricky situation, especially in emergency medicine. This you come across only in the emergency. Patient is brought dead, pulselessness. You are supposed to give CPR. Okay. Recently, we got 2 weeks. We got a guidelines from the Health and Family of Central Government that for all brought dead cases, you are not supposed to give a bill. And there is a case, I forgot to put it in the case, where a case was brought dead to the hospital and he was declared dead after a certain time. The bill was 15,000. They went to the consumer court at later point of time. So it is a tricky situation. Whom to give CPR? So whenever this happens most of the time in hospital, teaching hospitals, especially private hospitals, private teaching hospitals, the patient loads are less. You have been taught that there are 5H and 5T. The moment the body comes, you are supposed to start your investigation. 5H, 5T, ABG, intubation, central line, pneumothorax, ICD, the bill actually it goes 15 to 20,000. So whether to give intubation, CPR for that is you have to use your intelligence. Once when I was doing PG in JJM, medicine HOD was brought that to ER. When I was doing PG, surgery HOD also was brought that to ER. Medicine HOD also both were declared. And I was in first year PG. And he was found dead in his room early morning. He died in midnight. What concept is, just thump on this, thinking the heart will start. And this happened in 15, 16, 17. Like, that concept was completely outdated. We were like, Ravi sir is really angry on this person. So those things, if a trained person like us thinks that this was assault, just think about you are doing CPR to a patient and some layman just this. There's a very senior professor in Davangere by name Professor Eli. One of his patients was brought to the emergency and was giving CPR. And Professor Eli he's a very short person, almost this still here. When giving CPR, patient attendants came and almost they lifted him like this. Because they thought that they are assaulting the patient and declaring broad death. This concept is almost, and what happens is, when you are declaring death, make a notes. Even suppose the patient is broad dead, pupils are dilated, almost in rigor mortis. What are you start bleeding of rigor mortis? What are you going to do with CPR? But they may sue you that you have not tried to attempt it. So what you have to do? You have to record. Patient attempted, according to ACLS protocol, CPR start initiated, adrenaline given, 3 cycles of this. You are going to document it for our safety. Don't give CPR, don't do ABG, pneumothorax for all broad dead rigor mortis patients. So this is almost similar to the scenario which you are seeing now in where some young interns or fresh postgraduates in private colleges, most probably, are doing videos on cardiac resuscitation or patient care, how to lead a healthy life. The senior doctors who have seen the lakhs of patients are silent. They are not the YouTube stars. The interns, first year PGs in a peripheral private college, they are becoming YouTube stars because of the mistake. So they have not done anything, but they patient. The previous PG or the resident would have written patient conscious, cooperative, pulse rate. What we tend to do is just see that and write the same thing. The copy paste, that should not be done. Missing the timestamps, you are not writing the time. So when we were in I was working in Mysore. It had become a very headache. So we are used to writing date we will write. Time we were never trained to write. So every day after a round server, sisters will bring the case sheets. So on time per middle, on time per. That is because of NABH assessment. So missing the timestamps, overwriting notes, you are not supposed to cut, so court may not like it. Non-standard abbreviation like DAMA, LAMA, PR, RR. PR is pulse rate. It can also be per rectum. So writing opinions instead of observations, lack of reassessment notes. Reassessment notes is very important. Emergency medicine, we have something called as primary assessment and the secondary assessment. Or in the ward or ICU, periodic assessment. You have to reassess and write the observations. 78, 82, that is a natural, 72, 120 by 8. They will see the nursing because they trust more. Nursing, they will not fake it. They will see it and they will write it. Second, objectivity, time, consistency. So in ED, it is still a question whether it is a life-saving procedure or documentation. A patient has been brought in a gasping state, whether the attendants are available, delay endangers his life or limb. According to section IPC 192 or the Bharatiya Nyaya Samhita section 30. What must be documented in emergency is the patient condition. Always document patient condition at arrival, why immediate intervention was required, why consent would not be obtained, why was it not intimated to the patient attendants, who was in prison for lack of consent and legal justification. So this is the very famous case which the court mentions, where patient Paramanand Katara versus Union of India, where it is ruled that the doctors, whether in government or private hospitals, must provide immediate first aid in an emergency as a life-saving takes precedence over any legal formalities. So this case usually protects you in case if you have done something and not taken the consent. This allows that doctor intubated, it was intubated and shifted to ICU. Hypoxic injury, endotracheal intubation performed in patient's best interest. So coming to another concept, so all the while we are discussing about documentation done. So you have done, if you have the intubation, you have done the intubation, but in the case sheet it is not written, it is as good as you have not intubated it. So it also means that if it was not documented, it also means that you do not know it. So where does this come into scenario? So this is a small scenario. This is a 30-year-old female presents to ED with history of allergy after taking tablet amoxicillin. On presentation, patient vitals were stable. Patient had only gluteus reaction. Patient was treated with symptomatic medication and discharged. This is a very common scenario. This is a photo which our PGs had done just for the demonstration purpose. This is the commonly put allergy to amoxicillin, rashes present, injection amyl and ranitidine, adrenaline, something is given, diagnosis, anaphylaxis, and patient is sent home. This is the commonest, whether it comes to OPD also, or if it comes to emergency, this is what the commonly we do. So patient again developed rash and mild breathing difficulty after 24 hours and approached a different hospital. Patient is admitted on a daycare, given almost the same medication which was given in the previous hospital. So what we want to focus here is, the treatment is same. It is same, adrenaline, amyl, hydrocodone, trantax, and maybe some fluids. He has come again because it is called as biphasic reaction. If you know that allergy can present within 24 hours, again, and with more vigor, what you should have done, you have mentioned the medications, what you have given, and explain about the repetition of the symptoms, and to review immediately. And what is more important is the diagnosis. What is the diagnosis? Anaphylaxis secondary to drug ingestion, tablet amoxicillin, ring and Mesmer grade 2 anaphylactic reaction. This means that there is a classification for anaphylaxis. Okay, there is 1, 2, 3, 4. Ring and Mesmer is grade 4. If you know, you will mention it, or else it becomes a simple diagnosis. Anybody can write it. For final year student also can write it. Just remember a case that happened almost 4 years back. I had just finished my PG and working in a hospital in Mysore. I got a call from Madikeri, one of our relatives, patient bada serious. Okay, then we told him to take him to the nearest well-known hospital. Patient was taken to that hospital. Trained person had seen it, and after half an hour they said Mysore Karkondoli, standard protocol. Okay, so then I told what is the condition of the patient. Then he said, give the phone to the doctor. The phone was given to the doctor, very well known doctor. I asked the patient, glucose stable. I asked him what is the GCS, so that intubate someone. He said GCS improved. Then the patient came in a small Omni ambulance. By the time when we came here, it was a contact hemorrhage with GCS of 3, almost in extensor positioning. And we asked the attenders, because I was there and the relatives, how is that? Is the condition of the patient? Since the arrival, we took him to the hospital. So this is not a medico-legal complaint. See, you, the treating doctor, the referring doctor, not knowing what is GCS is called as losing your face. He may be very, very senior, paid crores of money by serving people, but what is the impression the young doctor gets when you say GCS is normal? For dead body, GCS is 3, right? So this is called as losing the face. The documentation, knowing the scoring systems, staging, these things will save your face. May not be the back. Okay. So there are different scorings and gradings, academic point of view. So many physicians complain that they do not have time or to write sufficient records. So the concept is, if you don't have time, you'll have to spend time in the court. So there is something called as video consent. This is off late, coming as wherever you are entering the hospital, whatever you are telling, it is video recorded. So, but this is also illegal. You cannot video record anything unless you take the permission of the patient. But still, when I was working, there was a room and it was written in the board of it. Video recording done of the conversations here. I don't know if it is legally viable. So I'll tell you the one more interesting thing. So according to it, it is feasible, but still the court depends on the written consent, not the video consent. So this happened during the second wave of COVID. A leukemia patient came to the hospital where I was working. He had chemotherapy along with him. 32-year-old guy came to the hospital in a very bad state. severe thrombocytopenia, severe anemia, plastic crisis. So oncologist in the hospital refused to admit him because this case was treated in, chemotherapy was given in other Bangalore hospital. So chemotherapy is the dollars of the hospital. Chemotherapy all ಬೇರೆ hospital ಕೊಡ್ಬಿಟ್ಟು pantoprazole randomly in ನಮ್ಮ hospital they will admit. So me out of concern we admitted in the emergency department, we started treating him. But he was developing a ARDS-like picture, he was deteriorating, and that was a time when all the ventilators were preserved for COVID patients, the fag end of COVID. So we didn't have the BiPAP patients also. It was there, it was for COVID patients. So we kept on telling him that this we don't have NIV, we don't have ventilator, shift the patient to the Bangalore hospital. And the patient kept on saying, we know that patient is dying, it's the last stage of CLL, so you do whatever you want. But one day, one sister, she is actually from MADIKERI, she came and told me, sir, don't trust them, you take a video recording of the whatever you are telling. So I was on night duty that day, so we take video consent was taken telling that the thing is he didn't know that the recordings were going on. Whatever I had done, said from day 1, I repeated it on day 3 or day 4. That NIV and he whatever he said also got recorded. One fine day, the night he deteriorated. So I said we will put him on ventilator. And finally made a ventilator and put him on ventilator. And 8:30 my friend, Dr. Zoe, he was pulmonologist, he called me, Bopana, what did you tell to the patient? The patient is dead. He got arrested at 7:30, but there is some situation in the hospital. No, I told him, from day 1 I am telling them that patient is deteriorating, he will not survive, you have to refer him. No, now the different sounds are coming. I took, that is day off for me, but got ready and went to the hospital. The situation is different. The patient's son, the father, I still remember him, he's a lorry driver and owner. He's the driver of the, that is a different concept already. Okay. So, he is not seeing my face. Every day he used to see my face, he used to talk to me, sir, everything was, today he is just seeing through me. And the case, the body was shifted to the mortuary. By evening 6:30, the people started ventilating in the emergency. By that time, the MLC, MLA, and they also came for consent. Video documentation is to save your back. It has a code identifies it, but what happens is if you present a video consent, did you take consent for that video? That becomes a problem. So it will save your back, may not save your face in the court. The patient gives against advice, dies at home 6 hours later, family arranges, doctor sent him home. Okay. So what happens is inadequate documentation, patient left against medical advice. This is what we do. We write it, patient left against medical advice, no risk explained, documented, no patient signature, more. So one copy you have to keep. So this is inadequate documentation. What would have been adequate documentation documented in simple language? Now the patient is not signing. I think legal people should time it better. If it is a criminal case, again these things don't have. Coming to the last few slides, documented call from the hospital where I was working. They said, sir, you know, someone's done it. And I had no idea what is that case. And unfortunately, it was a COVID case. And I asked them to send the case sheet of that patient. Believe it or not, case sheet is almost empty because it was a COVID ICU patient. COVID ICU type patient. It was a different type. It was a different. They referred the patient to the nearby Apollo hospital. The patient succumbed. So I got a summons, but the lawyer called me and said, "Son, you will manage." And I didn't go till today. I don't know what happened later. So conclusion is, documentation is not a clerical task.
Thank you very much, Anil. So we used to have something called as child safeguarding. So any child that was with a mother who was probably known for drug use or abuse or any of these things used to come under us. And once a child had come to me in their casualty, I was finishing off my duty, but then because of this child I had to stay late. Documented in depth everything, came back to cook, started my practice here, and one day all of a sudden I get an email saying you have been asked to come to court because this child's case has come up. They said your email ID that used to work, the NSS ID is not working, so we have to get you here and we are informed that you have to come to court. But the problem was I was here and for one hearing I couldn't go all the way. So they took me up for a virtual court, and I had to present my evidence from court, the virtual court. So that's how important documentation is. So yes, so everyone better buck up and document everything and stay safe. And thank you very much for the organizing committee for having me here. And
subordinates like PGs and interns. 2 parts I need the inputs from you. We are writing all for signatures and all. How it will be taken in the court and as well as the documentation purpose. As well as the treating doctor, not mentioning but the unit's name is written and all. Some lights about that. And regarding medical legal cases, is it okay to write for or is it mandatory that a treating doctor?
Okay, if it is a criminal case, whole for against everybody will be brought to the court to the law. But generally we write for. When I was doing PG case, we will not write our names also. It was case seen by Dr. Chandrasekhar Maheshwar. The for has no value in court of law. And if it is respondent superior, the person who is in charge of the department at the end will be pulled. So if the intern is writing, because it is he still has not got a permanent registration number, it is again the boss is responsible. But once you are, whether it is postgraduates or signing, they are responsible.
I had an experience at a private hospital here, Virus Hospital, but I was not involved in that. Dr. Ajit is there. Okay. One patient, PGH patient, was brought to the reception and immediately it was rushed to the OT. Our gynecologist, anesthetist, they were so busy in saving the patient. They did not write the case sheet at all. So, patient later on, after a few hours, patient died in the OT. So the whole mob entered the OT, ransacked the OT, and with due respect to our police here, police was intimidated by the local people. So police SHO, they all came and confiscated our case sheet. Then of course our SP was our good friend. We told him like this happened scenario. So SP spoke to our station who was the inspector there. Then the case sheet was written up later on. Then what you said was rightly, definitely it has to be noted. When we write the case sheet, the doctor timing and the sister timing must match. It was a mismatched one because it was written later on. It was mismatching. The timings was mismatching. What doctor notes timing was different and sister notes timing was different. It went to the court. So in the court of law, they identified this mismatch of the timings written in the case sheet. Ajit, I think you remember this case.
No, I don't know.
Okay. He was also there. So ultimately what happened was, oh, he was there. Correct, he is there. Okay, his wife is a gynecologist. She was there. So ultimately the matter settled out sister's timing as well as the doctor's timing. So the court identified this mismatch of the timings. This is what I want to convey.
To do it, he will do it meticulously. Time match ಮಾಡೋದು, ಜಾಗ match ಮಾಡೋದು. If you go to some private colleges, they are there. See, if your NMC inspection is going to happen here, only you should be worried about the infrastructure. Because private colleges, they have to get worried about the patient load, ambulances, vehicles parked outside. Okay. So what has happened was, they should take one case sheet. They should say ANC our number hakkidare. Where did they go for ANC? Whether the number is matching in the doctors are gentle beings, we have to learn certain skills.
Our patron-in-chief, Dr. Lokesh AJ, Union Director, to please come on the dais. Our patrons, Mr. Vishal Kumar, Principal, Coins Madikeri, Dr. Somshekhar HK, Medical Superintendent, Coins Madikeri, Dr. Nanjundaya, the District Surgeon, Coins Madikeri, Mrs. KM Rohini Basuraj, our CAO, Dr. Abhinandan, the RMO, Kaveri Block, Dr. Dhananjay Kumar, RMO NCH Block, to please come on the dais. HOD, Department of Dentistry. Organizing Joint Secretary, Dr. Purushottam DR, Professor and HOD, Department of Pediatrics. Charapati N, the State Chairman, IAP Medical Legal Chapter, to please grace the dais. May I request Dr. Chandrasekhar HV, Inspector, Madikeri Rural Division, to please come on the dais. Salutations to the flame which brings auspiciousness, prosperity, health and destroys negativity. I request all the dignitaries of the dais to please come forward and light the lamp. We request you all to rise for the prayer and lamp lighting.
गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणाधीशाय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि नमस्ताय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलस्थायिने गुरुविक्रमाय गुह्यप्रवराय गुरवे गुणगुरवे गुरुदैत्यकलाक्षेत्रे गुरुधर्मसदाराध्याय गुरुपुत्रपरित्रात्रे गुरुपाखण्डखण्डकाय.
It gives me immense pleasure to welcome you all to this conference, Medical Legal Essentials in Emergency Care and hands-on workshop on basic life support. The theme here is saving life and staying safe. This is a sort of a unique concept which we have initiated this time with the guidance of our Dean and Director, Dr. Lokesh, who guided us, and we started this program together, two departments joining together and having a common platform, sharing the knowledge. And the main idea of this program is to save the treating doctor as well as to give a best care for our patients. This is our motto of this wonderful day, this 2 days program. So I like to honor our Dean and Director, the Principal, Dr. Vishal Kumar, who is always so academic to this institution. I welcome you, sir. She's here with us, and we are all IME, as well as who is so forensic department. We are Rajit is here, Dr. Aziz is here, and our NEMA doctors are there with us who are supportive to us. Thanks for accepting our invitation. Rajaram is the president of NEMA Ayush for KODAGU branch, and his team has come. So I like to recognize the presence of our dental Dr. Hemant has come all the way from Shulya. He is actually from my wife is here, Mrs. Nisha Mohan is here. She is also very supportive to me for all this sort of functions. Thanks for coming, and I wish you will come in the evening also. I want to call you in the evening program also. Please do come. All of you, all the faculties. I expect all the faculties to come in the evening also. He is also a KGMO president. Thanks for coming, for gracing us. All the staffs, all the faculties of this institution, and as well as non-teaching staffs also having come, I really appreciate. And of course, our Master of Ceremony, Sumuk, and our 4 days, they are working very hard in the emergency. She is a casualty medical officer. Since many years, she is working in our casualty. Very good medical officer. She is doing a great job in casualty. Start in the afternoon, maybe tomorrow they will be coming. Our Honorable Panana has already confirmed it yesterday that he is coming tomorrow. And Mantargod is already there in Bangalore Vidhan Sabha. That meeting is there. He has conveyed a message to us. So tomorrow I think they will be gracing the occasion. So once again I extend a warm welcome to everyone and wish all of you a high It must be a very informative, interactive and successful conference. Hope you'll enjoy this 2 days stay here, all the delegates and resource persons also. You have to carry this good message and let us work together, strengthen the doctors community and see that less litigation will happen. So our doctors fraternity must work together, conduct similar programs to save our skin as well as to render the better service to our
saving life and staying safe. If you do safe practice, you will stay safe. That means to practice safe practice, you have to update yourself. Especially students are not talking to patients, they are not taking history, they are not examining. There are so many instances or case scenario Gopala has narrated in his talk. You are not taking history. See, 10 days back, I think 2-3 months back, one patient came to our emergency department. Then the patient was having irrelevant behavior. Nobody did check the blood glucose level. Then they referred the patient saying that this is a psychiatric patient and all. They have corrected hypoglycemia, the patient became all right in Bangalore. This is an example for you to improve your knowledge. That's why keep talking to the patient. Talking to the patient means you should take history. You are not taking history because you are addicted to mobile. That's a major problem. When mobile is there, you will not talk. You will not talk to patients also, and you will create nuisance here. And some people are sleeping even in this session also. At least in the classroom, people will sleep. One person is sleeping since half an hour. One student. That's the interest. That's why I am telling you, if you save the patient, patient will also save the doctors. That's why you should update, and that's one side. Other side is you should do fair practice, honest practice, and then you should develop some goodness. This will save from all these atrocities against patient or whatever the documentation reporting that this and all you do. Ultimately, you should develop some goodness and experience also. If you see more number of patients, you will be experienced so much so that you will not get into trouble. Once again, I wish you all the best for this conference. Thank you, Honorable.
IIP Medical Legal Chapter to please speak a few words.
There is an increase of 400% of litigations on doctors. You can imagine the proportion of the allegations that have been foisted on doctors. So you all have to be equipped with day-to-day legal implications in our practice. And what are these cases? All the cases, most of these cases were forced on doctors because of poor consent. 80% of these cases were because of poor consent, and rest of them were because of poor documentation. And Dr. Bhupanna brought out everything in detail regarding the documentation. So friends, particularly the students, this is very good that we have started training them regarding the medical legal issues. So I once again wish this program a grand success. I don't want to take much time.
ಈಗ ತಾನೇ ಸರ್ ಹೇಳಿದ್ರು, ಒಂದು ಪಾಯಿಂಟ್ ರೈಸ್ ಮಾಡಿದರು, ನಾವು ಕೂಡ ನೋಟಿಸ್ ಮಾಡಿದ್ದೀವಿ. ಪೂರ್ ಡಾಕ್ಯುಮೆಂಟೇಷನ್ ಅಂತೇಳಿ, ಅದು ಖಂಡಿತವಾಗ್ಲೂ ನಮ್ಮಿಂದನೂ ಪೂರ್ ಡಾಕ್ಯುಮೆಂಟೇಷನ್ ಆಗುತ್ತೆ, ನಿಮ್ಮಿಂದಲೂ ಕೂಡ ಪೂರ್ ಡಾಕ್ಯುಮೆಂಟೇಷನ್ ಆಗುತ್ತೆ. ಅದ್ರ ಕರೆಕ್ಷನ್ಸನ್ನು ಖಂಡಿತವಾಗ್ಲೂ ಮಾಡಲೇಬೇಕಾಗುತ್ತೆ. ವೈದ್ಯಕೀಯ ಒಂದು ವೃತ್ತಿಯಲ್ಲಿರುವಂತಹ ಡಾಕ್ಟರ್ಸ್ಗಳು ಜೊತೆಗೆ ನಮಗೂ ಕೂಡ ಇನ್ವೆಸ್ಟಿಗೇಷನಲ್ಲಿ ಹೊಸ ಹೊಸ ಚಾಲೆಂಜಸ್ಗಳನ್ನ ನಾವು ನೋಡ್ತಾನೆ ಹೋಗ್ತಿದ್ವಿ. ನಮಗೆ ನಾವು ಇಲಾಖೆಗೆ ಸೇರೋದಕ್ಕಿಂತ ಮೊದಲು ಪ್ರೊಫೆಷನ್ ಡಾಕ್ಟರ್ದು ವೃತ್ತಿ ನಾವು ನೋಡಿರುವಂತಹ ಕೆಲವೊಂದು ಚಲನಚಿತ್ರಗಳು, ಮೂವಿ, ನಂತರ ನಾವು ಕಣ್ಣಾರೆ ನೋಡಿರುವಂತಹ ಟ್ರೀಟ್ಮೆಂಟ್ ತೆಗೆದುಕೊಂಡಿರುವಂತಹ ಡಾಕ್ಟರ್ಸ್ ಇವರನ್ನ ನೋಡಿ ನಮಗೆ ನಾವು ಕೆಲವು ಪಿಕ್ಚರ್ಗಳನ್ನು ನೋಡಿ ನಂತರ ನಮಗೆ ಟ್ರೀಟ್ ಮಾಡಿರೋಂಥ ಡಾಕ್ಟರ್ಗಳನ್ನ ನೋಡಿ ಈ ಪ್ರೊಫೆಷನ್ ಬಗ್ಗೆ ಅಲ್ಪ ಸ್ವಲ್ಪ ತಿಳ್ಕೊಂಡು ಬಂದು ಅದರಲ್ಲಿ ನಮ್ಗೆ ಗೊತ್ತಿರೋ ಹಾಗೆ ನಿಮ್ಗೊಂದು ಮೆನ್ಷನ್ ಮಾಡ್ತೀನಿ. ಒಂದು ಮೂವಿ ಇದೆ, ಡಾಕ್ಟರ್ ಕೃಷ್ಣವರ್ಧನ್ ಅವ್ರದ್ದು, ಡಾಕ್ಟರ್ ಕೃಷ್ಣ ಅಂತೇಳಿ, ಭಾಳ ಚೆನ್ನಾಗಿದೆ. ಸೂಪರ್ಸ್ಟಿಷಿಯಸ್ ಬಿಲೀವ್ಸು, ನಂತರ ಡಾಕ್ಟರ್ ಟ್ರೀಟ್ಮೆಂಟು, ಒಬ್ಬ ಫಿಟ್ಸ್ ಪೇಷಂಟ್ ಇರ್ತಾರೆ, ಯಾವ ರೀತಿ ಅವರು ಹ್ಯುಮ್ಯಾನಿಟಿ ಬೇಸಲ್ಲಿ ಅವ್ರಿಗೆ ಟ್ರೀಟ್ ಮಾಡ್ತಾರೆ ಅಂತ ನಾವು ಮೂವಿ ನೋಡಿ ನಾವು ತಿಳ್ಕೊಂಡಿದ್ದೀವಿ. ನಂತರ ನಮ್ಮ ಸಣ್ಣ ಪುಟ್ಟ ಇದರಲ್ಲಿ ನಮಗೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಟ್ಟಿರುವಂಥ ಡಾಕ್ಟರ್ ಕಿಶೋರ್ ಕುಟ್ಟ ಒಬ್ಬರು ಡಾಕ್ಟರ್ ಇದ್ರು ವಿರಾಜಪೇಟೆಯಲ್ಲಿ. ತುಂಬ ವರ್ಷ ಅವರು ಸರ್ವಿಸ್ ಮಾಡಿದ್ರು. ಬಹಳಷ್ಟು ಹೆಸರು ಮಾಡಿರುವಂಥ ಒಬ್ಬರು ಡಾಕ್ಟರ್ ಅವರು. ಅವ್ರ ಮೂಲಕ ನಾವು ಈ ಥರ ಡಾಕ್ಟರ್ಗಳನ್ನ ಕೂಡ ಪರಿಚಯ ಮಾಡ್ಕೊಂಡು ಹಾಸ್ಪಿಟ್ಲು ಡಾಕ್ಟರ್ ಅಂದ್ರೆ ಹೀಗಿರ್ತಾರೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಹೀಗಿರುತ್ತೆ ಅಂತ ಹೇಳಿ ತಿಳ್ಕೊಂಡಿದ್ದು. ನಂತರ ಇಲಾಖೆಗೆ ಸೇರಿದ ಮೇಲೆ ಚಾಲೆಂಜಸ್, ಡಾಕ್ಟರ್ಸ್ ಮೇಲೆ ಏನು ಅಲಿಗೇಷನ್ಸ್ ಬರ್ತದೆ, ಡಾಕ್ಟರಿಂದ ಡಾಕ್ಯುಮೆಂಟ್ಸ್ ಅನ್ನ ಕಲೆಕ್ಷನ್ ಮಾಡ್ಕೊಳ್ಳೋದ್ರಲ್ಲಿ ಅಥವಾ ರೆಕಾರ್ಡ್ಸ್ ಅನ್ನ ಕಲೆಕ್ಟ್ ಮಾಡ್ಕೊಳ್ಳೋದ್ರಲ್ಲಿ, ಅದನ್ನ ಡಾಕ್ಯುಮೆಂಟೇಶನ್ ಮಾಡೋದ್ರಲ್ಲಿ, ಅದನ್ನ ಪ್ರೆಸೆಂಟ್ ಮಾಡೋದ್ರಲ್ಲಿ ಯಾವ ರೀತಿ ಪೊಲೀಸ್ನವರು ಹೇಳ್ತಾರೆ, ಅದನ್ನ ಎಲ್ಲಿ ಸರಿಪಡಿಸ್ಕೊಳ್ಬೇಕು ಅಂತೇಳಿ. ಈಗ ತಾನೇ ನಾವು ಬರೋಕ್ಕಿಂತ ಮೊದಲು ಗೋಪನ ಸರ್ ಮಾತಾಡ್ತಿದ್ರು, ನಾವು ಬೇಗ ಬರಬೇಕಿತ್ತು ಅಷ್ಟು ಬಹಳ ಚೆನ್ನಾಗಿ ಅವರು ಅದನ್ನು ಹೇಳ್ತಾ ಇದ್ರು. ಈ ಚಾಲೆಂಜಸ್ಗಳನ್ನ ಮೀಟ್ ಮಾಡಿಕೊಂಡು ಅದನ್ನ ಫೇಸ್ ಮಾಡಿಕೊಂಡು ಯಾವ ರೀತಿ ಹೋಗ್ಬೇಕು ಅನ್ನೋದನ್ನ ಕಲಿಯೋದು ತುಂಬಾ ಚಾಲೆಂಜಸ್ ಮೆಡಿಕಲ್ ಫೀಲ್ಡ್ನಲ್ಲಿ. ಅದೇ ರೀತಿ ಡಾಕ್ಯುಮೆಂಟೇಶನ್ ಕೂಡ ಮಾಡುವಂಥದ್ದು ಕೂಡ ಅಷ್ಟೇ ಇಂಪಾರ್ಟೆಂಟ್ ಆಗುತ್ತೆ. ಸೆಕ್ಯೂರಿಟಿಗೋಸ್ಕರ ನಮ್ಮ ಸೇಫ್ಟಿಗೋಸ್ಕರ ಆಕ್ಟ್ ಇದೆ, ಇಲ್ಲ ಅಂತಿಲ್ಲ. ಹೊಸದಾಗಿ ಆಕ್ಟ್ 2009 ಮೆಡಿಕಲ್ ಪರ್ಸನ್ಸ್ ಮೇಲೆ ಏನಾದ್ರು ಅಟ್ರಾಸಿಟೀಸ್ ಆದರೆ ನಾವು ಅದರಲ್ಲಿ ಆ ಕೇಸ್ ಆ ಆಕ್ಟ್ ಅಂಡರ್ಲೇ ಬುಕ್ ಮಾಡ್ತೀವಿ. 2009 ಒಂದು ಆಕ್ಟ್ ಇದೆ, ಅದರ ಅಡಿಯಲ್ಲೇ ಬುಕ್ ಮಾಡಿ ನಾವು ಕೇಸನ್ನು ರಿಜಿಸ್ಟರ್ ಮಾಡಿ ತನಿಖೆ ಮಾಡ್ತೀವಿ. ಅದು ತನಿಖೆಗೆ ನಿಮ್ಮ ಸೇಫ್ಟಿಗೆ ಇರುವಂಥದ್ದು. ಬಟ್ ಅದನ್ನೆಲ್ಲ ನಾವು ಇವತ್ತೆಲ್ಲವೂ ಕೂಡ ನಾವು ಚೆಕ್ ಮಾಡ್ತೀವಿ. ಸರ್ ಹೇಳಿದ್ರು, ವಿಡಿಯೋಗ್ರಫಿ ತನಕ ಕೂಡ ಹೇಳಿದ್ರು, ಖಂಡಿತವಾಗಿ ತಗೊಳ್ಳೇಬೇಕಾಗುತ್ತೆ. ತಗೊಳ್ಳಲ್ಲ ಅಂತ ಹೇಳಿದ್ರೆ ಅವ್ರು ತಗೋತಿರ್ತಾರಲ್ಲ, ನೀವು ತಗೊಳ್ಳೋಕೆ ಏನು ತಪ್ಪೇನಿಲ್ಲ, ಖಂಡಿತವಾಗಿ ತಗೊಳ್ಬೋದು. ನಂತರ ಅದನ್ನ ಪರ್ಮಿಷನ್ ತಗೊಳ್ಬೇಕು ಬಿಡಬೇಕು ಅಂತ ಹೇಳೋದು ಪ್ರಶ್ನೆ. CCTV ಕ್ಯಾಮರಾಗಳನ್ನ ನಾವು ತುಂಬ ಇಂಪಾರ್ಟೆನ್ಸ್ ಇರ್ತದೆ, ಅದನ್ನ ನಾವು ಹಾಕ್ಲೇಬೇಕು ಅಂತ ಹೇಳ್ತೀವಿ, ನಾವು ಅದನ್ನ ತಗೊಳ್ತೀವಿ. ಅದು ಒಂದು CCTV ಕ್ಯಾಮರಾದಲ್ಲಿ ರೆಕಾರ್ಡ್ ಆಗಿರುವಂಥ ಫುಟೇಜ್ ಎಲ್ಲ ವಿಚಾರವನ್ನು ಹೇಳ್ಬಿಡುತ್ತೆ. ನಮಗೆ ಸ್ಟೇಟ್ಮೆಂಟ್ಸ್ಗಿಂತ ಅದೇ ಎಲ್ಲ ಪಿಕ್ಚರ್ನ ಹೇಳ್ಬಿಡುತ್ತೆ, ಯಾರ್ಯಾರು ಏನೇನು ಮಾಡಿದ್ದಾರೆ ಅಂತ ಹೇಳ್ಕೊಂಡು ಹೇಳುತ್ತೆ. ಹಾಗೇನೆ ಹಾಸ್ಪಿಟ್ಲಿಗೆ ಹೋದಂಥ ಸಂದರ್ಭ ನಾನು 2 ಇದನ್ನ ಫೇಸ್ ಮಾಡಿದ್ದು ನನಗೆ ಈಗಲೂ ಯೋಚನೆ ಇದೆ. ಸುಳ್ಯದಲ್ಲಿ ಡೆಲಿವರಿ ಆಗುವಂಥ ಟೈಮಲ್ಲಿ ಒಂದು ಏನು ಎಂಬಾಲಿಸಿಮ್ ಅಂತೇಳಿ ಆಗುತ್ತೆ. ನಾನು ಆವಾಗಲೇ ಫಸ್ಟ್ ಕೇಳಿಸ್ಕೊಂಡಿದ್ದು ಈ ಥರ ಎಲ್ಲ ಇರುತ್ತೆ ಅಂತೇಳಿ. ಆ ಸಂದರ್ಭದಲ್ಲಿ ಪಿರಿಯಾಪಟ್ಟಣದಿಂದ ಬಂದು ತುಂಬ ಗಲಾಟೆ ಮಾಡ್ತಾರೆ, ಕ್ಲಾಸಸ್ ಎಲ್ಲ ಹೊಡೆದಾಕ್ತಾರೆ. ನಾವು ಅವ್ರನ್ನೆಲ್ಲ ಅರೆಸ್ಟ್ ಮಾಡಿ ಕೇಸ್ ಬುಕ್ ಮಾಡ್ತೀವಿ ಅವ್ರ ಮೇಲೆ. ಆಮೇಲೆ ನೋಡಿದಾಗ ಆಲ್ರೆಡಿ ಅವರಲ್ಲೇ ಟ್ರೀಟ್ಮೆಂಟ್ ತಗೊಳ್ತಿರೋ ಡಾಕ್ಟರ್ ಹೇಳಿದಾಗೆ ಸಿಚುವೇಶನ್ ಬಂದ್ಬಿಟ್ರೆ ಸಡನ್ಲಿ ಅವರು ಫೇಸ್ ಚೇಂಜ್ ಆಗಿಬಿಡ್ತದೆ, ಜನ ಬಂದ್ಬಿಡ್ತಾರೆ. ಆಮೇಲೆ ಅವ್ರದ್ದೇ ಆದಂಥ ಇದನ್ನು ಪ್ರೆಸೆಂಟ್ ಮಾಡ್ತಾ ಹೋಗ್ತಾರೆ. ಸೇಮ್ ಆ್ಯಸ್ ನಮ್ಮ ಕುಶಾಲನಗರದಲ್ಲಿ ಇತ್ತೀಚೆಗೆ ಒಂದು ಕೇಸ್ ರಿಜಿಸ್ಟರ್ ಆಯಿತು. ಆ ಥರ ಅದರಲ್ಲಿ ನಂತರ ಒಂದು ಕ್ಯಾಸ್ಟು, ನಂತರ ಕಮ್ಯುನಿಟಿ ಅದೆಲ್ಲ ಹೋದಾಗ ಬೇರೆ ಬೇರೆ ರೀತಿಯಾಗಿ ಬೇರೆ ಬೇರೆ ಟರ್ನ್ಸ್ ಅಂತ ಹೋಗುತ್ತೆ. ಬಟ್ ಮೆಡಿಕಲ್ ಲೀಗಲ್ ಕೇಸಸಲ್ಲಿ ಇದೆಯಾ ನೆಗ್ಲಿಜೆನ್ಸ್ ಇದೆಯೋ ಇವತ್ತು ಡೈರೆಕ್ಟಾಗಿ ನಾವೇನು ಬುಕ್ ಮಾಡ್ಲಿಕ್ಕೆ ಆಗಲ್ಲ. ಯಾಕೆಂತ ಹೇಳಿದ್ರೆ ಮೊದಲು ಪ್ರಿಲಿಮಿನರಿ ಇದಕ್ಕೆ ನಾವು ಬೋರ್ಡ್ಗೆ ಕಳಿಸ್ತೀವಿ, ಅಲ್ಲಿಂದ ನಮಗೆ ಬಂದ ಮೇಲೆ ನಾವು ಒಂಥರ ಇನ್ವೆಸ್ಟಿಗೇಷನ್ನ ಮಾಡ್ತಾ ಹೋಗ್ತೀವಿ. ಅವರು ಎಮೋಷನಲ್ಸ್ ಇರ್ತಾರೆ, ಸೊ ಪೇಷನ್ಸ್ ಆಗಿ ನಾವು ಕೂಡ ಅದನ್ನು ವಿಚಾರವನ್ನು ಮಾಡಬೇಕಾಗುತ್ತೆ. ನಾವು ಕೂಡ ಅಷ್ಟೇ ಬಂದು ಯಾರು ಕಂಪ್ಲೇಂಟ್ ಕೊಟ್ಬಿಟ್ಟು ಅಂತ ಹೇಳಿ ಮಾತ್ರಕ್ಕೆ ನಿಮ್ಮ ಹತ್ರನೂ ಕೂಡ ಕಿರಿಕಿರಿ ಮಾಡ್ಕೊಳ್ಳೋದು, ಜೋರಾಗಿ ಮಾತಾಡೋದು ಏನು ಯೂಸ್ ಇಲ್ಲ. ಸೊ ಪ್ರೊಫೆಷ್ನಲಿ ನಾವು ಆ ಕೆಲಸಗಳನ್ನ ಮಾಡ್ಕೊಂಡು ಹೋಗ್ಬೇಕಾಗುತ್ತೆ. ಮೆಡಿಕಲ್ ಕಾಲೇಜಲ್ಲಿ ಮಾತ್ರ ಅಲ್ಲ, ನಾವು ಎಲ್ಲಿ ಕೆಲಸ ಮಾಡಲಿ ಡಾಕ್ಟರ್ ಮತ್ತೆ ಪೊಲೀಸ್ನವ್ರು ನಡುವೆ ಒಂದು ಮೆಡಿಕಲ್ ಲೀಗಲ್ ಕೇಸಲ್ಲಿ ಬಹಳಷ್ಟು ಬಾಂಡ್ಸ್ ಇರ್ತವೆ, ಇರಲೇಬೇಕಾಗುತ್ತೆ. ನಮಗೊಂದು ಸರ್ಟಿಫಿಕೇಟ್ ಕೂಡ ಬರ್ಬೇಕಾದ್ರೆ ನಾವು ವೆಯ್ಟ್ ಮಾಡ್ತೀವಿ. ನೀವು ನಮಗಿಂತ ಬಿಸಿ ಇರ್ತೀರಾ ನಮ್ಗೆ ಗೊತ್ತು, ಯಾಕೆಂದರೆ ನಿಮ್ಮದು ಲೈಫ್ ಸೇವಿಂಗ್ ಕೆಲಸ. ನಾವು ಅದಕ್ಕೆ ನಮ್ಮ ಸಿಬ್ಬಂದಿಗಳು ಕೂಡ ಅದನ್ನು ಮನವರಿಕೆ ಮಾಡ್ಕೊಳ್ತೀವಿ. ಡಾಕ್ಟರ್ ಹತ್ರ ಸರ್ಟಿಫಿಕೇಟ್ ಸಿಕ್ಕಿಲ್ಲ ಅಂತ ಹೇಳ್ಕೊಂಡು ಕಿರಿಕಿರಿ ಮಾಡಬಾರ್ದು. ಅವರು ನಿಮಗಿಂತ ಬಿಸಿ ಇರ್ತಾರೆ. ನೋಡಿದ್ರೆ ಹಾಸ್ಪಿಟ್ಲಿಗೆ ಹೋದಾಗ ಸಾಲು ಗಟ್ಟಲೆ ನಿಂತಿರ್ತಾರೆ ಇಷ್ಟು ಪೇಷಂಟ್ಸು. ನಾವು ಹೋಗ್ತಾ ಇರ್ತೀವಿ, ಯಾವುದಾದ್ರು MLC ಇದೆಯೋ ಯಾವುದೋ ನಂತರ ಎಮರ್ಜೆನ್ಸಿ ಇದ್ದಾಗ ಅಲ್ಲಿ ಆ ಕಡೆ ಬರ್ತಾ ಇರ್ತಾರೆ, ಹೋಗ್ತಾ ಇರ್ತಾರೆ, ಡಾಕ್ಟರ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡ್ತಾ ಇರ್ತಾರೆ. ನಾವು ಏನು ಅವ್ರ ಜೊತೆ ಜೋರಾಗಿ ಹಾರಾಡಿ ಕಿರ್ಚಾಡಿ ಕೂಗಾಡಿ ಮಾಡೋಂಥದ್ದು ಏನೂ ಇಲ್ಲ. ಪೇಷನ್ಸ್ ಆಗಿ ನಾವು ಕೆಲಸವನ್ನು ಮಾಡಿದ್ರೆ ಖಂಡಿತವಾಗ್ಲೂ ಆಗುತ್ತೆ. ಯಾಕಂದರೆ ಲೈಫ್ ಸೇವಿಂಗ್ ಕೆಲಸ ಮುಖ್ಯ. ಒಂದು ಡಾಕ್ಯುಮೆಂಟೇಷನ್ನ ಬರ್ಕೊಳ್ಳೋದು ಒಂದು ಅರ್ಧ ಗಂಟೆ ಲೇಟ್ ಆದರೆ ಏನು ಸಮಸ್ಯೆ ಏನಾಗಲ್ಲ. ಈ ಥರದ ವಿಚಾರ ಇರುತ್ತೆ. ಮೂರ್ನಾಡಲ್ಲಿ ನಾನು ಲಿಮಿಟ್ಸ್, ನಾನು MRPS ಪೊಲೀಸ್ ಸ್ಟೇಷನ್ ಲಿಮಿಟ್ಸ್ ಇನ್ಸ್ಪೆಕ್ಟರ್. ದಿಸ್ ಆಲ್ಸೋ ಬಿಲಾಂಗ್ಸ್ ಟು ಮೈ ಜ್ಯೂರಿಸ್ಡಿಕ್ಷನ್. ಈ ಕಾಲೇಜ್ ಕೂಡ ಮೂರ್ನಾಡು ಅಂತ ಒಂದು ಉಪಠಾಣೆ ಇದೆ. ಅಲ್ಲೊಬ್ಬರು ಡಾಕ್ಟರ್ ಒಂದು ಕ್ಲಿನಿಕ್ ಇದೆ, ಡಾಕ್ಟರ್ ಮೊಹಮ್ಮದ್ ಅಂತ ಹೇಳ್ಕೊಂಡು. ಅಲ್ಲಿಯೂ ಕೂಡ ಅವ್ರ ಮೇಲೆ ಒಂದು ಅಸಾಲ್ಟ್ ಮಾಡಿಬಿಟ್ಟಿದ್ದ ಒಬ್ಬ ಹುಡುಗ, ಕೊಡಂಗೇರಿ ಹುಡುಗ. ಟ್ರೀಟ್ಮೆಂಟ್ ಲೇಟ್ ಮಾಡಿದ್ರು, ಸರಿ ಕೊಡಲಿಲ್ಲ ಅಂತೇಳಿ. ಆ ಟೈಮಲ್ಲೂ ಕೂಡ ನಾವು ಫಸ್ಟ್ ಟೈಮ್ ನಾನು ಈ ಆ್ಯಕ್ಟರಲ್ಲಿ ಅವನ್ನ ಬುಕ್ ಮಾಡಿ ಅರೆಸ್ಟ್ ಮಾಡಿದ್ದೆ. ನಂತರ ಕೇಸು ಅವ್ರು ಏನು ಮಾಡಿಕೊಂಡು ಗೊತ್ತಿಲ್ಲ, ಕೋರ್ಟಲ್ಲಿ ಡಿಸ್ಪೋಸಲ್ ಆಗಿದೆ. ಸೊ ನೀವು ಹೆಸಿಟೇಟ್ ಮಾಡಬಾರ್ದು. ನಿಮ್ಗೆ ಏನೋ ತೊಂದರೆ ಅಂದರೆ ಖಂಡಿತವಾಗ್ಲೂ ಮುಂದೆ ಬಂದು ಕೇಸ್ ಕೊಡಬೇಕು. ನೀವು ಕೊಡಲಿಲ್ಲ ಅಂತ ಹೇಳಿದ್ರೆ ಮತ್ತೆ ಅವರು ಅದನ್ನು ಒಂದು ಅಡ್ವಾಂಟೇಜಾಗಿ ತೊಗೊಂಡ್ಬಿಡ್ತಾರೆ, ಎಲ್ಲ ಕಡೆಯಲ್ಲೂ ಮತ್ತೆ ಅದನ್ನು ಸ್ಟಾರ್ಟ್ ಮಾಡಿಬಿಡ್ತಾರೆ. ಅದನ್ನು ಮಾಡಲಿಕ್ಕೆ ಬಿಡಬಾರ್ದು ಅಂತ ಹೇಳೋದು ನನ್ನ ಮನವಿ. ಜೊತೆಗೆ ಭಾಳಷ್ಟು ವಿದ್ಯಾರ್ಥಿಗಳು ಕೂಡ ಇದ್ದೀರಿ, ಸೀನಿಯರ್ ಡಾಕ್ಟರ್ಸ್ ಇಲ್ಲಿದ್ದಾರೆ. ಅವರು ಪ್ರೊಫೆಷನಲ್ಲಿ ಎದುರಿಸ್ತಿರುವಂತಹ ಚಾಲೆಂಜಸ್ಗಳನ್ನು ನಿಮಗೆ ಹೇಳ್ತಾರೆ. ಡಾಕ್ಯುಮೆಂಟೇಷನ್ ಇಸ್ ವೆರಿ ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್. ಇದು ಯಾವುದಕ್ಕೂ ಸಂಬಂಧಪಟ್ಟದ್ದು ಆಗಿರ್ಬೋದು. ನಮ್ಮ ಪೊಲೀಸಲ್ಲೂ ಕೂಡ ಅಷ್ಟೇ ತುಂಬ ಮಿಸ್ಟೇಕ್ ಮಾಡ್ತೀವಿ. ಆ ಮಿಸ್ಟೇಕ್ಸ್ನ ನಾವು ಕಡಿಮೆ ಮಾಡ್ಕೋಬೇಕು, ನೀವು ಖಂಡಿತವಾಗ್ಲೂ ಕಡಿಮೆ ಮಾಡ್ಕೊಳ್ಬೇಕು. ಒಬ್ಬ ಗುಡ್ ಡಾಕ್ಟರ್ ಅವ್ರಿಗೆ ಒಳ್ಳೆ ಪೇಷಂಟನ್ನು ನೋಡುವಂಥ ಒಂದು ಪೇಷಿಯನ್ಸು, ಕನ್ಸೆಂಟ್ ಜೊತೆಗೆ ಡಾಕ್ಯುಮೆಂಟೇಷನ್ ಕೂಡ ನೀವು ಚೆನ್ನಾಗಿ ಮಾಡ್ಕೊಳ್ಬೋದು. ಮಾಡ್ಕೊಳ್ಳೇಬೇಕಾಗಿರೋ ನೆಸೆಸಿಟಿ ಈಗಿದೆ. ಉತ್ತಮವಾದಂಥ ಒಂದು ಕಾರ್ಯಕ್ರಮವನ್ನು ಇವತ್ತು ನೀವು ಅರೇಂಜ್ ಮಾಡಿದ್ದೀರಿ. ಮೇಡಮ್ ಬದಲಿಗೆ ನಾನು ಬಂದಿದ್ದೀನಿ ಇನಾಗ್ರೇಷನ್ಗೆ. ಮೇ ಬಿ ಮೇಡಮ್ ಮಧ್ಯಾಹ್ನ ಮೇಲೆ ಬಂದು ತಮಗೆ ಅಡ್ರೆಸ್ ಮಾಡ್ಬೋದು ಅಂತ ನಾನು ಅಂದ್ಕೊಂಡಿದ್ದೀನಿ. ನಾಳೆ ನಮ್ಮ ಪೊಲೀಸ್ ಸಿಬ್ಬಂದಿಗಳು 30 ಜನಕ್ಕೆ ನೀವು ಕರೆದಿದ್ದೀರಿ. ಇದೊಂದು ಒಳ್ಳೆ ಇದು, ಯಾರು ಕೂಡ ಮಿಸ್ ಮಾಡಬಾರ್ದು ಅಂತ ಹೇಳ್ಕೊಂಡು ನಾನು ಇನ್ನೂ ಹೆಚ್ಚಾಗಿ ನಮ್ಮ ಸ್ಟೇಷನಿಂದ ಐಒ ಅಸಿಸ್ಟೆಂಟ್ಸ್ ಅಂತ ಹೇಳ್ತೀವಿ ನಾವು. ಇನ್ವೆಸ್ಟಿಗೇಷನ್ ಮಾಡೋದಕ್ಕೆ ಸ್ವಲ್ಪ ಗೊತ್ತಿರೋರು, ಅದೆಲ್ಲ ಗೊತ್ತಿರುವಂಥವ್ರು, ಡಾಕ್ಯುಮೆಂಟೇಷನ್ ಮಾಡೋರು, ಇದನ್ನು ಯಾವುದೇ ಕಾರಣಕ್ಕೂ ಮಿಸ್ ಮಾಡಬಾರ್ದು ಅಂತ ನಾನು ಅಂದ್ಕೊಂಡಿದ್ದೀನಿ. ನಮ್ಮ ಜಿಲ್ಲೆ ಮೂಲಕ ಕಂಟ್ರೋಲ್ ಮೂಲಕ ಕೂಡ ನಾನನ್ನು ವಿನಂತಿ ಮಾಡ್ಕೊಂಡು ಯಾರನ್ನೂ ಕೂಡ ಮಿಸ್ ಮಾಡಿದಂಗೆ ಪ್ರತಿಯೊಬ್ಬರು ನಾವು ಏನು ನಾಮಿನೇಟ್ 30 ಜನ ಮಾಡಿದ್ದೀವಿ ಬಂದು ಅದರ ಲಾಭವನ್ನು ಪಡ್ಕೊಳ್ಬೇಕು, ಆ ನಾಲೆಜನ್ನು ತಗೊಳ್ಬೇಕು ಅಂತ ಹೇಳಿ ನಾನು ಈಗಾಗಲೇ ಅವರಿಗೆ ಮಾಹಿತಿಯನ್ನು ಕೊಟ್ಟಿದ್ದೇನೆ. ಮೇಡಮ್ ಪರವಾಗಿ ಬಂದು ನಾನು ಇಲ್ಲಿ ಹಾಜರಾಗಿ ನನಗೆ ಒಂದೆರಡು ಮಾತನ್ನು ನಿಮ್ಮ ಮುಂದೆ ಶೇರ್ ಮಾಡಲಿಕ್ಕೆ ಅವಕಾಶ ಕೊಟ್ಟಿದ್ದಕ್ಕೆ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ನ ಎಲ್ಲ ವೈದ್ಯರಿಗೂ, ವೇದಿಕೆಯಲ್ಲಿರುವಂಥ ಎಲ್ಲ ವೈದ್ಯರಿಗೂ, ಇಲ್ಲಿ ಕುಳಿತಿರುವಂಥ ಎಲ್ಲ ಡಾಕ್ಟರ್ಸ್ಗೂ, ವಿದ್ಯಾರ್ಥಿಗಳಿಗೂ ವಂದನೆಯನ್ನು ಸಲ್ಲಿಸಿ ನನ್ನ ಮಾತನ್ನು ಮುಗಿಸ್ತೀನಿ.
Now may I request our organizing joint secretary Dr. Purushottam DR, Professor and HOD, Department of Pediatrics, to kindly speak a few words.
Thank you for giving an opportunity to speak a few words. And sir has introduced me as a mastermind. Not a mastermind. Sir is a master, I am the mind. I am one of the mind. So we have equally contributed for organizing this conference. So first talk was from Dr. Bopada. He spoke about documentation in medical practice. I just wanted to share few words as an NQS assessor, National Quality Assurance Standards Assessors. And Dr. Anand is also there. He is also a state level NQS assessor. So with respect to documentation, one more important point I just wanted to convey you is there is something called as verbal order. So most of the times after we're doing the rounds and all those things, we just go to duty rooms, or we go to OPDs, or we go to some for lunch break and all those things. During that time, if you happen to give any of the advices on an emergency basis, it's better we write down all those verbal orders in a so-called dedicated verbal order book. This is very, very important. And there is one concept called as closed loop communication. Closed loop communication in the sense whatever the order is given, that should be repeated back by the person who is listening. For example, injection ceftriaxone 1.5 grams, it should be given intravenous, stat dose should be given. The other person who is listening should repeat the same. Sir, is it injection ceftriaxone 1.5 grams intravenous should be given? Then the person who is saying he is supposed to say yes or no. If there is any wrong things is been uttered, you are supposed to correct then and there itself. So this is very, very important, and they are supposed to document these things in the verbal order book. Because at times, since it's a medical legal issues, for example, you say a postgraduate, some mishappening happened with respect to the particular patients. The consultant says, I called you, informed you at 9:30 p.m. Regarding these things, and he will just say. And the postgraduate or the nursing officer says, no sir, you have never told me these things, and she will say. So how to escape from these situations? So as everyone says, documentation is important. You please document that thing in a verbal order book. After the duty consultants come back from his come back to hospital, you are supposed to put a signature in the verbal order book saying that whatever he has told has been is corrected. And this is very, very important. This will definitely kind of prevent us from having the communication gaps. This is one point. And second, closed loop communications, this should be done, and probably in our all the basic life support training and emergency care life support training which has been endorsed by RHHS, we will be teaching our students with respect to these communications. And also ISBA, there is something called when you are referring the patient from one hospital to other hospitals, you will be kind of identifies and you will tell everything of the patient, you will tell to the referring patients and all those recommendations, all those things, that should be informed. And third point is, so for example, if the patient is in step down ward or patient is in pediatric ward, or some medicine ward, if the patient is having some acute event, when you are referring the patient from that particular ward to ICUs or HDUs or something, that the referring persons, the duty nursing officer or duty PG or duty pediatrician or any consultant should make a note of what was the point, before referring the patient, what was the vitals, whether hemodynamic is stable, all those vitals should be properly documented, and then it should be referred to the referring place. You are writing legibly with the date, time and all those things with the legible name and signature. This is very, very important, because with these things we will come to know exactly where exactly the problem has happened and what was the time, what was the time gap and all those things, and we can later on we can do the verbal autopsies and we can come to proper diagnosis and all those things. So these are some of the things as a doctors, as a professionals. In fact, not only doctors, each and every person's documentation is very, very important. So that will kind of save our skin. And with this, with our recent, we will be having, we have become very much smart. We are using smartphones. So we will not be using which person is having mobile deployment. Clandestinely, we will be shooting whatever the audio messages or video messages. And audio visual consent is also very, very important. So this is one I just wanted to communicate to you people. So, and probably rest of the talks, with respect to all those medical issues will be spoken by the learned speakers. So once again, I thank the organizing team for giving me an opportunity.
CMA ಮಾಡ್ತಿದ್ದಾರೆ. ಸೊ ಇದರ ಬಗ್ಗೆ ಡಾಕ್ಯುಮೆಂಟೇಷನ್ ಬಗ್ಗೆ ತುಂಬ ಮಾತಾಡ್ತಾರೆ. ಸೊ ನಾನು ಏನು ಹೇಳೋದಂದರೆ ನಮ್ಮ ಪ್ರೆಸೆಂಟ್ ಜನರೇಷನ್ ಸ್ಟೂಡೆಂಟ್ಸ್, ಸೊ ಸಿನ್ಸ್ ಐ ಆಮ್ ಫಸ್ಟ್ ಇಯರ್, encountering first year students, so day by day ನಮ್ಮ ಡೈರೆಕ್ಟ್ ಹೇಳಿದಾಗೆ they are more into the mobile, they are more tech savvy, other generation X, Z, all those things, they are more into that mobile. ಅವ್ರು ಸ್ವಲ್ಪ patience ಕಡಿಮೆ, so they want everything in a short time and they have to finish everything in a short duration, everything. So repetition ಮಾಡಿದರೆ ಅವರಿಗೆ ಬೋರ್ ಆಗುತ್ತೆ, ಅದೆಲ್ಲ ಇದೆ. ಸೊ ಇಂಥ ಸ್ಟೂಡೆಂಟ್ಸ್ಗಳು ಅಂದರೆ ವಿ ಹ್ಯಾವ್ ಟು ಟ್ರೈನ್ ದೆಮ್ ಎ ಲಾಟ್, ಆ್ಯಂಡ್ ಐ ಹೋಪ್ ಫಾರೆನ್ಸಿಕ್ ಮೆಡಿಸಿನ್ ಅವ್ರು ಅಂದರೆ ಸಪ್ರೇಟ್ ಕ್ಲಾಸಸ್ ಇದ್ರ ಬಗ್ಗೆ, ಕಾನೂನು ಆರೋಗ್ಯ ಬಗ್ಗೆ ಕ್ಲಾಸಸ್ ಇರ್ಬೋದು ಅಂದ್ಕೊಂಡಿದ್ದೀನಿ ಅವರ ಡಿಪಾರ್ಟ್ಮೆಂಟಲ್ಲಿ. ಆ್ಯಂಡ್ ಆಲ್ಸೋ ವೆನ್ ದೆ ಕಮ್ ಫಾರ್ ದ ಇಂಟರ್ನ್ಶಿಪ್, ಅವರನ್ನು ಒಂದು ಪ್ರತಿ ಸಲ ನಾವು ಅವರಿಗೆ ಒಂದು ಓರಿಯೆಂಟೇಷನ್ ಡೇ ಅಂತ ಮಾಡ್ತೀವಿ. ಸೊ ಡ್ಯೂರಿಂಗ್ ದಟ್ ಪೀರಿಯಡ್ ಐ ಥಿಂಕ್ ಇದನ್ನು ಜಾಸ್ತಿ ಸ್ಟ್ರೆಸ್ ಮಾಡಬೇಕು, ಪರ್ಟಿಕ್ಯುಲರ್ಲಿ ಡಿಪಾರ್ಟ್ಮೆಂಟ್, ಕ್ಲಿನಿಕಲ್ ಸೈಡ್ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಅವರು ದೇ ನೀಡ್ ಟು ಸ್ಟ್ರೆಸ್ ಆನ್ ದೀಸ್ ಕೈಂಡ್ ಆಫ್ situations so that during their internship or casualty medicine and casualty postings, so they can do the documentation properly. So obviously emergency time bandaga now we will have to give more stress on the focus on the patients, but by the meantime so documentation is must anta ella helidare. ಸೊ ಇಷ್ಟು ಹೇಳಿ ಇವತ್ತಿನ ಕಾನ್ಫರೆನ್ಸಿಗೆ ಒಳ್ಳೆಯದಾಗಲಿ ಅಂತ ಹೇಳಿ ನಾನು ಮಾರ್ಗದರ್ಶಿಸಿದ್ದೆ.
ಡಾಕ್ಟರ್ ಹರ್ಷ ಜಿ.ವಿ., ಶಿವಕೃಪಾ ಮಲ್ಟಿ ಸ್ಪೆಷಾಲಿಟಿ ಹಾಸ್ಪಿಟಲ್, ವಿಜಯನಗರ್.
Sir is general surgeon. He has finished his fellowship in minimal access surgery and fellowship in laparoscopy surgery. Sir has also completed LLB. Sir is currently working as a MD in Shivagrupa Medical Multi-Specialty Hospital and RC in Arpnadi. Sir, please.
The tubes, I work through the laparoscopes, and I have got my own hospital. We operate all complex cases. We face complex issues, and you know, I am a general surgeon settled at a Taluka headquarter, where I attend so many kinds of cases, including obstetric cases, including urology cases, and also general medicine cases, surgical cases. I myself from Bangalore Medical College in esteemed college, you might be knowing, and the training which we had those days, I can do so many procedures, but still my limitation was what, where and how I should stop myself. And also, before I start, good morning, Shubhodaya, respected chairpersons, esteemed faculty and dear colleagues, and also the delegates. I should not compromise the highest profession like another suffering should not compromise another's suffering. This single thought unites our disciplines. Medicine is karma, duty in action, ethics is dharma, the moral compass, law is lokasangra, the protection of social order, and humanity is spirit that binds them all. Historically, KODAGU, how it was related to Vijayanagara, they were the military backbone to Vijayanagara. These are all very proud people who are very strong warriors. So, in this land, you have given me this opportunity. I am very thankful for the people who invited us. I will start my presentation. Things are gradually rising. So those who are in first year MBBS right now, or those who are in first year BDS or BAMS, definitely by the time they come for a consultant post, once they finish, they will have quite large number of litigations. Awareness is building. That doesn't mean that whatever you do is right, and taken granted attitude of doctor should change. So I have put intentionally the Indian Medical Association, and there is law, and also there is, I am from the Association of Surgeons of India, ASI. Why association is important, I just want to put a few words here. Associations are important in spite of you being correct. Sometimes atrocities will be put on you. Maybe direct public atrocities, or maybe from the official atrocities, or maybe from the courts. If the law is written wrongly, if the law is written in a very draconian manner, how you will come out of the draconianness of the act is only with the help of associations. I pass one message here. Maybe you belong to so many. I have been to this place for more than 5 to 6 times. This time it was different. Every time it is different. It is a very beautiful place. Please do come to Hampi, which is our place, which is Vijayanagara, which is more beautiful, still more beautiful and more rich, full of history, richer than even Rome. You visit this place with a second dimension, one more dimension. Come and see my place, which is more. We all passed our pre-university with the distinction, good marks, then went into medical schools, thought we are pure science students, thinking that we are researchers, we do some rockets, planes, or we go directly inside the body and change the cell structure, we think we can even cut the DNA. That's all research level which is done in microbiology field, or which is done in BSc kind of field. We don't do. We are application science students. So we are going to apply all the knowledge of science onto the human beings. Human beings where, see, there is humanity, one, social science is there, one, and ethics, of course, which is written in Bhagavad Gita itself. So medical education system is incomplete in India. Why? Because once you come out as a registered medical doctor, you will land up directly into a casualty service practices, or suddenly you may land up into a clinical practice where you do not know all these things, where I am a doctor, I am treating the patient, his disease, but not only his disease, you should know his culture, you should know his sociology, you should know his financial background. Without knowing all these things, and we are directly taught, we are taught in the colleges, the manner is more of science, less of sociology. And sociology is less taught. What happens is, you are a very perfect student, a rank student, gold medalist. You have gone outside, but you encounter troubles in handling the patient, especially in the way of conversation, the way you tell. Recently, we had an obstetrician got appointed to my hospital. What happens is, she saw one IUD case. She did an ultrasound, it was an IUD. What she told, she suddenly told the patient as well as the attenders, Magu Satogil. Okay. Then what happened was, because I am practicing there since 25 years, I could able to manage the situation. But what happened was, they bought some 10-15 people, they started making galata. We are regularly coming ANC, already 7th month, baby is dead inside. All this. See, the way how I should have told is, I could have taken one more scan from one more consultant. Then I would have sat with them, talked to them carefully, not to disclose this directly to the patient. first disclosed to the elders of the family and would have told limitations, this can happen, such things have happened. So the way you disclose, the way your face is also very, very important. Same thing, she's a rank student. She came out of the college just 2 years. She got appointed to my hospital, and where she did an ultrasound and directly told it's an IUD. So such things, they will excite the patient. Suddenly it will bring all the emotions to the patient. Such disclosures should be done carefully where it should be taught. It should be taught in the colleges only. So it is not taught in the college. Even after post-graduation, she did the mistake. In spite, she is correct, but she is not correct. So I myself, already a kind introduction has been done. See, broad dead definition, all of you must be knowing, already you might have read. I don't want to dig into those things. I will dig into the social aspects and law aspects. No sense of life on arrival, death is confirmed, attempt to resuscitation avoided. If you do CPR, it is not broad dead. If you have brought a case into the casualty and you are doing CPR, you have written on the document, that means it is not broad dead. Okay. So broad dead, first confirm the death. Before doing anything, you should say it is dead. I will not do anything to that. It is dead. Who is the person who can tell someone is dead? He is only the doctor, who is a registered medical practitioner, RMP with a KMC registration. No one else. If you are not registered in Karnataka, you cannot tell this. If you are not registered in Maharashtra, you can't tell this. Okay, you have to be a registered medical practitioner, should be able to seal, put a sign, put a seal, sign your KMC number, then only you are allowed to tell this word, broad dead. And broad dead includes no sense of life and attempt resuscitation avoided, not done, totally not done. If you have done also, if you document it, it is not broad dead. If you have done also, if you don't document it, okay, then it is broad dead, a kind. Do not issue medical certificate of cause of death. Form 4 or Form 4A. All of you know Form 4 and Form 4A. I will not go into that. My topic is very much limited and time is also limited. So, never issue MCCD, cardiac arrest. Patient, okay, patient brought dead, cardiac arrest, death certificate is given to the patient address. It is wrong, totally wrong. You should never do that. What you should do? It is an MLC. First you document everything in proper register and also inform police. How to inform? I am going to come in the next slide, okay? Section 174 CRPC. I will give you the corresponding section of BNSS later. All suspicious deaths, police inquest is mandatory. Next, in such cases, broad dead cases, it is PM is mandatory. Whether patient has something and all, they will refuse doing PM, police will tell, don't give inquest, all. That is all secondary. I am talking pure thing what should be done. Later you can ask me questions what I should do, then I will tell you what you should do. They will come and ask you, a broad dead patient is brought onto your clinic or to the hospital. They want to say, sir, please don't document, don't inform police. What to do? You have to ask me this question, I will answer. But what should be done, I am showing in the slide. Confirm the death, who has to do? A registered medical practitioner can do confirmation of the death. It's very simple. Not to dig too much into, sir, patient may be in a kind of a state where you can't completely say whether it is dead or not. I am a medical student, I know, like brain death has to be confirmed, such test has to be done, some kind of test has to be done. Don't go into that. It's a very clinical decision. Pulse, respiratory rate, BP, and the deep reflexes, all those are not there. Broad dead is, and one flat ECG, if you can, you have ECG machine is available. It's a very simple legal definition, broad dead. You have to follow that broad dead definition. Don't go too deep into the neurology. Okay? Failure to inform police what is going to happen. Okay, broad dead case is there at your clinic or in the hospital, and you have seen police intimation, or MLC, section 39, 174, 176 CRPC. I think the session is also being chaired by the police department, forensic people, and it is more important not for forensic people. It's not for police, it is for clinicians who are sitting here. Okay, police will come after this, after whatever happens, the trouble, they will come. Okay, they come and sit here to see But whether their role is there before it happens. No, there is no role. So it is for whom it is very important. It is very, very important for the active clinician who really works in the field. Okay, I am a person, I am not under cover of government, I am not under cover of any health mafia. I am alone in the field. I have to cover myself. Okay, such kind of personalities who are sitting here, wants to practice outside, should know all these things in proper. Otherwise you are covered. Don't worry too much. You are covered. You are already, there is a Godfather. I have seen a Godfather movie. But one day you will definitely get hit, okay? But you should know, those who wants to practice actively in the field should know all these things. So, once you do not inform, as per CRPC, section 39, you should inform. Then police will come as per CRPC 174 or magistrate will come as per CRPC 176. Why CRPC, why 39, why 74, why 76? It is all written. Our Indian constitution is a written constitution. So whatever is procedures done in law is purely, completely written. Whatever is written and is, are, they, them, 200 or otherwise 2 years of imprisonment, arrest and fine. All these things are written. When they are written, they will be executed. So when they are not written, they are not executed. 106 BNS you might have read already. Previously we had medical negligence, we had fine or imprisonment. Like accused list, in that last person will be the doctor, and he will be testified in the witness box as an accused unless magistrate gives a pardon and put you into the witness list. So ignorance has no excuse. You can say, sir, I don't know, I didn't know. They have put fine of 2,000 rupees. There are cases I can show you. So even KMC registration soon after MBBS, nowadays nobody is practicing post MBBS. Most of them will go for post-graduation training. Post-graduation institutes also won't teach all these things. They come out as a PG. They do the mistake. My first mistake, first time I have done. First time I have cut the throat, patient died. So even first time, if you make a mistake, the CRPC and IPC is applied. Even judges are very soft towards doctors. Police are also very cooperative towards doctors. But the law which is written, and already a party is there looking at you. There is an advocate from opposite side looking at you, looking at your mistakes, will not leave you. Even police wants to leave you, but the opposite advocate will not leave you. Even magistrate wants to help you, but opposite advocate will not leave you. Because that is what India, that is what the beauty of India, isn't it? See, there is a discussion in the courtroom. Opposite advocate will always ask the question. So it's actually a good thing. Law is very good for common people and professionals like us. When law is, why this is written, this should not have been written, we would have been happy. No. It is written, that is why it is easy. That is why India is progressing. It should be written, it should be stringent, it should be written clearly. So we have to be law-abiding citizens. Why? Because for our goodness. By the law, law is made by us, for us. So law is important for professionals and common man. It is not important for people who are very rich. Okay. So these things we should know. So section 39, parallel is 39 in BNSS recently passed, duty to inform cognitive offences. Section 174 and Section 194 parallel, BNSS is a police inquest, and 176 CRPC, 196 parallel is magistrate inquiry. You know magistrate inquiry, all of you might have read in your forensic books when magistrate inquiry is done. Simple thing, but the only thing is it is not been stressed in forensic classes. Why? Because they don't practice. Forensic people, they don't see the patients. They don't face the death. They will be sitting in the room, as you all think. Okay, they are very greedy. They do not come for help when there is a problem with other colleagues. They always try to snatch cases. They also, it's a means to make money, to become famous, make money, have so we are in a greed. So when you are in a greed, you may some or other time you may get into the trap of law.
So you have to overcome the greed. Kama, Krodha, Moha, Lobha, Mada, Matsaragalanu Saha, Miri, Solpa Mundu ಹೋಗಬೇಕು ಈ profession. Why? Because this profession is not just for bread and money. Okay, this is not bread and butter, not for hand and mouth. This is actually, we are all blessed to touch other human being and heal him. Money will follow. Service first, money will follow. So if we follow this kind of ethics, we follow this kind of things in our life, then usually nothing will happen. But in spite of that, awareness of law, there is no, ignorance has no excuse. You can't say that I don't know. So, intentional concealment means, I told doctors sometimes they try to conceal some kind of evidence and try to help someone, so law will not spare them. Section 39, there is a case law. State of Karnataka versus P. Raj, there are so many cases are there. Omission to inform police is punishable, which is in the Karnataka High Court. So Article 29, treatment cannot delay for CRPC 39. This is Paramananda Katara versus Union of India 1989. All of you should read this Paramananda Katara case. Why? Because Article 29. Why article? Sir, you just now told BNSS and now you are telling article. See, law is also similarly classified like anatomy, physiology, biochemistry. Like that only it is classified. So it has got different subjects. There are more than 35 subjects which you are compulsorily you have to read and pass. Then only you will come to understand. You will have understanding of what law is, how law works, what is international law, what is national law, what is human ethics, what is humanity, all those things. There are so many subjects. Actually should be integrated with medicine because we deal with human beings. We do not deal with machines. We do not deal with, for example, channels, or we do not deal with bandwidth or even mobile phones or such things. No, we directly deal with human beings. Directly we interact with all social issues. Okay, so Article 21, there are so many articles in Constitution of India. Among them, most important is Article 21, right to life. So when patient comes there, treatment cannot be delayed for CRPC 39. Here, one doctor, a private doctor, actually, Paramanand Katari is an activist. He is not the person who got suffered. One person died, and that fellow was brought to a private hospital. They refused and they told to take it to government hospital for emergency purpose. There he died. He was badly hit, there he died. There was a delay. Delay of 1 minute itself is considered as delay. Whether he would have saved or not saved, okay, he is very badly hit and he was very bad. He was brought to my clinic, even otherwise also he would have died. He was brought to my other hospital, before transport only he would have died. All these explanations nobody will accept. What they will accept is, okay, he was brought to your clinic, did you do the life-saving procedures or not? If you have not done life-saving procedure itself is criminal negligence. It's not civil negligence, it's a criminal negligence. For that you may be sorry. Nobody will spare you. When the emergency comes to your clinic, it is your duty to do that. A nephrologist has to conduct a delivery. A cardiologist has to suture a wound. Okay, you can't say that. I am a white coat fellow, I have got a white collar fellow. No, you can't do that, okay? That is the meaning of right to life. Next is, I think 176 through CRPC 39, you know, that is one more case is Ram Prasad versus State of UP. Delay information accepted in article. So there was a delay of more than 2 days, but still court has accepted because of they have kept the patient in the hospital while treating, but they delayed. So delay acceptable. This is one of the exception I am telling, but this is not going to protect us unless in MLC will attract this section 6 months to 2 years of imprisonment. See, when IPC 202, when it is attracted is mens rea is proved. For example, you have intentionally concealed some medical legal case for the benefit of a patient or for your benefit. If that is proved, then section IPC 202 is attracted, where imprisonment will definitely come into picture. So that should not happen. Once in prison, your degree is gone. 1 day imprisonment also, degree is gone. Yes. Death of a married woman within 7 years. Still India is not like gender equal. Okay?
Destin book. It's because chain of record it is. You can't send one paper. If you send one paper, actually court will not accept it. You have to send a book. In that book, they have to seal and put a signature and go. Otherwise, police comes also, they will put a seal and sign and take the letter to a letter and a book. So these are all very important kinds of maintaining documents. Keep the MLC documents actually under lock and key. IPC 170 failure to produce the documents. Sometimes you have done everything but hospitals and government hospital. I was working in a government hospital. I was there in the government setup for 10 years. They will not keep the documents properly. So you have to make some arrangements, some kind of arrangement in different talukas, different districts, I don't know. MLCs done, seen by you, should be kept under lock and key under yourself. You have to maintain them. Whenever you go to other place after transfer, you can't take them, no? It's not possible to take them from there to your place, but those things should be properly kept and saved in the record. We don't know when. There is no expiry time for MLCs. It can be revoked even after hundreds of years. Whereas for other cases, 3 years is the expiry time as per the NMC Act. 3 years, if you keep the documents, that should be okay. But whereas if it is an MLC, there is no expiry time. Court can revoke, open any time. You can see 1886 cases are getting discussed in the court even now, 2020. Isn't it? 1886 cases. Who is a destitute? There is no identity, no address, no bystander, alive or dead. Is a destitute. So destitute, no identity, no address, no bystander, alive or dead. Whether he is a citizen of India or not is not material, not very much material for you. Whether he is an Indian citizen or not a citizen, still Article 21 comes into picture. So alive, treat as per Article 21 is a fundamental right. Whether he pays money or not, still you have to treat. Your MBBS doctor, patient comes with MI, I am not a cardiologist, I can't treat. You can't tell this. You should know what you should do as an MBBS doctor. You should know what you should do as a gynecologist if an MI comes. So it's not a labor case. How can I treat a renal failure case, sir? You can't tell that. What should be done as an emergency? You do it. Then later on stabilize the patient, then shift the patient to appropriate person who can treat it or an institute which can handle it. But whether success is not actually Jacob Matthew case is a landmark case. Success is not quantified. Success is not really important. But what is important is whether you properly followed the procedure of standard of care. Standard of care, what should have been done by in the same place, if a doctor of same qualification stands there, what should have been done is what is expected by the court. It's not the success. So, all of us should understand a case of any kind. If it's an emergency, Article 21 is attracted and we have to treat. Maybe whatever may be our specialty, that's why we are trained in that manner. So documentation, just the previous presenter was really very much putting this one is importance on not written is not done. Jo nahi likha hai, wo nahi kiya hai. This is what very clear in the court. Our constitution is written constitution. Whatever is not in the constitution, they cannot enforce on us. Similarly, whatever not written in your books or your case sheets, you can't say that I did it and I forgot to write. Nobody will accept it. So documentation, especially for a destitute, you have to document the important things, and it is an MLC, and police intimation is a must. If it is dead, again it's an MLC, not dead, again it's an MLC. See, for other patient who is not a destitute, not dead, it's not an MLC, unless it's an MLC case. Here, it is, if it is non-MLC or whatever, even fever case also, a destitute is an MLC. That is the meaning of it. So, you will not be issuing medical certificate of cause of death in these cases. Postmortem is a must in a destitute. And both are police cases. See, alive, destitute, alive, even police will come into picture. Destitute, dead, police will come into picture. I am just repeating it. Destitute, treat. Alive means you treat him. Death means disposal of body only after police authorization and postmortem. Postmortem is a mandatory thing here.
Always MLC, time, date, then record age, sex, height, build, class, all these things you know. As a medical student, you are all sharp people. We are less than 0.1% of the whole mass, Indian mass. Still, we know all these things, we have to do these things. Scars, tattoos, deformities, photographs. So, suspicious death, they are superposing terminologies. Sudden, unexpected, unnatural, unexplained is suspicious. You have to remember these words. Broad death, RTA, poisoning, burns, hanging, hospital death within 24 hours of admission. This is, I think, this one is important, I feel. Death within 24 hours of admission, especially for emergency departments. Unexpected death in hospital, medical negligence cases, deaths due to while treating, or some medical negligence allegations, custodial deaths, death of a woman, 7-year marriage, you know. They are all suspicious deaths. So, any suspicious death, avoid giving the body without police intimation, permission. Avoid MCCD. Sir, they are taking away the body, what shall I do? You have to ask this question. This is what is theory. It is MLC, documentation, proper documentation is a must. How to document, an MBBS doctor knows. Police intimation, I already told, section 39, you have to do this, otherwise you will get trouble under IPC 176. You can't give medical certificate of cause of death. MCCD is medical certificate. You can't give. PM is a must. Section 174 and 176 CRPC comes into picture. You have to read those things. Appropriate IPC and BNS will be applied. According to the MLC, it belongs to. A female died before 7 years. IPC sections are different. Crimes against women. There is a list of crimes against women. So death certificate, medical certificate cause of death, and official death certificate. There are two types of death certificates here. You should understand, you may think that there are death certificate means I can give death certificate. No, doctor cannot. Is only cause of death certificate it is. Medical certificate of cause of death, that's it. Official death certificate is different. See, institutional deaths, form 4 is given to give the cause of death. Non-institutional 4A is given for the cause of death. Police report, police also conduct some kind of inquiries, whatever, when doctors are not involved. Post-mortem is done, then form 2 will be submitted. They will give form 2. Don't issue MCCD in broad death cases. Never. Unnatural MLC deaths without attending the case. Sometimes doctors they give, there was a case recently without attending the case they had given, so I just mentioned it. So certificate only natural deaths, doctor issues MCCD, cause of death, not mode of death. We give cause of death, we don't give mode of death. And we give only natural deaths. Natural death, what is natural death? You have to check, you have to search and read what is natural death. Police magistrate in MLC cases issues mode of death. Police will issue the mode of death, how he died. 174, 176, based on, again, mode of death. They give the mode of death there, and we give mode of death in natural deaths. Whereas in unnatural deaths, police and magistrate will give the mode of death. Registrars of birth and death issues the official death certificate. That is proof of death. You just see mode of death and proof of death. There are two different things. We don't give mode of death. We are not investigating officers. And we don't give proof of death. We are not the authority. I am not the registrar. So mistakes, avoid writing such words in medical documents. You can't write homicide, suicide, accident, dowry death. This is mode of death which is written by police or a magistrate or the court. Court has to decide it, and you can't decide this. So you can just write why patient has come there. So history of so-and-so hanging, such words you can, history of hanging, history of stab. Like that you have to reframe your sentence. False certificate, if you issue false certificate, it can attract some high profile cases, it can attract, say, IPC 197, 7 years of imprisonment. And false evidence 191 to 193, issuing death certificate in broad death, changing the cause of death. Sometimes you may try to fabricate the document for the benefit of either your relative or a friend by the pressure of an MLA. You will be stuck for 7 years in the jail. This is Ugra Nursing. You come to Hampi,
visit. Maybe many of you have come. Maybe this actually is a we had a golden age, golden period. Whole South India was ruled by us, and sometimes you can feel the Rome, original Rome. You may feel the difference, but this is a wonderful place. And take-home message is never hesitate to make an MLC. Be cautious, never assume. Emotional doctor. See, Constitution is a written thing. Whatever is written, you have to follow. Whatever written on your document, you have to give as a statistics. See, a small suspicion among the team of emergency physicians cannot
be documented, and it is not about what is not being done. So, when you see a particular hospital where the MRD is empowered, where he has direct access to the medical superintendent and the HODs of the various departments, you can see the change in the files of that hospital, like very beautifully explained by the pediatrics HOD here. The transfer note, the receiving note of when a patient goes from one place to another, you can make out in a particular hospital's file whether that transfer note is there and the receiving note is there, and that hospital.
Yeah, with the permission of the person. When patient comes, we'll see pulse, blood pressure, then pupils, or any electric activity for the heart, or then flat ECG. That is a documentation we make, and pupils dilated. Then we declare, we take a second opinion also, we declare death in our emergency room in our hospital. This is the way we are following the protocol, but if you want, you can add anything for that.
I agree with the...
Both are cold, I tell you, both are cold, both are flat.
Yeah.
What will you do?
I mean, this is illuminated by you.
The angle of law is totally different.
Yeah.
So we have to pass the message to these people very clear. See, law is written clear, crystal clear. You can't say by looking at the patient's size, age, you can't deny the resuscitation. I told you that is why undercover you do whatever you want. Or died after admission, there is no much difference. But when the statistics comes on the board, then you will feel bad, isn't it? See, my emergency department, so many patients are brought alive and they died. So in other emergency department, University of Massachusetts, there is no broad death, there is no death after admission. This is what they do, NY, New York people. So this is what not done in India. So we are much more better than all other countries. But still, we don't know the documentation properly. Otherwise, we know documentation, we neglect documentation. We are more trainee, but a little bit lazy. So I want to put a legal angle for this thing. It's a very tricky thing.
Was found having broad death. He gave CPR. It was our own boy. In fact, broad death did CPR, folded his legs. I think you can remember the JGM specialty because the demography. We folded his legs. It was there, and I kept it in the last room. Right? I think it's the same emergency room. It was there, last room. And since he is a hospital employee, almost everybody were coming and seeing him. Manja. Okay. So I still remember people used to come and try manja, butol. Did everything 4:30, 5:30. The body was taken home. 9:30. My senior Dr. Kalesh Ramnur called me. Gopana, did you declare that case? I said yes. Other CG hospital intubate madidare. He's put in ventilator. Hell broke loose. Patient was declared by me, was flat lying, folded his legs, he was lying in the emergency room triage area for 3 hours. Right by 9:30 the call comes that patient is alive, he has pulse, he has been ventilated. The body went cold. Okay, we don't know what to do. Then my guide was there, Dr. Neswami. He told me, no, don't worry. It is a syndrome called as Lazarus syndrome. Have you heard of it? No. It is not suspended animation. There is a difference between suspended animation and Lazarus syndrome. Lazarus syndrome, have you heard of it? Any Christians here? Any Christians? There is a saint by name Saint Lazarus who lived in the times of Jesus Christ. He is the person whom Jesus gave life. Okay. So, some of the miracles attributed to Jesus Christ, one is the resurrection of Lazarus. Raghavendra Swami resurrected 5 or 6 people, but still, the name after Lazarus is, Saint Lazarus is this syndrome called Lazarus syndrome, where a person who has been declared dead by CPR and by documentation, kicks back to life later. It is called a Lazarus syndrome. It happened in first year of my PG. Only 3 or 4 cases are documented. Nobody told me to present this case for publicity. It would have been a very good case. 3 or 4 cases are reported. Suspended animation is completely different. There it comes in forensic science. Where a flick, the ready, forensic book ready, it says flickers of life is present in the medulla oblongata. I think that students can correlate, right? This is my fact and memory. That reactivates. There is life, there is pulse activity, but it is unmeasurable. That is suspended animation. That happens in cold injury, drowning, and electrocution. But this is dead. And it actually happened in our own family, long before I was born. My mother, some distant grandmother, who was died in Kuri culture, they bring the body and put him to the hall. After that she got up and she lived up to 111, 112 years. But it is not Lazarus, because it was not medically declared blood dead. You have it was suspended animation. This is one. You have to have an idea about this. Very rare. If you get such case, you are lucky. Not lucky. This is one case. I was lucky. Okay. And very recurring a blood dead case, it is headache. Okay. When cases have come back to the emergency telling, kai shaking. Okay. Especially if you are given CPR, given adrenaline, little bit of flickers will be there. And they will come back to the...
This is very much in units.
Yes.
Neonatal deaths.
Okay. At one point of time we started telling the patient has died, okay. Another one case is, it happened in my friend's hospital. A 80-year-old Ajja was brought to emergency in a private hospital. The CMO of that hospital, very senior retired government doctor who was working as a CMO, means their CMO is only for registering. He said brought it, sent home. And body was cremated. 2 weeks back, another son of the person who was abroad, he came, he put a case that it was a murder. Okay, the case was exhumed and it was proved to be a murder. The doctor is now facing charges. Be careful with declaring deaths as natural, even if it is a...
You declare it, don't worry, and document it. If you really in a doubt, one more doctor, you make him sign there. 2 of you sign means court cannot say no. Such things, if he wakes up, I am not against any faith. I neither follow any faith. If he wakes up, you don't give the credits to Jesus Christ or Raghavendra or even Paigambar. So that is a science. Call one of your doctor to the box and give him the evidence that what an emergency doctor told, this can happen, and come out of the problem. That's it.
The problem is if you come out of the problem.
Promoting access to justice for underprivileged in the district KODAGU. Welcome you again, ma'am. You can start.
ನ್ಯಾಯಾಲಯಗಳಿಗೂ ವೈದ್ಯರಿಗೂ ಇರುವಂತಹ ಕಾನೂನಿನ ಪ್ರಕಾರ ಇರುವಂತಹ ಸಂಬಂಧದ ಬಗ್ಗೆ ತಿಳಿಸಿಕೊಡಲಿದ್ದೇನೆ. ಈಗಾಗಲೇ ಡಾಕ್ಟರ್ ಹರ್ಷ ರವರು ನಾನು ಹೇಳಬೇಕಾದಂಥ ಹಲವು ವಿಷಯಗಳನ್ನು ತುಂಬ ಚೆನ್ನಾಗಿ ಹೇಳಿದ್ದಾರೆ. ಗೌರವಾನ್ವಿತ KPB ವಕೀಲರೇ, ನಾನು ಹೇಳುವಂತಹ ಸಾಕಷ್ಟು ವಿಚಾರಗಳು ಬಹುಶಃ ನಮ್ಮ ಮಾನ್ಯ ವಕೀಲರಾದ KPB ಅವರಿಗೆ ಒಂದು ಲಿಂಕ್ ಆಗತ್ತೆ ಅಂತೇಳಿ ನಾನು ಭಾವಿಸ್ತೇನೆ. ಯಾಕೆಂದರೆ ಅಭಿಪ್ರಾಯಗಳು, ಅವರು ಕಂಡಂತಹ ಕೆಲವು ವಿಸ್ಮಯಗಳು, ಅದನ್ನು ಕೂಡ ಹೇಳಿ ನಾನು ಮಾತನಾಡಲಿಕ್ಕೆ ಇಷ್ಟಪಡ್ತೇನೆ. ಒಂದು ಬುಕ್ಕಲ್ಲಿ ಹೇಳಿದಂತಹ ಕಥೆಯನ್ನು ಕೂಡ ನಾನು ಹೇಳ್ತೇನೆ. ಬಹುಶಃ KPB ಅವರಿಗೆ ಅದು ಗೊತ್ತಿದೆ ಅಂತೇಳಿ ಭಾವಿಸ್ತೇನೆ. ಯಾಕೆಂತ ಹೇಳಿದರೆ ಅವರೇ ಅದಕ್ಕೆ ಮುನ್ನುಡಿಯನ್ನು ಬರೆದಿದ್ದಾರೆ. ಮೊದಲಿಗೆ ಇಲ್ಲಿರುವಂತಹ ಯುವ ವೈದ್ಯರಿಗೆ ಅನುಕೂಲವಾಗಲಿ ಅಂತ ಹೇಳಿ ಫ್ರಮ್ ದ ಇನಿಸಿಯೇಷನ್ ಹೇಳ್ತೀನಿ. ಕೋರ್ಟ್ ಆಫ್ ಲಾ ಅಂತ ಹೇಳಿದರೆ ಏನು ಅನ್ನುವ ಬಗ್ಗೆ ಕೂಡ ಸ್ವಲ್ಪ ಹೇಳಿ ನಂತರ ಮುಖ್ಯ ವಿಷಯದ ಬಗ್ಗೆ ಬರ್ತೇನೆ. ಪೊಲೀಸ್ ಆಫೀಸರ್ ಕ್ಯಾನ್ ಅರೆಸ್ಟ್ ಎ ಪರ್ಸನ್ without warrant from the magistrate. For example, murder, rape, robbery, etc. So in such cases, ಈ ಕ್ರಿಮಿನಲ್ ಕೇಸಸ್ಗೆ ಸಂಬಂಧಪಟ್ಟಂಗೆ it is a notice, it will be issued by the court as per section 350 of CRPC. If neglected to attend the court without any justification, court may sentence him to a fine, or the court may issue bailable or non-bailable warrant to secure the presence of the witness. ಹಾಗಾಗಿ ಕೋರ್ಟಿಂದ ಸಮನ್ಸ್ ಬಂದಾಗ ಅಪಿಯರ್ ಆಗಲೇಬೇಕು. ಇನ್ನೊಂದು, ಕ್ರಿಮಿನಲ್ ಕೇಸಸ್ಸಲ್ಲಿ ಬಿಕಾಸ್ ದ ಇಂಟ್ರೆಸ್ಟ್ ಆಫ್ ದ ಸ್ಟೇಟ್ ಇನ್ ಸೆಕ್ಯೂರಿಂಗ್ ಜಸ್ಟಿಸ್. ತಮಗೆಲ್ಲರಿಗೂ ಗೊತ್ತಿರಲಿ, ಕ್ರಿಮಿನಲ್ ಕೇಸ್ ದ ಕೇಸ್ ಇನ್ ಆಲ್ ಕೇಸಸ್ ಸ್ಟೇಟ್ ಈಸ್ ಪ್ರಾಸಿಕ್ಯೂಟಿಂಗ್ ದ ಕೇಸ್. ಯಾಕೆಂತ ಹೇಳಿದ್ರೆ ಸ್ಟೇಟ್ ಮಸ್ಟ್ ಪ್ರೊಟೆಕ್ಟ್ ದ ರೈಟ್ಸ್ ಆಫ್ ದ ಸಿಟಿಸನ್ಸ್. ಹಾಗಾಗಿ ಆ ನಿಟ್ಟಿನಲ್ಲಿ ಯಾವುದೇ ಒಂದು ಹವೆವರ್ ನಿಮ್ಗೆ ಯಾವುದೇ ರೀತಿಯ ಫೀ ಕೊಡಲಿಕ್ಕೆ ಸಾಧ್ಯ ಇಲ್ಲದಿದ್ರೂ ಕೂಡ ಕನ್ವೇನ್ಸ್ ಚಾರ್ಜಸ್ ಆ್ಯಂಡ್ ಡೈಲಿ ಅಲವೆನ್ಸ್ ವಿಲ್ ಬಿ ಪೇಯ್ಡ್. ಇನ್ನು ಮೆಡಿಕಲ್ ಎವಿಡೆನ್ಸ್ plays a huge part in proving the guilt of the accused and lead the investigating authorities to the truth. So evidence anta bandaga there are documentary evidence. It includes all documents produced for the inspection of the court. The contents of the documents may be proved either by primary or secondary evidence. ಆಮೇಲೆ ನೆಕ್ಸ್ಟ್ ಅಂತ ಹೇಳಿದ್ರೆ ಓರಲ್ ಡೈರೆಕ್ಟ್ ಎವಿಡೆನ್ಸ್, ಆಮೇಲೆ ಸರ್ಕಮ್ಸ್ಟೆನ್ಷಿಯಲ್ ಎವಿಡೆನ್ಸ್ ಅನ್ನುವಂಥದ್ದು ಬರುತ್ತೆ. ಈ ಸರ್ಕಮ್ಸ್ಟೆನ್ಷಿಯಲ್ ಎವಿಡೆನ್ಸ್ ಅಂದ್ರೆ ಏನಪ್ಪಾ ಅಂತಂದ್ರೆ, ಇನ್ ಎ ಕೇಸ್ ಆಫ್ ಮರ್ಡರ್ ಆಫ್ ಎ ಬೈ ಬಿ at certain place on a particular day and time, the circumstantial evidence would be that C saw B with a knife on that day at that place a few minutes before the murder. So C ಅನ್ನುವನು ಮರ್ಡರ್ ಆಗೋಕ್ಕಿಂತ ಸ್ವಲ್ಪ ಮುಂಚೆ ಒಂದು ನೈಫನ್ನು ಹಿಡ್ಕೊಂಡು ಹೋಗ್ತಿದ್ದದನ್ನ ನೋಡಿರ್ತಾನೆ. C becomes a circumstantial evidence. ಇನ್ನು ಡಾಕ್ಯುಮೆಂಟರಿ ಎವಿಡೆನ್ಸ್. ಡಾಕ್ಯುಮೆಂಟರಿ ಎವಿಡೆನ್ಸ್ ಅಂತ ಹೇಳಿದ್ರೆ ನೀವೆಲ್ಲ ವೈದ್ಯರು ಏನು ಕೊಡ್ತೀರಲ್ಲ, ಮೆಡಿಕಲ್ ಸರ್ಟಿಫಿಕೇಟ್ಸ್, ದೇ ರೆಫರ್ ಟು ಇಲ್ ಹೆಲ್ತ್, ಇನ್ಸ್ಯಾನಿಟಿ, ಡೆತ್. ದೇ ಆರ್ accepted in the court of law only when they are issued by a qualified registered medical practitioner. ಈ ಮೆಡಿಕಲ್ ಸರ್ಟಿಫಿಕೇಟ್ ಅನ್ನುವಾಗ ಒಂದು ಸಣ್ಣ ಕಥೆಯ ಮುಖಾಂತರ ಮೆಡಿಕಲ್ ಸರ್ಟಿಫಿಕೇಟ್ ಇಶ್ಯೂ ಮಾಡುವಾಗ ಏನಾದರೂ ಸಣ್ಣ ತಪ್ಪಾದರೆ ಏನಾಗುತ್ತೆ ಅನ್ನೋದನ್ನು ನಾನು ಹೇಳ್ತೇನೆ. ಇದು ವೈದ್ಯರು ಬರೆದಂತಹ ಪುಸ್ತಕದಲ್ಲಿ ದಾಖಲಾಗಿದ್ದು ಮೊದಲ ತಪ್ಪು ಅಂತ ಹೇಳಿ. ಒಬ್ಬರು ಯುವ ವೈದ್ಯರು ಸರ್ಕಾರಿ ಕೆಲಸಕ್ಕೆ ಸೇರಿ ಕೆಲವೇ ದಿನಗಳಾಗಿತ್ತು. ಒಂದು ಸಣ್ಣ ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ಕಾಂಪೌಂಡರು, ನರ್ಸು ಮತ್ತು ಇಬ್ಬರು ಸಹಾಯಕರು ಅವರ ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ಇದ್ದರು. ಒಂದು ದಿನ ಬೆಳಗ್ಗೆ ಕಾಂಪೌಂಡರ್ ಬಂದು ತನ್ನ ಸ್ನೇಹಿತನ ತಂದೆಗೆ 3 ದಿವಸದ ವಿಶ್ರಾಂತಿ ಬೇಕು ಅಂತ ಹೇಳಿ ಒಂದು ಸರ್ಟಿಫಿಕೇಟ್, ಮೆಡಿಕಲ್ ಸರ್ಟಿಫಿಕೇಟ್ ಕೊಡಿ ಅಂತ ಕೇಳಿದರು. ಇವರು ವೈದ್ಯರು ಆಗಿನ್ನೂ ಬಿಸಿ ರಕ್ತ ಹೋದಂತಹ ಮೊದಲೇ ಯುವ ವೈದ್ಯರು, ಅವರಿಗೆ ಈ ಕಾಂಪೌಂಡರ್ ಚೆನ್ನಾಗಿ ಪರಿಚಿತ ಇದ್ದ. ಹಾಗಾಗಿ ಅವರು ಆಯಿತು ಅಂತ ಹೇಳಿ OPD ರಿಜಿಸ್ಟರ್ನಲ್ಲಿ ದಾಖಲಿಸಿ ಬೀರಪ್ಪ 70 ವರ್ಷ ಅಂತ ಹೇಳಿ ನಮೂದಿಸಿ ರೋಗಿಯನ್ನು ನೋಡದೆ ಮುದುಕ ತನ್ನ ಮಕ್ಕಳೊಂದಿಗೆ ಜಗಳ ಮಾಡಿಕೊಂಡು ಮನೆ ಬಿಟ್ಟು ಹೋಗಿ ಕೆಲವು ಸಮಯ ಆಗಿತ್ತು. ಆತ ಅಲ್ಲಿಂದ ಸ್ವಲ್ಪ ದೂರದಲ್ಲಿ ವಾಸವಾಗಿದ್ದ ಒಬ್ಬರು ಭಟ್ರ ಮನೆಗೆ ಹೋಗಿ ಸೇರಿಕೊಂಡಿದ್ದ. ನಂತರ ನನಗೆ ಈ ಮಕ್ಕಳು ಬೇಡ, ನನ್ನೆಲ್ಲ ಆಸ್ತಿ ಭಟ್ರಿಗೆ ಹೋಗಲಿ ಅಂತ ಹೇಳಿ ಬರೆದಿದ್ದ. ಅಷ್ಟಾದ ನಂತರ ಕೆಲವು ದಿನಗಳ ನಂತರ ಆ ಮುದುಕ ರಸ್ತೆಯಲ್ಲಿ ನಡ್ಕೊಂಡು ಹೋಗ್ತಾ ಇರುವಾಗ ಮಕ್ಕಳು ಆತನನ್ನು ಎತ್ಕೊಂಡು ಜೀಪಲ್ಲಿ ಹಾಕಿ ಕರ್ಕೊಂಡು ಹೋದರು. ಈ ಭಟ್ರು ಹೆಬಿಯಸ್ ಕಾರ್ಪಸ್ ಅನ್ನುವಂತಹ ರಿಟ್ ಪಿಟಿಷನ್ ತಮಗೆಲ್ಲ ಗೊತ್ತಿರ್ಬೋದು ಅಂತ ಅಂದ್ಕೊಳ್ತೀನಿ. ಯಾವುದೇ ಪರ್ಸನ್ ಮಿಸ್ಸಿಂಗ್ ಆದರೆ ಹೆಬಿಯಸ್ ಕಾರ್ಪಸ್ ಅನ್ನುವಂತಹ ರಿಟ್ ಪಿಟಿಷನನ್ನು ಸಲ್ಲಿಸಲಾಗತ್ತೆ ಗೌರವಾನ್ವಿತ ಹೈಕೋರ್ಟ್ನಲ್ಲಿ. ಅದೇ ರೀತಿ ಹೆಬಿಯಸ್ ಕಾರ್ಪಸ್ ಅನ್ನ ಆ ಭಟ್ರು ಸಲ್ಲಿಸ್ತಾರೆ. ಆವಾಗ ಪೊಲೀಸರು ಬೀರಪ್ಪನ ಮನೆಗೆ ಬಂದು ಕೇಳುವಾಗ ಮಕ್ಕಳು ಅವನು ಬೀರಪ್ಪ ಇಲ್ಲಿ ಇಲ್ಲ ಅಂತ ಹೇಳ್ತಾರೆ. ಪೊಲೀಸರು ಅದರಂತೆ ವರದಿ ಸಲ್ಲಿಸ್ತಾರೆ. ಈಗ ಬಂತು ನೋಡಿ ತೊಂದರೆ. ಪೊಲೀಸರು ಹೇಳ್ತಾರೆ ಬೀರಪ್ಪ ಅವರ ಮನೆಯಲ್ಲಿ ಇಲ್ಲ, ಆದರೆ ಡಾಕ್ಟರ್ ಸರ್ಟಿಫಿಕೇಟ್ನಲ್ಲಿ ಅವರನ್ನು ನೋಡಿ ವಿಶ್ರಾಂತಿ ಹೇಳಿದ್ದಾರೆ, 3 ದಿವಸದ ವಿಶ್ರಾಂತಿಯನ್ನ ಹೇಳಿದ್ದಾರೆ. ಈಗ ಕೋರ್ಟ್ ಮುಂದೆ ಇರುವಂತಹ ವಿಷಯ ಅಂತ ಹೇಳಿದ್ರೆ ಪೊಲೀಸ್ ಮತ್ತು ಡಾಕ್ಟರ್ ಇಬ್ಬರಲ್ಲಿ ಯಾರೋ ಒಬ್ರು ಸುಳ್ಳು ಹೇಳ್ತಾ ಇದ್ದಾರೆ. ಹಾಗಾಗಿ ಅವರನ್ನ ಪ್ರತಿವಾದಿ 12 ಮತ್ತು 13 ಮಾಡಬೇಕು ಅಂತ ಇದ್ದಾರೆ ಅಂತ ಹೇಳಿ ಈ ವಕೀಲರು ಆ ವೈದ್ಯರಿಗೆ ಹೇಳ್ತಾರೆ. ವಕೀಲರಿಗೆ ನಿಂತ ನೆಲವೇ ಬಿರಿದು ಹೋಗುದಂತೆ ಭಾಸವಾಗುತ್ತೆ. ಯಾಕಂತ ಹೇಳಿದ್ರೆ ಅವ್ರು ಕೇಳ್ತಾರೆ, ಅಲ್ಲ ನೀವು ನಿಜವಾಗಿಯೂ ಬೀರಪ್ಪನನ್ನ ನೋಡಿದ್ದೀರಾ? ನೋಡಿಲ್ಲ ಅಂತ ಹೇಳಿದ್ರೆ ಸತ್ಯವಾಗಿ ಒಪ್ಪಿಕೊಂಡು ಬಿಡಿ, ಇಲ್ಲದಿದ್ರೆ ಭಾರಿ ತೊಂದರೆ ಆಗ್ಬೋದು ಅಂತ. ಆದರೆ ವೈದ್ಯರು ಯೋಚನೆ ಮಾಡ್ತಾರೆ, ಹೇಗಿದ್ರು ನಾನು ಅವರ ಮಗನ ಹೇಳಿಕೆಯಂತೆ ಸರ್ಟಿಫಿಕೇಟನ್ನು ಕೊಟ್ಟಿದ್ದೇನೆ, ಏನಾದರೂ ಆಗಲಿ ಅಂತ ಹೇಳಿ ಧೈರ್ಯವಾಗಿ ಹೇಳ್ತಾರೆ. ವೈದ್ಯರು, ಯುವ ವೈದ್ಯರು ಬಿಸಿ ರಕ್ತ, ಹಾಗಾಗಿ ಹೇಳ್ತಾರೆ, ಇಲ್ಲ ನಾನು ನೋಡಿದ್ದೇನೆ, ಬೀರಪ್ಪನನ್ನು ನೋಡಿದ್ದೇನೆ, ನಾನು ಅವರ ಬೀರಪ್ಪನ ಮೈ ಮೇಲೆ ಇರುವಂತಹ ಮಚ್ಚೆ ಮೋಲೇನಿದೆ ಅದನ್ನು ಕೂಡ ನಮೂದಿಸಿದ್ದೇನೆ, ವಿತಿನ್ ಬ್ರಾಕೆಟ್ ಅವರ ಮಗನ ಹೇಳಿಕೆಯಂತೆ. ಹಾಗಾಗಿ ಅದು ಅವರಿಗೆ ಮಾತ್ರ ಗೊತ್ತು. ಅದೇ ರೀತಿ ಹೆಬ್ಬೆಟ್ಟಿನ ಗುರುತು ಇರುತ್ತೆ, ಹೆಬ್ಬೆಟ್ಟಿನ ಗುರುತು ಈ ವೈದ್ಯರಿಗೆ ಮಾತ್ರ ಗೊತ್ತು ಅದು ಅವರ ಮಗನದ್ದು ಅಂತ ಹೇಳಿ, ಆದರೆ ಅದು ಬೀರಪ್ಪಂದು ಆಗಿರೋದಿಲ್ಲ. ಇಷ್ಟನ್ನು ಹೇಳಿದಾಗ ಆ ವಕೀಲರಿಗೆ ಇಷ್ಟು ಧೈರ್ಯವಾಗಿ ಹೇಳ್ತಾ ಇದ್ದಾರಲ್ಲ, ಮೋಸ್ಟ್ಲಿ ಇವರು ಇದಕ್ಕಿಲ್ಲ, ಈ ರೀತಿ ಏನು ಮಾಡಿರ್ಲಿಕ್ಕಿಲ್ಲ ಅಂತ ಹೇಳಿ ಅವರನ್ನ ಪ್ರತಿವಾದಿಯಾಗಿ ಅವರು ಕೈ ಬಿಡ್ತಾರೆ. ಪೊಲೀಸರನ್ನ ಮಾತ್ರ ಪ್ರತಿವಾದಿಯಾಗಿ ಮಾಡ್ತಾರೆ. ಇಷ್ಟೆಲ್ಲ ಆಗಿ ಈ ವೈದ್ಯರು ಮೊದಲು ಮಾಡಿದಂತಹ ತಪ್ಪಿನಿಂದ ಹೊರಗೆ ಬರ್ತಾರೆ. ಅಂತ ಹೇಳಿದ್ರೆ ಇನ್ನು ಮುಂದೆ ಯಾವತ್ತೂ ನಾನು ಈ ರೀತಿಯ ಮೆಡಿಕಲ್ ಸರ್ಟಿಫಿಕೇಟ್ ಕೊಡುವುದಿಲ್ಲ ಅಂತ ಹೇಳಿ ಅವರು ತೀರ್ಮಾನ ಮಾಡ್ತಾರೆ. ಆದರೆ 2 ವರ್ಷದ ಬಳಿಕ ಅದೇ ಮುದುಕ ಅವರ ಮಕ್ಕಳ ಮನೆಯ ಹತ್ತಿರ ಮಳೆಗಾಲದಲ್ಲಿ ಹೊಳೆ ದಾಟಲು ಹೋಗಿ ಜಾರಿ ಬಿದ್ದು ನೀರಿನಲ್ಲಿ ಮುಳುಗಿ ಮರಣ ಹೊಂತಾನೆ. ಆಗ ಅವರ PM ರಿಪೋರ್ಟನ್ನು ನಾನು ಈ ಮೇಲೆ ಹೇಳಿದಂತಹ ನಮ್ಮ ಕಥಾನಾಯಕ ಯುವ ವೈದ್ಯರು ಅವರೇ ಕಾಡಿನ ಹೊಳೆಯ ದಂಡೆಯ ಮೇಲೆ ಮಾಡಬೇಕಾಗತ್ತೆ. ವಿಪರ್ಯಾಸ ಅಂತ ಹೇಳಿದ್ರೆ ಜೀವ ಬಿದ್ದಾಗ ಬೀರಪ್ಪನನ್ನ ಅವರು ನೋಡಿರಲಿಲ್ಲ, ಆದರೆ ಆತ ತೀರಿಕೊಂಡ ನಂತರ ಆತನ ಡೆಡ್ ಬಾಡಿಯ ಮೇಲೆ PM ರಿಪೋರ್ಟ್ ಮಾಡುವಂಥದ್ದನ್ನು ಅವ್ರು ಮಾಡ್ತಾರೆ. ಇದನ್ನು ಒಂದು ಕಥೆಯ ರೂಪದಲ್ಲಿ ನಾನು ಹೇಳಿದ್ದು ಯಾಕೆ ಅಂತ ಹೇಳಿದರೆ, ಇದರಲ್ಲಿರುವಂತಹ ಏನೋ ಕೆಲವೊಂದು ಸಂದರ್ಭಗಳಲ್ಲಿ ಕೆಲಸದ ಒತ್ತಡದಲ್ಲಿ ನೀವು ಒಂದು ಸರ್ಟಿಫಿಕೇಟನ್ನು ಯಾವುದೋ ದಾಕ್ಷಿಣ್ಯಕ್ಕೆ ಬರೆದು ಕೊಟ್ಟರೆ, ಯಾವುದೋ ಒಂದು ಕ್ಷಣದಲ್ಲಿ ಯಾವುದೋ ಒಂದು ಇನ್ಸ್ಟೆನ್ಸಲ್ಲಿ ನೀವು ಪಾರಾಗ್ಬೋದು, ಬಟ್ ನಾಟ್ ಇನ್ ಆಲ್ ಟೈಮ್ಸ್ ಅನ್ನುವಂತಹ ವಿಷಯವನ್ನು ಹೇಳಿ ಇನ್ನೊಂದು ಅಂತ ಹೇಳಿದರೆ ಡಾಕ್ಯುಮೆಂಟರಿ ಎವಿಡೆನ್ಸಲ್ಲಿ ಮೆಡಿಕಲ್ ಸರ್ಟಿಫಿಕೇಶನ್ ಆಫ್ ಡೆತ್ ಅನ್ನೋದು ಕೂಡ ಬರುತ್ತೆ. ಇದರಲ್ಲಿ ಈಗಾಗಲೇ ನಿಮಗೆ ವೈದ್ಯರು ಹೇಳಿದಂತೆ ಇದರಲ್ಲಿ ಕ್ಲಾಸಿಫಿಕೇಶನ್ ಆಫ್ ಡಿಸೀಸಸ್ ಅನ್ನ, ಆಮೇಲೆ ಇಂಜುರೀಸ್, ಕಾಸಸ್ ಆಫ್ ಡೆತ್. ಇದ್ರ ಏನಾಗುತ್ತೆ ಅಂತ ಹೇಳಿದ್ರೆ ಯೂಶುವಲಿ ಅಕ್ಯೂಸ್ಡ್ ವಿಲ್ ಬಿ ಬ್ರಾಟ್ ಬೈ ದ ಪೊಲೀಸ್ ಕಾನ್ಸ್ಟೇಬಲ್, ನಿಮಗೆಲ್ಲ ಗೊತ್ತಿರಬೇಕು. ಅವ್ರು ಏನು ಮಾಡ್ತಾರೆ, ಬ್ರಾಟ್ ಬೈ ಪೊಲೀಸ್ ಕಾನ್ಸ್ಟೇಬಲ್, ಫಾರ್ ಎಕ್ಸಾಂಪಲ್ ಸಂತೋಷ್ ಅಂತ ಹೇಳಿ ಬರೆದಿರ್ತಾರೆ ಮೇಲ್ಗಡೆ, ಸಂತೋಷ್ ಅಂತ. ಕೆಲವು ಟೈಮ್ ಏನು ಮಾಡ್ತಾರೆ, ಮೇ ಬಿ ಜೂನಿಯರ್ ಡಾಕ್ಟರ್ಸ್ ಕೈಯಲ್ಲಿ ಕೊಡ್ತಾರೋ ಏನೋ ಗೊತ್ತಿಲ್ಲ, ಕೆಳಗೆ ಪುನಃ ಐ ಆಮ್ ಆಫ್ ದ ಒಪಿನಿಯನ್ ದ್ಯಾಟ್ ಸೊ ಅಂಡ್ ಸೊ ಸಚ್ ಅಂಡ್ ಸಚ್ ಅಂಡ್ ಪರ್ಸನ್ ಈಸ್ ಕೇಪೇಬಲ್ ಅಂತ ಹೇಳಿ ಬರೀಬೇಕಲ್ವ ನೀವು. ಕೇಪಬಿಲಿಟಿ ಕೊಡುವಾಗ ಆ ಅಕ್ಯೂಸ್ ಹೆಸರನ್ನ ಮರೆತು ಬಿಡ್ತಾರೆ, ಸಂತೋಷ್ ಬರ್ತಾರೆ, ಅಂದರೆ PC ಹೆಸರನ್ನ ನೀವು ಬರೆದು ಬಿಡ್ತೀರಿ. ಇದು ನಾನು ಪ್ರಾಕ್ಟಿಕಲ್ ಆಗಿ ನೋಡಿರುವಂಥದ್ದನ್ನು ಹೇಳ್ತಾ ಇದ್ದೀನಿ. ಯಾಕಂತ ಹೇಳಿದ್ರೆ ಅಲ್ಲಿ ಮೇನ್ ಅಲಿಗೇಷನ್ ಯಾರ ಮೇಲೆ ಇರುತ್ತೆ, ಅಕ್ಯೂಸ್ಡ್ ಮೇಲೆ ಇರುತ್ತೆ. ನೀವು ಯಾರ ಮೇಲೆ ಬರೀತೀರಿ, PC ಮೇಲೆ ಬರೀತೀರಿ. ಸೊ ಬಿವೇರ್, ಯಾಕಂತ ಹೇಳಿದ್ರೆ ಡಿಫಾಮೇಷನ್ ಕೇಸ್ ಕೂಡ ನಿಮ್ಮ ಮೇಲೆ ಬರುವಂಥ ಚಾನ್ಸಸ್ ಕೂಡ ಇರುತ್ತೆ. ಆಮೇಲೆ ಇನ್ನೊಂದು ಅಂತ ಹೇಳಿದ್ರೆ ಪ್ರೆಸೆನ್ಸ್ ಆಫ್ ಎನಿ ಸೈನ್ ಆರ್ ಆಫ್ ಲೋಕಲ್ ಇಂಜುರಿ ಅನ್ನುವಂಥದ್ದು ಒಂದು ಅಕ್ಯೂಸ್ ಎಕ್ಸಾಮಿನೇಷನಲ್ಲಿ ಇರುತ್ತೆ. ಒಂದು ಅಂತ ಹೇಳಿದರೆ ಬಹುಶಃ ನಿಮಗೆ ಡಾಕ್ಟರ್ಸ್ ನನಗಿಂತ ನಿಮಗೆ ಚೆನ್ನಾಗಿ ಗೊತ್ತಿದೆ, ಇಫ್ ಎ ರೇಪ್ if there is a allegation that accused has committed a rape against a woman aged 70 years ಅಂತ ಹೇಳಿ ಇರುತ್ತೆ ಅಂತ ಆದರೆ ಯೂಶುವಲಿ 65 years woman ಅಂತ ಇದ್ರೆ ಡೆಫಿನೆಟ್ಲಿ there will be a chances of injury on the internal organ of the accused also. That will be missing. ಸೊ ನಾನು ಅದನ್ನು ಕೆಲವೊಂದನ್ನೆಲ್ಲ ನಾನು ಫೈಂಡ್ ಔಟ್ ಮಾಡಿದ್ದೀನಿ. ಯಾಕೆಂತ ಹೇಳಿದ್ರೆ ನಾವು ಐ ಎಮ್ ಎ ಸೀನಿಯರ್ ಸಿವಿಲ್ ಜಡ್ಜ್, ಇನ್ನೂ ಹೀನಿಯಸ್ ಅಫೆನ್ಸಸ್ ಬಗ್ಗೆ ಟ್ರೈ ಮಾಡಿಲ್ಲ. ಬಟ್ ವೈಲ್ ವರ್ಕಿಂಗ್ ಇನ್ ಎ ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಲೀಗಲ್ ಸರ್ವಿಸ್ ಅಥಾರಿಟಿ ನಮ್ಮಲ್ಲಿ ಲೀಗಲ್ ಏಡ್ ಡಿಫೆನ್ಸ್ ಕೌನ್ಸಿಲ್ಸ್ ಇರ್ತಾರೆ. ಚೀಫ್ ಲೀಗಲ್ ಏಡ್ ಡಿಫೆನ್ಸ್ ಕೌನ್ಸಿಲ್ಸ್, ಡೆಪ್ಯೂಟಿ ಲೀಗಲ್ ಏಡ್ ಡಿಫೆನ್ಸ್ ಕೌನ್ಸಿಲ್ಸ್ಗೆ ಸೆಷನ್ ಟ್ರೈಬಲ್ ಮ್ಯಾಟರ್ಸ್ ಬರ್ತದೆ. ಅವರು ಕೇಸಸ್ಸನ್ನು ನಡೆಸುವಾಗ ಅವರ ಅನುಭವಗಳನ್ನು ಪಡೆದುಕೊಂಡು ಅದರಲ್ಲಿ ಇರುವಂತಹ ದಾಖಲಾತಿಗಳ ಆಧಾರದ ಮೇರೆಗೆ ನಾನು ನಿಮ್ಗೆ ಹೇಳ್ತಾ ಇದ್ದೀನಿ. ಏನಾಗುತ್ತೆ ಅಂತ ಹೇಳಿದರೆ, ಇಫ್ ಅ ರೇಪ್ ಇಸ್ ಕಮಿಟೆಡ್ ಅಗೇನ್ಸ್ಟ್ ಎ ಸ್ಮಾಲ್ ಗರ್ಲ್ ಆಲ್ಸೋ, ಒಂದು 6-7 years ಗರ್ಲ್ಸ್ ಮೇಲೆ ಆದಂತಹ ಅಫೆನ್ಸಲ್ಲಿ ಕೂಡ ಅಲ್ಲಿ ವಜೈನಾ ಅಲ್ಲಿ ವಿಲ್ ನಾಟ್ ಬಿ ವೆಟ್. ಹಾಗಾಗಿ ಅಂಥ ಸರ್ಕಮ್ಸ್ಟೆನ್ಸಸ್ಸಲ್ಲಿ ಒಂದು ಇಂಜುರೀಸ್ ಆಗುವಂಥ ಸಾಧ್ಯತೆ ಇರುತ್ತೆ. ಸೊ ಅದನ್ನು ಡಿಫೆನ್ಸ್ ಆಗಿ ತಗೊಳ್ತಾರೆ ಅವರು. ಹಾಗೆ ಅದನ್ನು ಕೂಡ ನೀವು ಗಮನದಲ್ಲಿರಿಸಬೇಕು ಅಂತ ಹೇಳಿ ನಾನು ಹೇಳ್ತೇನೆ. ನೆಕ್ಸ್ಟು FSL ರಿಪೋರ್ಟಲ್ಲಿ ಕೂಡ ಡ್ಯೂರೇಷನ್ ಆಫ್ ಎಕ್ಸಾಮಿನೇಷನ್ ಟು ಬಿ ಮೆನ್ಷನ್ಡ್. ಯಾಕೆಂತ ಹೇಳಿದ್ರೆ ಯಾವ ಟೈಮಿಂದ ಯಾವ ಟೈಮ್ವರೆಗೆ ಎಕ್ಸಾಮಿನೇಷನ್ ಆಗಿದೆ ಅಂತ ಹೇಳಿ ನಮೂದು ಮಾಡಿಲ್ಲ ಅಂತ ಹೇಳಿದರೆ ಇಟ್ ಮೇ ಬಿ ಎ ಗ್ರೌಂಡ್ ಫಾರ್ ಅಕ್ವಿಟಲ್ ಆಫ್ ದ ಕೇಸ್. ನೆಕ್ಸ್ಟು ಡೈಯಿಂಗ್ ಡಿಕ್ಲರೇಷನ್. ಡೈಯಿಂಗ್ ಡಿಕ್ಲರೇಷನ್ ಅಂದರೆ ಇಟ್ ಈಸ್ ಎ ರಿಟನ್ ಆರ್ ಓರಲ್ ಸ್ಟೇಟ್ಮೆಂಟ್ ಆಫ್ ಎ ಪರ್ಸನ್ ಹೂ ಈಸ್ dying as a result of some unlawful act relating to the material facts of cause of his death or bearing on the circumstances. Next, oral evidence. It includes all statements which the court permits or which are required to be made before it by the witness in relation to matters of fact under inquiry. Oral evidence. Next, to exceptions to oral evidence anta helidre dying declaration. Statements verbal or written of relevant facts made by a person who is dead, who cannot be found, who has become incapable of giving evidence, or whose attendance cannot be procured without unreasonable delay and expenditure as admissible as evidence. Amele expert opinion expressed in a treatise may be proved in court by producing such book ಅಂತ ಹೇಳಿ ಇದೆ. ಆಮೇಲೆ ಈ ಎವಿಡೆನ್ಸ್ ಇದ್ರ ಬಗ್ಗೆ ಸಂಪೂರ್ಣವಾಗಿ ಹೇಳ್ತಾ ಕೂತ್ರೆ ನಿಮಗೆ ಅದು ಬೋರ್ ಆಗ್ಬೋದು. ಇದನ್ನು ನಾನು ಪೇಪರ್ ಏನಿದೆ ಅದನ್ನು ನಿಮಗೆ ಪಾಸ್ ಓವರ್ ಮಾಡ್ತೀನಿ, ನಿಮಗೆ ಕಳಿಸ್ಕೊಡ್ತೀನಿ. ಪೂರ್ತಿ ಹೇಳ್ತಾ ಹೋದರೆ ಬಹುಶಃ ಈಗಾಗಲೇ ನಿಮ್ಮ ಒಂದು ಬ್ರೇಕ್ ಟೈಮನ್ನು ನಾವು ಕಸ್ದುಕೊಂಡು ಮಾತಾಡ್ತಾ ಇದ್ದೀವಿ. ನೆಕ್ಸ್ಟ್ ಅಂತ ಹೇಳಿದರೆ ವಿಟ್ನೆಸಸ್, ಟೈಪ್ಸ್ ಆಫ್ ವಿಟ್ನೆಸಸ್ ಬಗ್ಗೆ ಹೇಳೋದಾದರೆ there are 2 types of witnesses, common and expert. So doctors are the expert witnesses. Common witness is a person who gives evidence about the facts observed and perceived by him. Expert witness is a person who has been trained or is skilled in technical or scientific subject and capable of drawing opinions, conclusions from the facts observed by himself or noticed by others. ತಮಗೆಲ್ಲ ತಿಳಿದಿರಲಿ, ಈ ಡಾಕ್ಟರ್ಸ್ ಎವಿಡೆನ್ಸ್ ಏನಿದೆಯಲ್ಲ ಇದನ್ನು ಒಪಿನಿಯನ್ ಎವಿಡೆನ್ಸ್ ಅಂತೇಳಿ ಕನ್ಸಿಡರ್ ಮಾಡ್ತಾರೆ. ಆಮೇಲೆ ಕಂಡಕ್ಟ್ ಆ್ಯಂಡ್ ಡ್ಯೂಟೀಸ್ ಆಫ್ ದ ಡಾಕ್ಟರ್ ಇನ್ ದ ವಿಟ್ನೆಸ್ ಬಾಕ್ಸ್ ಅದ್ರ ಬಗ್ಗೆ ತುಂಬ ಇದೆ ಅಂತ ಹೇಳಿದರೆ ಹೌ ಹಿ ಶುಡ್ ಕಂಡಕ್ಟ್ ಹಿಮ್ಸೆಲ್ಫ್ ಅಂತೇಳಿ. ಅದು ಬಹುಶಃ ನಿಮ್ಗೆಲ್ಲರಿಗೂ ಗೊತ್ತಿದೆ. ಮೇಯ್ನಾಗಿ ಹೇಳಬೇಕು ಅಂತ ಹೇಳಿದರೆ ಬಿ ವೆಲ್ ಪ್ರಿಪೇರ್ಡ್ ವಿತ್ ದ ಡೀಟೇಲ್ಸ್ ಆಫ್ ಯುವರ್ ಕೇಸ್. ಅಂದರೆ ಎವಿಡೆನ್ಸ್ ವಾಟ್ ಯು ಆರ್ ಡಿಪೋಸಿಂಗ್ ಬಿಫೋರ್ ದ ಕೋರ್ಟ್ ಅದ್ರ ಬಗ್ಗೆ ವೆಲ್ ಪ್ರಿಪೇರ್ಡ್ ಆಗಿರಬೇಕು. ಟೇಕ್ ಆಲ್ ರೆಕಾರ್ಡ್ಸ್ ಆ್ಯಂಡ್ ರಿಲೆವೆಂಟ್ ರಿಪೋರ್ಟ್ಸ್ ವಿತ್ ಯು ಅನ್ನುವಂಥದ್ದು. ಬಿ ವೆಲ್ ಡ್ರೆಸ್ಡ್ ಆ್ಯಂಡ್ ಮಾಡೆಸ್ಟ್, ಸ್ಟ್ಯಾಂಡ್ ಅಪ್ ಸ್ಟ್ರೈಟ್, ನೆವರ್ ಅಟೆಂಪ್ಟ್ ಟು ಮೆಮೊರೈಸ್. ಯಾಕೆಂತ ಹೇಳಿದ್ರೆ ಈ ಮೆಮೊರೈಸ್ ಅನ್ನೋದಿಲ್ಲ, ನಮ್ಮಲ್ಲಿ ರಿಫ್ರೆಶಿಂಗ್ ಮೆಮೊರಿ ಇದೆ ಹೊರತು ಮೆಮೊರೈಸಿಂಗ್ ಅನ್ನುವಂಥದ್ದು ಕೋರ್ಟ್ ಆಫ್ ಲಾದಲ್ಲಿ ಇಲ್ಲ. ಆಮೇಲೆ ಬಿ ರಿಲ್ಯಾಕ್ಸ್ಡ್ ಆ್ಯಂಡ್ ಕಾಮ್ ಆ್ಯಂಡ್ ನಾಟ್ ಫ್ರೈಟನ್ಡ್ ಆರ್ ನರ್ವಸ್, ಸ್ಪೀಕ್ ಸ್ಲೋಲಿ, ಡಿಸ್ಟಿಂಕ್ಟ್ಲಿ ಆ್ಯಂಡ್ ಆಡಿಬ್ಲಿ ಅನ್ನುವಂಥದ್ದು. ನೆಕ್ಸ್ಟ್ ಸ್ಪೀಕ್ ವಿತ್ ಅಶ್ಯೂರೆನ್ಸ್, ಬಿ ಕಾನ್ಫಿಡೆಂಟ್. ಯಾಕಂತ ಹೇಳಿದರೆ ನೀವೇನಾದರೂ ಒಂದು ಸಣ್ಣ ಡೌಟ್ ಮಾಡಿದರೆ ಅಲ್ಲಿ ಆರೋಪಿ ಪರ ವಕೀಲರು ನಿಂತಿರ್ತಾರೆ ನಿಮ್ಮನ್ನು ಪ್ರಶ್ನೆಗಳನ್ನು ಕೇಳಲಿಕ್ಕೆ. ಹಾಗಾಗಿ ಏನು ಹೇಳ್ತೀರೋ ಅದನ್ನು ವಿತ್ ಅಶ್ಯೂರೆನ್ಸ್, ಬಿ ಕಾನ್ಫಿಡೆಂಟ್ ಆಗಿ ಹೇಳಬೇಕಾಗುತ್ತೆ. ಆಮೇಲೆ ಸಿಂಪಲ್ ಲ್ಯಾಂಗ್ವೇಜನ್ನು ಉಪಯೋಗಿಸ್ಬೇಕಾಗುತ್ತೆ. ಯಾಕಂತ ಹೇಳಿದರೆ ಈಗ ನೀವು ಈಗಷ್ಟೇ ಡಾಕ್ಟ್ರು ಸುಮಾರು ಚೆನ್ನಾಗಿ ಹೇಳಿದರು, ಆದರೆ ಅವ್ರು ಹೇಳಿದ ಸುಮಾರು ವಿಷಯಗಳು ನಮ್ಮ ತಲೆಗೆ ಹೋಗಲಿಲ್ಲ. ಯಾಕಂದರೆ ವಿ ಆರ್ ನಾಟ್ ಸೈನ್ಸ್ ಸ್ಟೂಡೆಂಟ್ಸ್. ಹಾಗಾಗಿ ಯಾಕಂದರೆ ಜಡ್ಜಸ್ಸು ಎಷ್ಟೇ ಓದಿದ್ರು ಕೂಡ ನೀವು ಆ ಫೀಲ್ಡಲ್ಲಿ ಎಕ್ಸ್ಪರ್ಟೈಸ್ ಆಗಿರ್ತೀರಿ. ನೀವು ಅದನ್ನು ಸಿಂಪಲ್ ಆಗಿ ಈ ರೀತಿ ಆಗ್ಬೋದು ಅಂತ ಹೇಳಿದಾಗ ಖಂಡಿತ ಆ ಕೇಸಿಗೆ ಒಂದು ಜಯ ಸಿಕ್ಕತ್ತೆ. ಜಯ ಇನ್ ದ ಸೆನ್ಸ್ ಜಸ್ಟಿಸ್ ಸಿಕ್ಕತ್ತೆ. ಯಾಕಂತ ಹೇಳಿದರೆ ಜಯ ಫಾರ್ ಅಕ್ಯೂಸ್ಡ್ ಕೌನ್ಸಲ್, ಆರೋಪಿಗೆ ಬಿಡುಗಡೆ ಆಗೋದು. ಫಾರ್ ಪಬ್ಲಿಕ್ ಪ್ರಾಸಿಕ್ಯೂಟ್ರಿಗೆ ಬಂದರೆ ಜಯ ಅನ್ನೋದು ದಟ್ ಕೇಸ್ ಶುಡ್ ಎಂಡ್ ಇನ್ ಕನ್ವಿಕ್ಷನ್. ಹಾಗಾಗಿ ನೆಕ್ಸ್ಟು ಅವಾಯ್ಡ್ ಸೂಪರ್ಲೇಟಿವ್ಸ್ ಆ್ಯಂಡ್ ಎಕ್ಸಾಗೇಷನ್. ತುಂಬ ಇದಾಗಿ ಹೇಳಬಾರ್ದು ಯಾವುದೇ ಒಂದು ಕಥೆಯನ್ನು. ಆಮೇಲೆ ನೆಕ್ಸ್ಟು ಡು ನಾಟ್ ಡಿಸ್ಕಸ್ ದ ಕೇಸ್ ವಿತ್ ಎನಿ ಒನ್ ಇನ್ ದ ಕೋರ್ಟ್ ಎಕ್ಸೆಪ್ಟ್ ದ ಲಾಯರ್ ಬೈ ಹೂಮ್ ಯು ವೇರ್ ಆಸ್ಕ್ಡ್ ಟು ಟೆಸ್ಟಿಫೈ. ಪಬ್ಲಿಕ್ ಪ್ರಾಸಿಕ್ಯೂಟರ್ ಹತ್ರ ಮಾತ್ರ ನೀವು ಡಿಸ್ಕಸ್ ಮಾಡಬೇಕು. ಆಮೇಲೆ ಅಡ್ರೆಸ್ ದ ಜಡ್ಜ್ ಬೈ ಹಿಸ್ ಪ್ರಾಪರ್ ಟೈಟಲ್ ಸಚ್ ಎಸ್ ಸರ್ ಆರ್ ಯುವರ್ ಆನರ್. ಯುವರ್ ಆನರ್ ಅಂತ ಹೇಳೋದನ್ನು ಈಗ ಕೆಲವು ಕಡೆ ತೆಗೆದಿದ್ದಾರೆ. ಹಾಗಾಗಿ ನೀವು ಸರ್ ಮೇಡಮ್ ಹೇಳಿದರೆ ಸಾಕಾಗುತ್ತೆ. ನೆಕ್ಸ್ಟ್ ಅವಾಯ್ಡ್ ಡಿಫರೆನ್ಸ್ ಬಿಟ್ವೀನ್ ಯುವರ್ ರೆಕಾರ್ಡ್ ಆ್ಯಂಡ್ ಯುವರ್ ಟೆಸ್ಟಿಮನಿ. ಇಫ್ an error or slight contradiction has been made in the testimony, admit and correct it. ಯಾಕೆಂದರೆ ನಾನು ಈಗೇನು ಹೇಳಿದೆ ಅಲ್ಲ, ಆ ಕೇಸಲ್ಲಿ PC ನೇಮನ್ನು ಮೆನ್ಷನ್ ಮಾಡಿದ್ರು ಅಂಥೇಳಿ, ಅದನ್ನು ನಿಮ್ಮ ಗಮನಕ್ಕೆ ಬಂದ ತಕ್ಷಣವೂ ನೀವು ಪಬ್ಲಿಕ್ ಪ್ರಾಸಿಕ್ಯೂಟರ್ಗೆ ಹೇಳ್ಬೋದು. ಯಾಕೆಂತ ಹೇಳಿದ್ರೆ ಎಟ್ ಎನಿ ಟೈಮ್ ಇಟ್ ಕ್ಯಾನ್ ಬಿ ರೆಕ್ಟಿಫೈಡ್. ಯಾಕೆಂದರೆ ಒಂದು ಮಿಸ್ಟೇಕ್ ಅಲ್ಲೇ ಉಳಿದ್ರೆ ರೆಕ್ಟಿಫಿಕೇಶನ್ ಆಗಿದೆ. ಅಟ್ಲೀಸ್ಟ್ ಯು ಕ್ಯಾನ್ ಅವರಿಗೊಂದು ಮಾತು ಹೇಳಿದರೆ ಪಬ್ಲಿಕ್ ಪ್ರಾಸಿಕ್ಯೂಟರ್ ಕ್ಯಾನ್ ಮೂವ್ ಎನ್ ಅಪ್ಲಿಕೇಶನ್ ಬಿಫೋರ್ ದ ಕೋರ್ಟ್. ರೆಕ್ಟಿಫಿಕೇಷನ್ಗೆ ಅವಕಾಶ ಇರುತ್ತೆ. ಇಲ್ಲದಿದ್ದರೆ ಏನಾಗುತ್ತೆ, ಆ ಮಿಸ್ಟೇಕು ಅಲ್ಲೇ ಉಳ್ಕೊಂಡು ಅದೇ ಒಂದು ಅಕ್ವಿಟಲ್ಗೆ ಗ್ರೌಂಡ್ ಆಗ್ಬೋದು. ಮತ್ತೆ ಡು ನಾಟ್ ಅಂಡರ್ ಎಸ್ಟಿಮೇಟ್ ದ ಮೆಡಿಕಲ್ ನಾಲೆಡ್ಜ್ ಆಫ್ ದ ಲಾಯರ್ಸ್. ಇದು ಒಂದಿದೆ. ಯಾಕೆಂತ ಹೇಳಿದರೆ ಲಾಯರ್ಗೆ ಇವ್ರಿಗೇನು ಗೊತ್ತು ಅಥವಾ ಜಡ್ಜಿಗೆ ಇವ್ರಿಗೇನು ಗೊತ್ತು ಅಂಥೇಳಿ. ಯಾಕಂದರೆ ನಿಮ್ಮಷ್ಟು ಅಫ್ಕೋರ್ಸ್ ಮೆಡಿಕಲ್ ಫೀಲ್ಡಲ್ಲಿ ಯು ಆರ್ ಎನ್ ಎಕ್ಸ್ಪರ್ಟ್, ನಿಮಗೆ ಗೊತ್ತಿರ್ಬೋದು. ಬಟ್ ಅಡ್ವೊಕೇಟ್ಸಿಗೂ ಕೂಡ ಗೊತ್ತಿಲ್ಲವನ್ನ ಅನ್ನುವಂತಹ ಒಂದು ಭಾವನೆಯಿಂದ ಅವ್ರ ಹತ್ರ ಮಾತಾಡಿಸ್ಬಾರ್ದು. ನೆಕ್ಸ್ಟು ಡು ನಾಟ್ ಲೂಸ್ ಯುವರ್ ಟೆಂಪರ್. ಯಾಕೆಂತ ಹೇಳಿದರೆ ನಾನು ನೋಡಿದ್ದೀನಿ ಸಾಕಷ್ಟು ಸಲ ಎವಿಡೆನ್ಸ್ಗೆ ಬಂದ ಡಾಕ್ಟ್ರುಗಳು ಬಹಳ ಸಿಟ್ಟಾಗಿ ಹೋಗ್ತಾರೆ. ನೀವು ಈ ರೀತಿ ಅದೊಂದು ಅವ್ರು ಕೇಳುವಂಥ ವಿಧಾನ ಅಷ್ಟೇ. ನೀವು ಸುಳ್ಳು ಮಾಹಿತಿ ಕೊಡ್ತಾ ಇದ್ದೀರಿ, ನೀವು ಸುಳ್ಳು ಸರ್ಟಿಫಿಕೇಟ್ ಕೊಡ್ತಾ ಇದ್ದೀರಿ. ಅವ್ರು ಹೇಳ್ತಾರೆ, ನೀವೇ ಯಾಕೆ ಅಷ್ಟು ಇದಾಗಬೇಕು, ಒಂದೇ ಸಲ ರೈಸ್ ಆಗಬೇಕು. ಅವ್ರು ಹೇಳ್ತಾರೆ ಇಟ್ ಇಸ್ ದೇರ್ ಡ್ಯೂಟಿ, ಪ್ರೊಫೆಷನ್ ಅವ್ರದ್ದು. ಅವರು ಅವರ ಆರೋಪಿಯನ್ನು ಕಾಪಾಡ್ಕೊಳ್ಳೋದು ಅವ್ರ ಕರ್ತವ್ಯ. ಆದರೆ ನಾನು ಎಷ್ಟೋ ಸಲ ಡಾಕ್ಟರ್ಸ್ ಸಡನ್ ಅವ್ರ ಟೆಂಪರ್ ಲೂಸ್ ಮಾಡ್ಕೊಳ್ಳೋದನ್ನು ನೋಡಿದ್ದೇನೆ. ಅಷ್ಟು ಸಿಟ್ಟಾಗೋ ಅಗತ್ಯ ಇಲ್ಲ. ಯಾಕಂದರೆ ಅಲ್ಟಿಮೇಟ್ಲಿ ಇಟ್ ಈಸ್ ದ ಕೋರ್ಟ್ ವಿಚ್ ಹ್ಯಾಸ್ ಟು ಡಿಸೈಡ್ ಏನಿದೆ ಆ ಕೇಸಲ್ಲಿ ಅನ್ನೋದು ಡಿಸೈಡ್ ಮಾಡುವಂಥದ್ದು ಕೋರ್ಟು. ನಿಮಗೆಲ್ಲರಿಗೂ ಗೊತ್ತಿರಲಿ, ಕೋರ್ಟ್ ಈಸ್ ಎ ನ್ಯೂಟ್ರಲ್ ಪರ್ಸನ್. ಹಾಗಾಗಿ ಯಾರ ಪರವಾಗಿಯೂ ಇರೋದಿಲ್ಲ ಕೋರ್ಟು. ನಿಮ್ಮ ವೈದ್ಯರು ಹೇಳಿದಂತಹ ಎವಿಡೆನ್ಸನ್ನು ನೋಡಿ ಅದನ್ನು ಅಸೆಸ್ ಮಾಡಿ ತಿಳ್ಕೊಳ್ಳುವಂಥದ್ದು ಕೋರ್ಟ್ಗಳಿಗೆ ಬಿಟ್ಟಿರುತ್ತೆ. ಹಾಗಾಗಿ ಡು ನಾಟ್ ಲೂಸ್ ಯುವರ್ ಟೆಂಪರ್. ಆಮೇಲೆ ರಿಟೈನ್ ಇಂಡಿಪೆಂಡೆನ್ಸ್ ಆಫ್ ಯುವರ್ ಮೈಂಡ್, ಬಿ ಹಾನೆಸ್ಟ್, ಇಂಪಾರ್ಷಿಯಲ್, ಅನ್ಬಯಾಸ್ಡ್ ಆ್ಯಂಡ್ ಟ್ರೂತ್ಫುಲ್. ಆಮೇಲೆ ಲಿಸನ್ ಕೇರ್ಫುಲಿ ಟು ದಿಸ್ ಕ್ವಶನ್ಸ್. ಯಾಕೆಂದರೆ ಎಷ್ಟೋ ಜನ ಇವರು ಡಾಕ್ಟರ್ಸು ನನಗೆ ಕನ್ಫ್ಯೂಸ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ ಅಂಥೇಳಿ ಹೇಳೋದನ್ನು ನಾನು ಕೇಳ್ಪಟ್ಟಿದ್ದೀನಿ. ಬಟ್ ದೇ ಆರ್ ಫಾರ್ ದಟ್ ಇದೊಂದು ಡ್ಯೂಟಿ ಓನ್ಲಿ. ಅವ್ರದ್ದು ಬಿಸ್ನೆಸ್ಸೇ ಅದು, ಕನ್ಫ್ಯೂಸ್ ಮಾಡಲಿಕ್ಕೆ ಅಡ್ವೊಕೇಟ್ಸ್ ಇದ್ದಾರೆ. ಬಟ್ ಯು ಶುಡ್ ನಾಟ್ ಬಿ ಕನ್ಫ್ಯೂಸ್ಡ್. ನೀವು ಕನ್ಫ್ಯೂಸ್ ಆಗಬಾರ್ದು. ಲಿಸನ್ ಕೇರ್ಫುಲಿ. ಯಾಕೆಂದರೆ ಅವರ ಪ್ರಶ್ನೆ ಏನು ಕ್ವಶನ್ ಇರುತ್ತೆ ಅದನ್ನು ಕರೆಕ್ಟಾಗಿ ನೀವು ಕೇಳಿಕೊಂಡ್ರೆ ಖಂಡಿತ ನಿಮ್ಮ ಬಳಿ ಉತ್ತರ ಇರುತ್ತೆ. ಹಾಗಾಗಿ ಉತ್ತರ ಆ ರೀತಿ ಕೊಡಬೇಕಾಗತ್ತೆ. ನೆಕ್ಸ್ಟು ಇಫ್ ಯು ಬಿಲೀವ್ ದ್ಯಾಟ್ a question is unfair or that the lawyer is teasing you ಅಂತ ಹೇಳಿ ಅನಿಸಿದ್ರೆ ನೀವು ಅದನ್ನು ಕೋರ್ಟ್ ಗಮನಕ್ಕೆ ತರ್ಬೋದು. ಆವಾಗ ಕೋರ್ಟ್ ವಿಲ್ ಕನ್ಸಿಡರ್ ಇಟ್. ಈ ಹಿಂದೆ ಹೇಳಿದರು ಸ್ಪೀಕರು, ಅಂದರೆ ಕೋರ್ಟ್ಗಳಿಗೆ ಇವರಿಗೆ ಡಾಕ್ಟರ್ಸ್ಗೆ ತುಂಬ ರೆಸ್ಪೆಕ್ಟ್ ಕೊಡುತ್ತೆ ಅಂತ ಖಂಡಿತ. ಯಾಕೆಂತ ಹೇಳಿದರೆ ನಾವು ಯಾವುದೇ ವಿಟ್ನೆಸ್ ಡಾಕ್ಟರ್ಸ್ ಬಂದಿದ್ರೆ ಫಸ್ಟ್ ನಾವು ಅವರದ್ದು ಡಾಕ್ಟರ್ಸ್ ಎವಿಡೆನ್ಸನ್ನೇ ಫಸ್ಟ್ ತೊಗೊಳ್ತೀವಿ. ವಿ ವ್ಯಾಲ್ಯೂ ಯುವರ್ ಟೈಮ್. ಹಾಗಾಗಿ ಫಸ್ಟೇ ನಾವು ಡಾಕ್ಟರ್ಸ್ ಎವಿಡೆನ್ಸನ್ನು ತಗೊಳ್ತೀವಿ, ನೆಕ್ಸ್ಟ್ ಪೊಲೀಸು, ನೆಕ್ಸ್ಟ್ ಯಾರಾದರೂ ಬೇರೆ ಅಫಿಷಿಯಲ್ಸ್, ಆ ರೀತಿ ಇರುವಂಥದ್ದು. ಹಾಗಾಗಿ ನೀವೇನು ಅಂತ ಹೇಳಿದರೆ ಸ್ವಲ್ಪ ಕೆಲವೊಂದು ಕೋರ್ಟ್ ಪ್ರೊಸೀಜರ್ಸ್ ಇರ್ತದೆ. ಯಾಕೆಂದರೆ ನಮ್ಮ ಕಾನೂನು ನಿಂತಿರೋದೇ ಪ್ರೊಸೀಜರ್ಸಲ್ಲಿ. ನಮ್ಮಲ್ಲಿ CRPC ಇತ್ತು, ಅದನ್ನು ಈಗ BNSS ರಿಪ್ಲೇಸ್ ಮಾಡಿದೆ. IPC ಇತ್ತು, ಅದನ್ನು BNS ರಿಪ್ಲೇಸ್ ಮಾಡಿದೆ. ಇಂಡಿಯನ್ ಎವಿಡೆನ್ಸ್ ಆ್ಯಕ್ಟ್ ಇತ್ತು, ಅದನ್ನು BSA ಮಾಡಿದೆ. BSA ಅಂದರೆ ಭಾರತೀಯ ಸಾಕ್ಷ್ಯ ಅಧಿನಿಯಮ ಅಂಥೇಳಿ. ಅದರಲ್ಲಿ ಎಲ್ಲದರಲ್ಲಿಯೂ ಕೂಡ ನಮಗೆ ಪ್ರೊಸೀಜರ್ಸಿಗೂ ಕೂಡ ಸ್ವಲ್ಪ ಸ್ಟ್ರೆಸ್ಸನ್ನು ಕೊಡಲಾಗಿದೆ. ಹಾಗಾಗಿ ಅದನ್ನು ಒಂದು ನೋಡ್ಕೊಳ್ಬೇಕಾಗತ್ತೆ. ನೆಕ್ಸ್ಟು ವಾಚ್ ಫಾರ್ ಡಬಲ್ಸ್ ಕ್ವಶನ್ ಆ್ಯಂಡ್ ಕ್ವಶನ್ಸ್ ದ್ಯಾಟ್ ಇನ್ಕ್ಲೂಡ್ ಆನ್ ಅಸಂಪ್ಷನ್ ಆಫ್ ಫ್ಯಾಕ್ಟ್ಸ್ ವಿಚ್ ಹ್ಯಾವ್ ನಾಟ್ ಬೀನ್ ಪ್ರೂವನ್. ಅಫ್ಕೋರ್ಸ್ ಹೈಪೋಥೆಟಿಕಲ್ಸ್ ಕ್ವಶನ್ಗೆ ಕೋರ್ಟ್ಗಳಲ್ಲಿ ಅವಕಾಶ ಇಲ್ಲ. ಟ್ಯಾಲೆಂಟೆಡ್ ಬಿಯಾಂಡ್ ದ್ಯಾಟ್ ಆಸ್ಕ್ಡ್ ಫಾರ್ ಇನ್ ದಿಸ್ ಕ್ವಶನ್. ಏಕೆಂತ ಹೇಳಿದರೆ ಈ ಏನಾದರೂ ನೀವು ಎಕ್ಸ್ಟ್ರಾ ಹೇಳಕ್ಕೆ ಹೋದ್ರಿ ನಿಮಗೆ ಎಕ್ಸ್ಟ್ರಾ ಕ್ವಶನ್ ಬಿತ್ತು ಅಷ್ಟೇ. ಯಾಕಂದರೆ ಅವ್ರು ಕೇಳಿರ್ತಾರೆ, ಅದಕ್ಕೆ ನೀವು ಎಷ್ಟೇ ಹೇಳಿದರೆ ಬೆಟರ್. ನಮಗೆ ಗೊತ್ತಿದೆ, ನನ್ನ ನಾಲೆಡ್ಜನ್ನೆಲ್ಲ ನಾನು ಇಲ್ಲಿ ಶೇರ್ ಮಾಡಬೇಕು ಅಂತ ನೀವು ಹೊರಟ್ರಿ. ಯಾಕೆಂದರೆ ವಿತ್ ಗ್ರೇಟ್ ರೆಸ್ಪೆಕ್ಟ್, ದೇರ್ ಆರ್ ಸೋ ಇಂಟೆಲಿಜೆಂಟ್ ಅಡ್ವೊಕೇಟ್ಸ್. ನಿಮಗೆ ಗೊತ್ತಿಲ್ಲ, ನೀವು ಈ ಡಾಕ್ಟರ್ಸ್ ನಮ್ಮ ಎಕ್ಸ್ಪರ್ಟೈಸು ನಮ್ಗೆ ಭಾರಿ ನಾಲೆಡ್ಜ್ ಇದೆ ಅಂತ ಅಂದ್ಕೊಂಡಿದ್ರಿ. ಬಟ್ ಅಡ್ವೊಕೇಟ್ಸ್ ಆಲ್ಸೋ ವೆರಿ ಇಂಟೆಲಿಜೆಂಟ್. ಯಾಕೆಂದರೆ ಅವ್ರ ಇಂಟೆಲಿಜೆನ್ಸ್ ಕೋರ್ಟಲ್ಲಿ ಬಂದು ನೋಡಬೇಕು. ದೇ ಆರ್ ವೆರಿ ಇಂಟೆಲಿಜೆಂಟ್. ನಿಮ್ಮನ್ನು ನಿಮ್ಮ ಪ್ರಶ್ನೆ ಒಳಗೆ, ನಿಮ್ಮ ಉತ್ತರದೊಳಗೆ ಸಿಕ್ಕಾಡಿಸಿ ಬಿಡ್ತಾರೆ. ಹಾಗಾಗಿ ನಿಮಗೆ ಆ ಕೇಸಲ್ಲಿ ಎಷ್ಟು ಹೇಳಬೇಕು ಅಂತ ಪಬ್ಲಿಕ್ ಪ್ರಾಸಿಕ್ಯೂಟರ್ ಹೇಳಿರ್ತಾರೋ ಅಲ್ಲಿಗೆ ಫುಲ್ ಸ್ಟಾಪ್ ಹಾಕೋದು ಭಾರಿ ಒಳ್ಳೆಯದು. ನೆಕ್ಸ್ಟ್ ಕ್ರಿಮಿನಲ್ ನೆಗ್ಲಿಜೆನ್ಸ್ ಅನ್ನುವಂಥದ್ದು. ಕ್ರಿಮಿನಲ್ ನೆಗ್ಲಿಜೆನ್ಸ್, ದ ಕ್ವಶನ್ ಆಫ್ ಕ್ರಿಮಿನಲ್ ನೆಗ್ಲಿಜೆನ್ಸ್ ಮೇ ಅರೈಸ್ when a doctor shows gross negligence, gross absence of skill or care during treatment, resulting in serious injury or death of the patient by acts of omission or commission. So when a doctor performs an illegal act, when an assaulted person dies, the defense may attribute the death to the negligence or undue interference in the treatment of the deceased by the doctor. Criminal negligence occurs when the doctor shows gross lack of competency, gross inattention, gross negligence in the selection and application of remedies. ಈಗಾಗಲೇ ವೈದ್ಯರು ಹೇಳಿದ ಹಾಗೆ ಜೋಕಬ್ ಮ್ಯಾಥ್ಯೂ ಕೇಸಲ್ಲಿ ಏನು ಹೇಳ್ತಾರೆ ಅಂತ ಹೇಳಿದರೆ, ಅದರಲ್ಲಿ ಈ ಸಪೋರ್ಟ್ ಸಿಸ್ಟಮ್ ಬ್ರೀತಿಂಗಿಗೆ ಅವರು ಅರೇಂಜ್ ಮಾಡಿರೋದಿಲ್ಲ ಹಾಸ್ಪಿಟ್ಲಲ್ಲಿ. ವೆದರ್ ಇಟ್ ಈಸ್ ಎ ಕ್ರಿಮಿನಲ್ ನೆಗ್ಲಿಜೆನ್ಸ್ ಅನ್ನುವಂತಹ ಪ್ರಶ್ನೆ ಬರುತ್ತೆ. ಆವಾಗ ನೋ ಇಟ್ ಈಸ್ ನಾಟ್ ಎ ಕ್ರಿಮಿನಲ್ ನೆಗ್ಲಿಜೆನ್ಸ್, ಇಟ್ ಮೇ ಬಿ ಎ ಸಿವಿಲ್ ನೆಗ್ಲಿಜೆನ್ಸ್ ಅನ್ನುವಂತಹ ಅಂಶವನ್ನು ಹಾನರಬಲ್ ಸುಪ್ರೀಂ ಕೋರ್ಟ್ ಅವರು ಹೇಳಿದ್ದಾರೆ. ಆಮೇಲೆ ಇನ್ನೊಂದು ಅಂತ ಹೇಳಿದರೆ, ಪರಮಾನಂದ್ ಕಟಾರ ವರ್ಸಸ್ ಯೂನಿಯನ್ ಆಫ್ ಇಂಡಿಯಾ ಕೂಡ ಬಹಳ ಒಂದು ಇಂಪಾರ್ಟೆಂಟ್ ಡಿಸಿಷನ್, ಪ್ರತಿಯೊಬ್ಬರು ಓದ್ಕೊಳ್ಬೇಕು. ಅದರಲ್ಲಿ ಈಗಾಗಲೇ ಡಿಸ್ಕಸ್ ಮಾಡಿದಾಗೆ ಎವ್ರಿ ಇಂಜೂರ್ಡ್ ಪರ್ಸನ್ ಬ್ರಾಡ್ ಫಾರ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಶುಡ್ ಬಿ ಗಿವನ್ medical aid immediately to preserve life, and thereafter the procedural criminal law should be followed ಅಂತೇಳಿ ಹೇಳ್ತಾರೆ. ಯಾಕೆಂತ ಹೇಳಿದರೆ ಆ ಕೇಸಲ್ಲಿ ಅವರಿಗೆ ತುಂಬ ಗಾಯವಾದ ವ್ಯಕ್ತಿಯನ್ನು ಕರ್ಕೊಂಡು ಬಂದಾಗ ಒಂದು ಪ್ರೈವೇಟ್ ಹಾಸ್ಪಿಟಲ್ನವರು ಅವರಿಗೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡಲ್ಲ. ಯಾಕೆಂತ ಹೇಳಿದರೆ ನಮ್ಮದು MLC ಕೇಸಸ್ ಟ್ರೀಟ್ ಮಾಡುವಂತಹ ಹಾಸ್ಪಿಟಲ್ ಅಲ್ಲ ಅನ್ನುವಂತಹ ಒಂದು ಅಂಶವನ್ನು ಎತ್ತಿಟ್ಕೊಂಡು ಅವರು ಡಿನೇ ಮಾಡ್ತಾರೆ. ಅದು ಅವರನ್ನು ಪೇಷಂಟನ್ನು 20 ಕಿಲೋಮೀಟರ್ ದೂರ ಕರ್ಕೊಂಡು ಹೋಗುವಾಗ ಹಿ ಕೊಲಾಪ್ಸಸ್. ಹಾಗಾಗಿ ಆ ಸರ್ಕಮ್ಸ್ಟೆನ್ಸಲ್ಲಿ ಕೋರ್ಟ್ ಏನು ಹೇಳಿದೆ ಅಂತ ಹೇಳಿದರೆ, ನಿಮ್ಮ ಪ್ರೈಮ್ ಡ್ಯೂಟಿ ಇದೆ ಅವರಿಗೆ ಕೊಡುವಂತಹ ಟ್ರೀಟ್ಮೆಂಟ್ ಅನ್ನುವಂಥ ವಿಷಯವನ್ನು ಹೇಳಿದೆ. ಇನ್ನೊಂದು ಮೆಂಟಲ್ ಡಿಸಬಿಲಿಟಿ ಅನ್ನುವಂಥದ್ದು ಬಂದಾಗ ಅಸೆಸ್ಮೆಂಟ್, ಇದು ಒಂದು ಒಬ್ಬರ ಹತ್ರ ಅವರ ಅನುಭವದ ಮಾತನ್ನು ಕೇಳಿ ನಾನು ಹೇಳ್ತಾ ಇರೋದು. ಒಂದು ಕೇಸಲ್ಲಿ ಬಸ್ ಡ್ರೈವರ್ ಕಾಸಸ್ ಆ್ಯನ್ ಆಕ್ಸಿಡೆಂಟ್ ಡ್ಯೂ ಟು ಎಪಿಲೆಪ್ಸಿ, ಅವನಿಗೆ ಫಿಟ್ಸ್ ಅನ್ನೋದು ಬರುತ್ತೆ. ಅವನು ಈ ಕಾಸಸ್ ಆನ್ ಆಕ್ಸಿಡೆಂಟ್, ಅವನಿಗೂ ಗಾಯ ಆಗುತ್ತೆ, ಆಮೇಲೆ ಸೆವೆರಲ್ ಪರ್ಸನ್ಸ್ ಇಂಜೋರ್ಡ್, ಅವ್ರಿಗೂ ಗಾಯ ಆಗಿರುತ್ತೆ. ಆವಾಗ ಅವನ ಮೇಲೆ ಡಿ ಕಂಡಕ್ಟ್ ಮಾಡ್ತಾರೆ. ನಾವು ಕಮ್ಸ್ ದ ಇಂಪಾರ್ಟೆನ್ಸ್ ಆಫ್ ಡಾಕ್ಟರ್. ಈ ಮೆಂಟಲ್ ಡಿಸೆಬಿಲಿಟಿ ಅಂತ ಹೇಳಿ ಬಂದಾಗ ವಾಟ್ ಈಸ್ ದ ಪರ್ಸೆಂಟೇಜ್? ಯಾಕೆಂತ ಹೇಳಿದ್ರೆ ನೀವೆಲ್ಲ ಡಿಸೆಬಿಲಿಟಿ ಅಸೆಸ್ಮೆಂಟ್ ಮಾಡ್ತೀರಿ ಅಲ್ವಾ? ಟಿಬಿಯಾ, ಫಿಬುಲಾ, ಫೀಮರ್, ಪ್ರತಿಯೊಂದೊಂದೊಂದು ಬೋನಿಗೆ ಕೂಡ ನೀವು ಸ್ಕ್ಯಾಪುಲಾ, ಪ್ರತಿಯೊಂದಕ್ಕೂ ನೀವು ಕೊಡ್ತಾ ಹೋಗ್ತೀರಿ ಎಷ್ಟು ದಿಸ್ ಮಚ್ ಆಫ್ ಅಂತ ಹೇಳಿ ಡಿಸೆಬಿಲಿಟಿ ಅಂತೇಳಿ ಅಸೆಸ್ ಮಾಡಿ ಕೊಡ್ತೀರಿ. ಬಟ್ ಮೆಂಟಲ್ ಡಿಸೆಬಿಲಿಟಿ ಎಪಿಲೆಪ್ಸಿ ಅಂತ ಬಂದಾಗ ಅಟ್ ದ್ಯಾಟ್ ಪರ್ಟಿಕ್ಯುಲರ್ ಟೈಮ್, ಈಗ ಎಪಿಲೆಪ್ಸಿ ಅನ್ನೋದು ಒಂದು ಸರ್ಟನ್ ಪಾಯಿಂಟ್ ಆಫ್ ಟೈಮಿಗೆ ಬರುತ್ತೆ. ದ್ಯಾಟ್ ಪಾಯಿಂಟ್ ಆಫ್ ಟೈಮ್ ಇಟ್ ಈಸ್ ಎ 100% ಡಿಸೆಬಿಲಿಟಿ. ಯಾಕೆಂದರೆ ಅವನಿಗೆ ಆ ಕ್ಷಣಕ್ಕೆ ಎಪಿಲೆಪ್ಸಿ ಬಂದಾಗ ಖಂಡಿತ ಅವನ ಕೈಯಿಂದ ಅವನೊಂದು ಡಿಸೇಬಲ್ ಆಗುವಂಥ ಸಾಧ್ಯತೆ ಇದೆ ಅನ್ನುವಂಥದ್ದನ್ನು ಒಂದು ಕೋರ್ಟ್ ನಿರ್ಧಾರ ಮಾಡಿದ್ದು. ಇದು ಒಬ್ಬರು ವಕೀಲರ ಹತ್ರ ನಾನು ಡಿಸ್ಕಸ್ ಮಾಡಿ ಹೇಳಿರುವಂತಹ ಒಂದು ಇನ್ಸ್ಟೆನ್ಸು. ಅದರಲ್ಲಿ ಕೋರ್ಟ್ ಏನು ಹೇಳುತ್ತೆ ಅಂತ ಹೇಳಿದರೆ ಇಟ್ ಹ್ಯಾಸ್ ಟು ಬಿ ಕನ್ಸಿಡರ್ಡ್ ಆ್ಯಸ್ 100% ಡಿಸೆಬಿಲಿಟಿ ಅಂತೇಳಿ. ಇನ್ನೊಂದು ಸ್ನೇಕ್ ಬೈಟ್ ಕೇಸ್, ಇದು ಕೂಡ ಒಂದು ಪ್ರಾಕ್ಟಿಕಲ್ ಆಗಿ ಒಬ್ಬರು ಹೇಳಿದಂಥದ್ದನ್ನು ನಾನು ತಮ್ಮ ಮುಂದೆ ಹೇಳಲಿಕ್ಕೆ ಬಯಸ್ತೇನೆ. ಇಬ್ಬರು ಸಣ್ಣ ಮಕ್ಕಳು ತೀರ್ಕೊಳ್ತಾರೆ. ಮರ್ಡರ್ ಕೇಸ್ ವಾಸ್ ರಿಜಿಸ್ಟರ್ಡ್ ಎಗೇನ್ಸ್ಟ್ ಫಾದರ್. ತಂದೆ ಕೊಲೆ ಮಾಡಿದ್ದಾನೆ ಅಂತ ಹೇಳಿ ಕೇಸ್ ರಿಜಿಸ್ಟರ್ ಆಗುತ್ತೆ. ಬಟ್ ಪೋಸ್ಟ್ ಮಾರ್ಟಮ್ ರಿಪೋರ್ಟ್ ಅಲ್ಲಿ ಮೆನ್ಷನ್ ಆಗುತ್ತೆ ದ ಚಿಲ್ಡ್ರನ್ ಡೈಡ್ ಡ್ಯೂ ಟು ಸ್ನೇಕ್ ಬೈಟ್ ಅನ್ನುವಂಥದ್ದು ಮೆನ್ಷನ್ ಆಗುತ್ತೆ. ಸೊ ಕೋರ್ಟ್ನಲ್ಲಿ ಎವಿಡೆನ್ಸ್ ನಡೀತದೆ. ಕೋರ್ಟು ದಾಖಲೆಗಳನ್ನೆಲ್ಲ ಅನಲೈಸ್ ಮಾಡಿ ಕೋರ್ಟ್ಸ್ ಕ್ವಶನನ್ನು ಕೇಳ್ತಾರೆ. ಅಂದರೆ ಇದು ಒಬ್ಬರು ಜಡ್ಜ್, ಲೇಟರ್ ಹಿ ಬಿಕೇಮ್ ಹೈಕೋರ್ಟ್ ಜಡ್ಜ್, ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಜಡ್ಜ್ ಆಗಿದ್ರು ಹಾಸನಲ್ಲಿ, ಜಸ್ಟಿಸ್ ಆನಂದ್ ಅಂತ. ಹಿ ಈಸ್ ನೋ ಮೋರ್ ನೌ. ಅವರು ಕೇಳಿದಂತಹ ಇದು ಪ್ರಶ್ನೆ. ಅವರು ಕೇಳ್ತಾರೆ ದ ಟೈಮ್ ಗ್ಯಾಪ್ ಬಿಟ್ವೀನ್ ದ ಡೆತ್ ಆಫ್ ಒನ್ ಚೈಲ್ಡ್ ಟು ಅನದರ್ ಚೈಲ್ಡ್ ಎಷ್ಟು ಅನ್ನುವಂಥದ್ದು. ಆವಾಗ ಇಟ್ ವಾಸ್ ಓನ್ಲಿ 5 minutes ಅಂತ ಹೇಳಿ ಮೆನ್ಷನ್ ಆಗಿರುತ್ತೆ PM ರಿಪೋರ್ಟಲ್ಲಿ. ಆವಾಗ ಕೋರ್ಟ್ ಪುಟ್ಸ್ ಎ ಕ್ವಶನ್ ಟು ದ ವಿಟ್ನೆಸ್, ವಾಟ್ ಈಸ್ ದ ಟೈಮ್ ಟೇಕನ್ ಫಾರ್ ರೆಸ್ಟೋರೇಷನ್ ಆಫ್ ವೆನಮ್, ಪಾಯ್ಸನ್ ಏನಿದೆಯಲ್ಲ ಹಾವಿನಲ್ಲಿ, ಇನ್ ದ ಸ್ನೇಕ್ಸ್ ಆಫ್ಟರ್ 1 bite ಅನ್ನುವಂಥದ್ದು. ಆವಾಗ ದ ಆನ್ಸರ್ ವಾಸ್ ಗ್ರ್ಯಾಜುವಲಿ ಆಫ್ಟರ್ 4 to 6 hours ಆಫ್ 1 bite ವೆನಮ್ ವಿಲ್ ಬಿ ರೆಸ್ಟೋರ್ಡ್ ಇನ್ ದ ಸ್ನೇಕ್ ಅಂತೇಳಿ ಅದನ್ನೆಲ್ಲ ಅಸೆಸ್ ಮಾಡಿ ಆ ಒಂದು ಪರ್ಟಿಕ್ಯುಲರ್ ಕೇಸಲ್ಲಿ ಹಾನರಬಲ್ ಜಸ್ಟಿಸ್ ಆನಂದ್ ಅವರು ಆವಾಗ ಪ್ರಿನ್ಸಿಪಲ್ ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಜಡ್ಜ್ ಹಾಸನ್ ಇದ್ದರು. ದೆನ್ ಹಿ ಲೇಟರ್ ಬಿಕೇಮ್ ಹೈಕೋರ್ಟ್ ಜಡ್ಜ್. ಅವರು he disbelieved the post-mortem report and convicted the accused for murder. ಇದನ್ನು ನಾನು ಯಾಕೆ ಹೇಳ್ತೀನಿ ಅಂತ ಹೇಳಿದರೆ ಪ್ರತಿಯೊಂದನ್ನು ಕೂಡ ಅಸೆಸ್ ಮಾಡಬೇಕಾಗುತ್ತೆ. ಯಾಕೆಂದರೆ ಟೈಮ್ ಟೇಕನ್, ಎಷ್ಟು ಗ್ಯಾಪ್ನ ನಡುವೆ ಅವು 2 ಮಕ್ಕಳ ಡೆತ್ ಆಗಿದೆ ಅನ್ನೋದು ಕೂಡ ಇಂಪಾರ್ಟೆಂಟ್ ಆಗುತ್ತೆ. ನಂತರ ಇನ್ನೊಂದು ಈ ಒಂದು ಸಣ್ಣ ಕಥೆಯನ್ನು, ಇನ್ನೊಂದು ಕಥೆಯನ್ನು ಹೇಳಿ ನಾನು ನನ್ನ ಮಾತನ್ನು ಮುಗಿಸ್ತೇನೆ. ಅಂದು ಇದೊಂದು ವೈದ್ಯರೇ ದಾಖಲಿಸಿದಂತಹ ಕತೆ, ಮಡಿಕೇರಿದ್ದೆ. ಅಂದು ರಾತ್ರಿ ಮತ್ತೊಮ್ಮೆ ಮಡಿಕೇರಿಯಲ್ಲಿ ಗುಂಡಿನ ಸದ್ದು. ದೊಡ್ಡ ಮರದ ವ್ಯಾಪಾರಿಯೊಬ್ಬರು 10 ಗಂಟೆಯ ಸಮಯದಲ್ಲಿ ಮನೆಯ ಗೇಟಿನ ಬಳಿ ಯಾರೋ ಹಾರಿಸಿದ ಗುಂಡಿಗೆ ಬಲಿಯಾಗಿ ಮರಣ ಹೊಂತಾರೆ. ಗುಂಡೇಟಿನ ಪ್ರಕರಣದಲ್ಲಿ ಗುಂಡು ಇದೆ ಅಂತ ಹೇಳಿ ಎಕ್ಸ್ರೇ ತೆಗೆದು ನೋಡಿದಾಗ ಗೊತ್ತಾಗತ್ತೆ ಎದೆಯ ಎಡಭಾಗದಲ್ಲಿ ಮತ್ತು ಎಡತೊಡೆಯಲ್ಲಿ ಸೀಸದ ವಸ್ತುಗಳು ಕಂಡು ಬಂದಿತ್ತು. ಶವ ಪರೀಕ್ಷೆ ಮಾಡುವ ಸಮಯದಲ್ಲಿ ಹುಡುಕಿದಾಗ ಅವು ಸಿಕ್ಕಲ್ಲ. ವೈದ್ಯರು ಪ್ರಯತ್ನ ಪಡ್ತಾರೆ, ಆದರೆ ಅವು ಸಿಕ್ಕಲ್ಲ. ಆದರೆ ಎಕ್ಸ್ರೇಲಿ ಹೇಗೂ ಕಾಣ್ತಾ ಇದೆ ಅಂಥೇಳಿ ಅದನ್ನೇ ಸಾಕ್ಷಿಯಾಗಿ ಕೊಟ್ಟು ಹೊಲಿಗೆ ಹಾಕ್ಬಿಡ್ತಾರೆ. ನಂತರ ಅವರ ಪದ್ಧತಿಯ ಪ್ರಕಾರ ಆ ಒಂದು ಡೆಡ್ ಬಾಡಿಗೆ ಸೂಟು, ಬೂಟು, ಕೋಟು ಎಲ್ಲ ಹಾಕಿ ಮರದ ಪೆಟ್ಟಿಗೆ ಒಳಗೆ ಇಟ್ಟು ಉಪ್ಪು ಹಾಕಿ ಆಳದ ಗುಂಡಿ ತೋಡಿ ಮಣ್ಣು ಮಾಡ್ತಾರೆ. ಆ ಬಗ್ಗೆ ಪ್ರಕರಣ ಕೂಡ ದಾಖಲಾಗುತ್ತೆ. ಕೆಲವು ದಿನಗಳ ಬಳಿಕ ಕೋರ್ಟ್ನಲ್ಲಿ ಕೇಸ್ ಪ್ರಾರಂಭ ಆಗುತ್ತೆ. ಆದರೆ ನ್ಯಾಯಾಧೀಶರು ಸಾರಾಸಗಟಾಗಿ ಪೊಲೀಸರ ಕೇಸನ್ನು ಒಪ್ಪೋದಿಲ್ಲ. ಯಾಕೆ ಅಂತ ಹೇಳಿದರೆ ಬುಲೆಟ್ ಇಲ್ಲದ ಮೇಲೆ ಒಂದು ರಿವಾಲ್ವರ್ನಿಂದ ಗುಂಡು ಹಾರಿದೆ ಅಂತ ಹೇಳಲಿಕ್ಕೆ ಸಾಧ್ಯ ಇಲ್ಲ. ಸೊ ಫೊರೆನ್ಸಿಕ್ ರಿಪೋರ್ಟನ್ನು ತರಿಸಿ ಅಂತೇಳಿ ಹೇಳ್ತಾರೆ. ಈಗಾಗಲೇ 1 ವರ್ಷ ಕಳೆದಿತ್ತು, ಇಷ್ಟೆಲ್ಲ ಆಗಬೇಕಾದ್ರೆ 1 ವರ್ಷ ಕಳೆದಿತ್ತು. ಶವವನ್ನು ಮಣ್ಣಲ್ಲಿ ದಫನ್ ಮಾಡಿ ಆಗಿತ್ತು. ಮಳೆಗಾಲ ಕಳೆದಿತ್ತು. ಮಡಿಕೇರಿ ಮಳೆ ಗೊತ್ತಿದೆ ನಿಮಗೆ, ಮಳೆಗಾಲ ಕಳೆದಿತ್ತು. ಆದರೆ ಸಿಕ್ಕದಿರುವ ಬುಲೆಟ್ ಬೇಕಾದರೆ ಶವವನ್ನು ಹೊರಗೆ ತೆಗೆಯಲೇಬೇಕಾಗಿತ್ತು. ಕೋರ್ಟ್ನ ಆದೇಶದ ಮೇರೆಗೆ ಮರಣೋತ್ತರ ಪರೀಕ್ಷೆಗೆ ಅರ್ಜಿ ಕೊಟ್ಟರು. ನಿಯಮಾನುಸಾರ ಶವವನ್ನು ತಹಶೀಲ್ದಾರ್ ಸಮಕ್ಷಮದಲ್ಲಿ ಹೊರತೆಗೆಯಲಾಯಿತು. ಶವವನ್ನು ನೋಡಿದ ಎಲ್ಲರಿಗೂ ಆಶ್ಚರ್ಯವೇ ಆಶ್ಚರ್ಯ. 1 ವರ್ಷದ ಹಿಂದೆ ಹೂತಿದ್ದ ಶವ ಕೊಳತು ಮಣ್ಣಿನೊಂದಿಗೆ ಬೆರೆತು ಹೋಗಿರಬೇಕು ಅಂತ ಹೇಳಿ ಯೋಚಿಸಿದ ಜನರಿಗೆ ಒಂದು ಶಾಕ್ ಆದಿತ್ತು. ಶವವನ್ನು ಸರಿಯಾಗಿ ಮುಚ್ಚಿ ಉಪ್ಪು ಹಾಕಿ ಗಾಳಿ ಸೇರದಂತೆ ಮಾಡಿದರೆ ಅದು ಕೊಳೆಯದೆ ಸಪೋನಿಫಿಕೇಶನ್ ಎಂಬ ಸ್ಥಿತಿಗೆ ಹೋಗಿ ಅನೇಕ ವರ್ಷ ಹಾಗೆ ಇರುತ್ತದೆ ಅಂತ ಹೇಳಿ ಆ ಲೇಖಕರು ದಾಖಲಿಸಿದ್ದಾರೆ. ಅದ್ರ ಬಗ್ಗೆ ನೀವೇ ನನಗೆ ಗಮನಕ್ಕೆ ತರಬೇಕು. ಯು ಹ್ಯಾವ್ ಟು ಎಕ್ಸ್ಪ್ಲೇನ್ ಮಿ. ಬಟ್ ಅದನ್ನು ಬರೆದಿದ್ದಾರೆ. ಗುಂಡಿಯಲ್ಲಿ ಮೊದಲು ವೈದ್ಯರ ಸಹಾಯಕ ಇಳಿಯುತ್ತಾರೆ. ಹಾಕಿದ್ದ ಹೊಲಿಗೆ ಬಿಚ್ಚಿ ಒಳಗೆ ನೋಡ್ತಾರೆ. 5 ನಿಮಿಷ ಆಯಿತು, 10 ನಿಮಿಷ ಆಯಿತು, ಅರ್ಧ ಗಂಟೆ ಆಯಿತು, ಗುಂಡು ಮಾತ್ರ ಸಿಗ್ತಾ ಇಲ್ಲ ಬಾಡಿಯಲ್ಲಿ. ಎಕ್ಸ್ರೇಯಲ್ಲಿ ಗುಂಡಿನಂತೆ ಕಾಣುವ ವಸ್ತು ಇದೆ, ಆದರೆ ಶರೀರದಲ್ಲಿ ಸಿಗ್ತಾ ಇಲ್ಲ. ವೈದ್ಯರಿಗೆ ಹೆದರಿ ಬೆವರು ಬಂತು. ಅಷ್ಟರಲ್ಲಿ ಜನ ಆಳಿಗೊಂದರಂತೆ ಮಾತನಾಡಲಿಕ್ಕೆ ಶುರು ಮಾಡ್ತಾರೆ. ಗುಂಡೇನು ಇರಲಿಲ್ಲ, ಸುಮ್ಮನೆ ಮೇಜಿನ ಮೇಲೆ ಇಟ್ಟು ಶವದೊಂದಿಗೆ ಎಕ್ಸ್ರೇ ತೆಗೆದರು ಅಂತ ಒಬ್ರು ಹೇಳ್ತಾರೆ. ಇನ್ನೊಬ್ಬ ಹೇಳ್ತಾನೆ, ಎಕ್ಸ್ರೇಗೆ ಹೋಗಿ ಬರುವಾಗ ದಾರಿಯಲ್ಲಿ ಎಲ್ಲಾದರೂ ಗುಂಡು ಬಿದ್ದು ಹೋಗಿರ್ಬೇಕು. ಇನ್ನೊಬ್ಬ ಹೇಳ್ತಾನೆ, ಅದು ಗುಂಡಲ್ಲ, ಹೆಪ್ಪುಗಟ್ಟಿದ ರಕ್ತ ಅಂತೇಳಿ. ಮತ್ತೊಬ್ಬ ಹೇಳ್ತಾನೆ, ಗುಂಡು ಕೊಳೆತು ಮಣ್ಣಿನ ಒಳಗೆ ಬೆರೆತು ಹೋಗಿರ್ಬೇಕು ಅಂತೇಳಿ. ಗಾಬರಿಯಿಂದ ಬೆರೆತು ಹೋಗಿದ್ದ ಡಾಕ್ಟ್ರಿಗೆ ಆಗ ನೆನಪಾಗಿದ್ದು ವಿಮಾನ ನಿಲ್ದಾಣದಲ್ಲಿ ಉಪಯೋಗಿಸುವ ಮೆಟಲ್ ಡಿಟೆಕ್ಟರ್. ನಮ್ಮ ಮೈಯಲ್ಲಿ ಯಾವುದೇ ಕಬ್ಬಿಣದ ಅಂಶ ಇದ್ದರೆ ಅದು ಪೀಮ್ ಪೀಮ್ ಅಂತೇಳಿ ಶಬ್ದ ಮಾಡುತ್ತೆ, ಹೌದಾ? ಅದನ್ನು ಪೊಲೀಸರಿಂದ ತರಿಸಿಕೊಡಿ ಅಂತೇಳಿ ಅವರು ಹೇಳ್ತಾರೆ. ಆವಾಗ ಪೊಲೀಸರು ಯಾರೋ ಒಬ್ಬರನ್ನ ಬೈಕ್ನಲ್ಲಿ ಕಳಿಸಿಕೊಡ್ತಾರೆ. ಇನ್ನು ಅವರು ಬರೋದಕ್ಕೆ ಸಮಯ ಆಗುತ್ತಲ್ಲ, 1 ಗಂಟೆ ಆದರೂ ಬೇಕಾಗುತ್ತೆ ಅಂಥೇಳಿ ಈ ವೈದ್ಯರೇ ಗುಂಡಿಗೆ ಇಳಿತಾರೆ. ಗ್ಲೌಸ್ ಹಾಕಿ ಇಡೀ ಶರೀರದ ಒಳಗೆ ಅಲ್ಲಿ ಇಲ್ಲಿ ತಡ್ಕಾಡ್ತಾರೆ. ಒಮ್ಮೆಗೆ ಚಿರುಕ್ ಅಂತ ಹೇಳಿ ಅವರ ಕೈ ಬೆರಳಿಗೆ ಏನೋ ಚುಚ್ಚಿದಂತಾಗುತ್ತದೆ. ಪೆಟ್ಟಿಗೆಯಲ್ಲಿ ಹಾಗೇನಾದ್ರು ಸೇರ್ಕೊಂಡಿದ್ಯಾ ಅಂತೇಳಿ ಅವ್ರಿಗೆ ಸ್ವಲ್ಪ ಭಯ ಆಗಲಿಕ್ಕೆ ಶುರು ಆಗುತ್ತೆ. ನಂತರ ನಿಧಾನವಾಗಿ ಪುನಃ ಎಗೇನ್ ಅದೇ ಜಾಗಕ್ಕೆ ಅವರು ಕೈಯನ್ನು ತೆಗೆದುಕೊಂಡು ಹೋಗಿ ನೋಡಿದಾಗ ಚೂಪಾದ ವಸ್ತು ಏನು ಅಂದರೆ ಮುರಿದಿದ್ದ ಬೆನ್ನಿನ ಹಿಂಭಾಗದ ಅಗಲವಾದ ಸ್ಕ್ಯಾಪುಲಾ ಬೋನ್ ನಲ್ಲಿ ತೂತು. ನಂತರ ಶವವನ್ನು ತಿರುಗಿಸಿದಾಗ ಶವವನ್ನು ಅವರು ತಿರುಗಿಸ್ತಾರೆ. ಆ ವೈದ್ಯರಿಗೆ ಬೇಕಾಗಿದ್ದ ಗುಂಡು ಸಿಗುತ್ತೆ, ಆಗ ಅವರಿಗೆ ಸಿಗುತ್ತೆ. ಆಗಿದ್ದು ಇಷ್ಟೇ, ಎದೆಯಿಂದ ಹೋದ ಗುಂಡು ಹಿಂಭಾಗದ ಸ್ಕ್ಯಾಪುಲಾ ಒಳಗೆ ತೂತು ಮಾಡಿ ಹೊರಗೆ ಹೋಗಲು ಸಾಧ್ಯವಾಗದೆ ಬರೀ ಚರ್ಮದ ಕೆಳಗೆ ಸಿಕ್ಕಿ ಹಾಕಿಕೊಂಡಿತ್ತು. ಆದರೆ ಯಾರೂ ಬೆನ್ನಿನ ಮೇಲೆ ಕೈ ಹಾಕಿ ಸವರಲಿಲ್ಲ. ಸವರಿದ್ರೆ ಅವರಿಗೆ ಆಗಲೇ ಆ ಗುಂಡು ಸಿಗ್ತಾ ಇತ್ತು. ಇದನ್ನು ಅವರು ಯಾಕೆ ಹೇಳಿದರು ಅಂತ ಹೇಳಿದರೆ, ಯಾವುದೇ ಒಂದು ವಿಷಯವನ್ನು ಕಲಿಯುವುದಕ್ಕೆ ಕೊನೆ ಅನ್ನೋದಿಲ್ಲ. ಹಾಗಾಗಿ ಈಚ್ ಆ್ಯಂಡ್ ಎವ್ರಿ ಡೇ ವಿ ಆರ್ ಸ್ಟೂಡೆಂಟ್ಸ್. ನಿಮ್ಮಿಂದನೂ ಕೂಡ ನಾವು ಕಲಿಬೇಕು, ನಮ್ಮಿಂದನೂ ಕೂಡ ನೀವು ಕಲಿಬೇಕು. ಪ್ರತಿದಿನವೂ ಕಲಿತಾನೆ ಇರಬೇಕಾಗತ್ತೆ. ನಾವೆಲ್ಲರೂ ಮಾಡುವಂತಹ ಕೆಲಸ ಒಂದು ಕಾಯಕವೇ ಕೈಲಾಸ ಅಂತ ಹೇಳಿ. ಯಾಕೆಂದರೆ ನಮ್ಮದು ಡಿಸ್ಪೆನ್ಸೇಷನ್ ಆಫ್ ಜಸ್ಟಿಸ್ ನಿಲ್ಲಬೇಕು. ಒಂದು ಸಮಾಜ ಪ್ರತ್ಯೇಕವಾಗಿ ವೈದ್ಯರಿಗೆ ಒಂದು, ನ್ಯಾಯಾಧೀಶರಿಗೆ ಒಂದು ಅಂತ ಇಲ್ಲ. ನಾವೆಲ್ಲರೂ ಈ ಸಮಾಜದ ಒಂದು ಭಾಗ. ನಮ್ಮೆಲ್ಲರ ಉದ್ದೇಶ ಅಂತ ಹೇಳಿದರೆ ತಪ್ಪಿತಸ್ಥರಿಗೆ, ಯಾರ್ಯಾರು ತಪ್ಪು ಮಾಡಿದಾರೆ ಅವ್ರಿಗೆ ಶಿಕ್ಷೆ ಆಗಬೇಕು, ಅಮಾಯಕರಿಗೆ, ಯಾರ್ಯಾರು ಇನ್ನೋಸೆಂಟ್ ಇದ್ದಾರೆ ಅವರು ಆ ಒಂದು ಸಂಕಷ್ಟದಿಂದ ಪಾರಾಗಬೇಕು. ನಮ್ಮೆಲ್ಲರ ಬಯಕೆ ಒಂದೇ, ನಿಮ್ಮದು ಕೂಡ ನಮ್ಮದು ಕೂಡ ಒಂದೇ, ಒಂದು ಸ್ವಸ್ಥ ಸಮಾಜ. ಹಾಗಾಗಿ ಮಾನ್ಯ DVG ಅವರು ಒಂದು ಮಾತನ್ನು ಹೇಳ್ತಾರೆ, ಸಾಮಾನ್ಯ ರೂಪದಲ್ಲಿ ಸಂಸಾರಿ ವೇಷದಲ್ಲಿ ಸ್ವಾಮಿ ನಿನ್ನೆಡೆಗೆ ಬರಬಹುದು ವರ ನೀಡಿ, ಮೈಮೆ ಕಾಂಬುಡ ನಿನಗೆ ಸಂಸ್ಕಾರವಿರಬೇಕು, ತಾಮಸಿಗೆ ವರವೆಲ್ಲಿ ಮಂಕುತಿಮ್ಮ ಅಂತೇಳಿ. ಹಾಗಾಗಿ ನಾವು ಪ್ರತಿಯೊಬ್ಬರೂ ಕೂಡ ನಮ್ಮ ಜೊತೆ ಕೆಲಸ ಮಾಡುವವರು ಒಂದು ದೈವ ಸ್ವರೂಪಿಯಾಗಿ ಬರ್ತಾರೆ, ನಮ್ಮನ್ನು ಹರಿಸ್ತಾರೆ.
Asks, what is the difference between the findings of cause of death in particular patient is you should look after the number of bites which the person has sustained. Okay? And number two, there will be 2 fang marks. Majority of the people say that. And we doctors, experienced doctors also search for fang marks. But while searching the fang marks, we should see the distance between the 2 fangs, number 1. And number 2, sometimes we find only 1 fang mark. Because if the snake bites over here, if it bites like that, this fang will misses. Or it may be multiple times. You may not see even number of fang marks. So 2, 4, 6 may be there, or 1, 2, 3, 4, 5, depending upon the permutation and combination. These questions will definitely confuse in KODAGU. As we take radiographs in different positions, for example, AP and lateral positions we take for chest. Or normally in medicine we go for chest X-ray, PA and lateral. Similarly, if we take the X-ray of the dead body in different angles, we can definitely make it up. The person during the first postmortem examination has taken the X-ray AP, IV. So in that, the X-ray shows that the bullet was at the center of the chest or lateral of the chest. But if the same person's X-ray has been taken in a lateral view, definitely it could have given a wonderful thing that the skin, just beneath the skin or at the scapula we can find out. So whenever we are taking the radiographs of the dead body, be careful. Virtual autopsy. Virtual autopsy is coming, but one drawback is, as the court of law expects the time since injury and manner of death, both cannot be explained in virtual autopsy. So virtual autopsy only can tell that depth and what are all the types of lacerations or soft tissue injuries can be detected as this one. But time since the injury has occurred cannot be detected. So it is better to take multiple views in.
ಬಟ್ ಅದಲ್ಲ, ಯಾಕೆಂದ್ರೆ ಮೆಂಟಲಿ ಪರ್ಸನ್ಸ್ಗೆ ಒಂದು 4 ಗೋಡೆ ಒಳಗೆ ಬಾಗಿಲು ಹಾಕಿ ತಕ್ಷಣ ಅವ್ರು ಕ್ಯೂರ್ ಆಗಲ್ಲ. ಒಂದು ಕ್ಯೂರ್ ಆಗ್ಬೇಕಂತ ಹೇಳಿದ್ರೆ ಅವರಿಗೆ ಒಂದು ಮುಕ್ತವಾದ ವಾತಾವರಣ ಬೇಕಾಗ ಅವರು ಸುರೇಶ್ ಇಲ್ಲ. ಆದ್ರೆ ಕೆಲವೊಂದು ಎಕ್ಸೆಪ್ಷನ್ಸ್ ನಿಮ್ಗೆ ಗೊತ್ತಿದೆ, ಕೆಲವೊಂದು ಗ್ರಾಸ್ ನೆಗ್ಲಿಜೆನ್ಸ್ ಇರುತ್ತೆ. ಡಾಕ್ಟರ್ಸ್ ಅನ್ನ ಖಂಡಿತ ಲ್ಯಾಬಲ್ ಮಾಡಲ್ಲ, ಯಾಕಂದ್ರೆ ಡಾಕ್ಟರ್ಸ್ಗೆ ಏನ್ ಹೇಳ್ತಾರೆ ಅವ್ರು ಅದನ್ನ ಬರೀತಾರೆ. ಡಾಕ್ಟರ್ಸ್ಗೆ ಆವಾಗಲೇ ಗೊತ್ತಾಗತ್ತೆ, ಆಶಾ ಕಾರ್ಯಕರ್ತರು, ಅಂಗನವಾಡಿ ಅವರು ನೆಕ್ಸ್ಟ್ ಬಂದಾಗ ಡಾಕ್ಯುಮೆಂಟ್ಸ್ ವೆರಿಫಿಕೇಶನ್ ಆದಾಗ ಬರ್ತಾರೆ. ಎಷ್ಟೋ ಕೇಸಸ್ ಅಲ್ಲಿ ತಾಯಿ ಕಾರ್ಡ್ ಎಲ್ಲ ಇಶ್ಯೂ ಆಗಿರುತ್ತೆ, ತುಂಬಾ 7-8 ತಿಂಗಳು ಆಗೋಗಿರುತ್ತೆ.
Now, as a token of gratitude, I request our chairpersons to kindly give the token of gratitude to our speaker, Srimati Shubha, the senior. May I call upon Dr. Anand.
Dr. Kripalini, Professor and HOD in the Department of Ophthalmology, KODAGU Institute of Medical Sciences, MEDICAL.
Also carries important legal and ethical implications. A question worth reflecting on is how often do we pause to consider whether what is clinically appropriate is also legally sound? To enlighten us on this crucial interface between law and medicine, it is my privilege to introduce Mr. K.P. Balasubramanya sir, one of the senior advocate of KODAGU and most respected member of the legal fraternity. Sir is a leading advocate of KODAGU with an illustrious legal career spanning nearly 5 decades, having commenced practice in 1976. He holds qualifications in BSc, LLB and MA, reflecting a strong academic foundation. He has been a valued legal advisor to our institute and an esteemed member of our institutional ethics committee, guiding us with clarity and wisdom. A noted author, he has published several books in Kannada and has made significant contributions through the Kannada Sangha of KODAGU.
That too, hungry minds may not work too much. But still, I feel it's my duty to speak a few things on the subject. Medicine and law is a huge topic. I don't think I can confine it to 20 minutes or 30 minutes or even 3 hours. Yes, I am in the bar for 50 years. This is the 50th year of my practice. And I have come across a lot of civil and criminal cases. In fact, I have conducted hundreds of sessions cases. Now I have given up, especially after the increase in POXO, rape, ganja, this, that and other things in the society. I felt, yes, as a senior member of the bar, I should have some moral attitude. And fortunately, I am also on the ethics committee of this institution. It has taught me a lot of things, do's and don'ts. After all, what is law? Do's and don'ts, as Madam Judge said. It will tell you what to say, what not to say, and other things. What is above medicine, medical world? Some problem in talking also. So, these are things which we should know. After all, why should doctors know law? We had 2 very useful discourses from Madam and earlier to that, some doctors. Whether you like it or not, law is around you. You are a good doctor, you park it on the wrong side, police will come and say, he will drive a challan. You can't say, I am a good doctor, patients love me, I am very respected, I was the governor of this club, that club, all these things. No, it won't work. But that moment you are an accused. And you receive a summons to give evidence. You can't say, I have an important case. Yes, it may be adjourned by hours, but courts will not care for that. Maybe on humanitarian grounds, a judge might allow you to come on a different date, but you can't take it for granted. Then you come to the court and you have not read the file, and you say, no, I have not read it. No, it is your duty to do it. And don't give more strain to the courts by stating I have not gone through this. These are simple examples I am saying, but this will not make up my subject as such. Because doctors and lawyers, however good they may be in their respective professions, if they are not useful citizens to the society, all that education is zero. Therefore, lawyers should know medicine and doctors should know law. This is where the point will meet. Both should meet. On legal and medical report, in fact, I once stopped at ETRC for some time, and I had an occasion to speak to one Mr. Ram Sharan Sharma, who later became the Speaker of Madhya Pradesh Assembly. He was both MBBS and LLB. And mind you, he had a clinic in his house. Later, I think he must have closed it. And there were patients, there were clients. He was not practicing, but a lot of people would come to him for legal advice. He had 2 chambers, one for clients, one for patients. And when we went there, he said, let them wait, we'll have a good breakfast, and we had it. Probably, that may be a rare case, may not be common. But you find a lot of people, even after retirement, they study one of these things. A person can become a doctor any time, but I don't know how because nobody says ignorance of medicine is no excuse, but everyone says ignorance of law is no excuse. We are supposed to know law. There are a lot of things we do not know, but we should ask someone and seek guidance. Now, the subject, as I said, it is totally out of syllabus. There is no prescribed text for the subject what I am talking. But we should know what a doctor, in fact, madam covered a lot of subjects. In fact, when I was given this assignment, I didn't see the assignment preceding my talk. I was about to talk about how to give evidence, then various other things. I'll confine to a few things. What a doctor should study. First of all, the best thing for you to do is to listen to him. It is said, the best conversationalist is one who listens most. We do follow it. If a client comes, he speaks for half an hour, I just listen. And he says, in fact, I didn't talk. He only spoke. But he feels that there was a communication between him and the client. Similar is the case with the patient, between a patient and a doctor. If you have no patience, I know of a doctor who is no more now. He was saying, see that? Well, no doubt, he treated him, but the way he put it was funny. See, these are things, quite antidotes. But a doctor should be first a good human being, should have a sense of empathy to say, see, if I were in his place, what would have been my situation? We had a good judge, a session judge in MADIKERI, who would always say, I always put myself in the accused box and study the case. It is easy to say, when an accused was unable to stand in the witness box, he said, sir, can I sit? This was one of the judges who spoke to him. Immediately I got up and said, probably at the cost of some Edwards orders, I said, friendly. I said, it's meant for all. Similar is the situation in the hospital. When a person comes, he comes with the maximum belief that yes, here is a God, here is somebody who will treat me. In fact, the saying, Vaidyo Narayana Hari, we all think, Vaidyaru Devuru, Allah. The saying is, Vaidyo Narayana Hari, at the time of your death, it is only God who can save you. God is the only doctor. Gange Tirtha ಅಂತ ಹೇಳ್ತಾರೆ. ಔಷಧಂ ಜಾಹ್ನವಿ ತೋಯಂ ವೈದ್ಯೋ ನಾರಾಯಣ ಹರಿ ಅಂದರೆ ಸಾಯ್ಲಿಕ್ಕಾಗೋ ನಿಮಗೆ ಗಂಗೆ ನೀರು ಬಿಟ್ಟರೆ ಯಾವುದೋ ಔಷಧಿ ಇಲ್ಲ, ಅದ್ರಲ್ಲಿ ಬದುಕ್ತೀರಿ ಇಲ್ಲ ಸಾಯ್ತೀರಿ. ಹಾಗೆಯೇ ಆ ಸಮಯದಲ್ಲಿ ದೇವರು ವೈದ್ಯರಾಗಬೇಕೇ ವಿನಃ ನಿಮಗೆ ಇನ್ನೇನು ಮಾಡಲಿಕ್ಕೆ ಆಗೋದಿಲ್ಲ. ಇಟ್ ಇಸ್ ನಾಟ್ ದಿ ಅದರ್ ವೇ, ಬಟ್ ಹೌಎವರ್ ವಿ consider this. The exact meaning is that God alone is the ultimate doctor, and Ganga, whatever it is, Tirtha, that is the ultimate medicine. Otherwise, I don't think with the attitude. That also, never underestimate an advocate. That's sophisticated technical terms. And some people may not know. But we advocates, over the years, we also study something of law, various other things, especially how much blood is lost before a person dies, or what is the requirement or quantity of blood loss to die. It is not negligence. Somebody was apprehensive about the fact. There is a decision of 1995 or 1985, I don't remember, that is Kulkarni's statement. The surgeon of Puttur, D. Krishna Prasad, I remember his name, he is a surgeon of 15 years experience. And a lady came for cesarean delivery or something like that. And he had to get the anesthesia from Mangalore. Then there were no anesthesias in Puttur. Being a surgeon, he applied anesthesia and conducted the surgery. Unfortunately, she died. And more unfortunately, she happened to be the wife of a sub-inspector in Puttur. Immediately the doctor was dragged to the police station. Probably any other person, police would not have acted so swiftly. He was taken and put in a lock. Immediately the entire medical world of Puttur went and stayed dharana and spoke to him then, and he was released. And the police filed a charge sheet because they had to, because the person deceased was.
Pain and palliative care therapist, member mediation cell, Dharwad district, consumer court, medical journalist, and sexual medicine therapist. Other than that, medical graduation, he has done plenty of other degrees also. LLB and LLM, MBA, Hospital Administration, MA, Journalism, Mysore University, and Postgraduate Medical Legal Systems, Postgraduate Medical Law Ethics, and Certificate in Dispute Management, and Fellowship and Fellow Indian Academy of Medical Specialties. Here I am introducing Dr. Shivkumar.
Advocate. For advocate, you need to be registered in the Bar Council of respective state, and I am just a lawyer whom I don't need to have a registration in the Bar Council, but still I am enjoying medical profession for the last 30 years. There was a huge discussion just an hour back. I did not have a time to interpret. Broad dead patient. To conclude and summarize myself, the two things, broad death and dead on arrival. Make all these cases emergency subject for the postmortem. Probably any district hospital in a week will be presented to death body for the postmortem, but this is practical scenario. So we have to interpret, and it all depends on exactly we interpret. And always, whenever I address the medical conferences, there is a slight conflict between the medical expert and forensic scenarios, and also, hopefully there are no police officers. Sometimes we may have to overshoot ourselves to express our, I would say that, to express their life in day-to-day existence of life, and even in the advocates also. Hope so they pardon me, fatal. I go for that. Next. Chairpersons, if I am exceeding time, if anybody getting bored, there is no hesitation, please raise your hands and get short point out.
Go ahead, sir.
Yeah, please. Yeah. ಯಾವುದೋ ಮಾಡಬೇಕಾದ ಮಾಡದೇ ಇರೋದು, ಯಾವುದೋ ಮಾಡಬಾರ್ದಾಗಿತ್ತು ಅದನ್ನು ಮಾಡೋದು. This is medical negligence in pure terminology. So we need to understand duty of care. The patient has paid you consideration in the form of consultant fee. It means that you have accepted the patient for the treatment. The consumer, it begins once the anesthesiologist or surgeon for that matter accept the responsibility of providing anesthesia services. This is duty of care. Expect that nobody bothers, because relatives also know about it and doctors also know about it. I try to consult a murder, unexpected death. What exactly is unexpected death? It's not talking at all. It's unexpected death. And in spinal anesthesia I have given for a case, IS grade 1, AS grade 1. Soon after the anesthesia, patient went to the cardiac arrest, which you don't really find it. This is unexpected death. What exactly? I never ever experienced, I never ever listed a legal notice harassment of the police or whatever it is. In my legal arrest, is telling lie, or he is a beginner. Everybody has to undergo such kind of a thing, no doubt about it. Anesthesia deaths occurring within 24 hours administration of anesthesia due to causes related to the anesthesia. I do not agree with this sentence. I want to specify it. I have given anesthesia. Few of the drugs might last for weeks together. So it does not mean that the only 24 hours the patient has died, the patient died to anesthesia. If the patient is persistently remain hypotensive in spite of the angiograms and dies after 10 days, it is anesthetic test only. We cannot switch on to some other else unless there is a contract to exist. So what are the places where death on the table can occur? Yes. When you are examining the patient on the table, something goes wrong. Yes, I consider the death on the table. Maternity tables, medical procedures where LP, epidurals and central access procedures on the side stepping are being done. Radiological places where you are injecting a dye. Okay? You are doing an MRI where the patient is or baby is being selected for the comfort of the radiologist. Yes. And many times we do lot of cases under local and also electroconvulsive therapy done by the psychiatrist. Death. What are the incidents? The incidence is 0.5 to 0.8 per lakh anesthetics nowadays. because of the improvised monitoring and vigilance of the anesthesia techniques, now it has come very, very minimal of that. So intraoperative deaths of anesthesia patient, that's what I said, 1 in 30 per lakh, of which 80% deaths occurs in emergency only, especially with the ASA grade 3 and 4 and emergency. So what are the causes? I don't want to go into that. The human error factor is the anesthesia practice. Age, extreme of age, elderly and infants, anesthesia, especially madam, agree with me. Associated comorbid conditions, especially ASA grade 3 and grade 4. Surgical factors, lot many are there. And anesthetic factors itself. If the anesthetist is fatigued, if he is giving multiple cases, and last 11 o'clock they call me some other cases, probably something might go wrong. Nothing. So that is unexpected death. And wrong labeling of the drugs, medication errors, and wrong routes, accidents, the intubation, anaphylaxis, single bed rapid mixture, malfunctioning of the machines, which you do not notice, these all fall into the causes of the unexpected death. What is the reaction of the anesthetist or the surgical team, for that matter, on the table? Cardiac arrest, 90% can be revived with the immediate CPR. You have to be very, very vigilant, and it embarks the whole team to revive the patient. Check the equipment at defibrillating at the OT team, including the staff. Accurate records. Dealing with anesthesia, call a serious anesthetist irrespective of your ego. Keep it, all egos aside. Take the surgeon's help, definitely they can come to you. And dealing with a dead patient is a procedure-related, fast documentation most important, because police people, they come and see your documents even if you are not completed in time. And many times I've seen something goes wrong, that they get to work with juniors and they run away. Never ever do it. Settle matter as early as possible, political, financial, never do it. Because we are legally sound nowadays. Being too confident, yes, is a double-edged weapon. Retaliate the abuse by abuse language, never ever do it. However the threat, however the relatives abuse, just be calm and quiet and accept. And once they calm down, you can tell what exactly went wrong. So having done this unexpected death on the table, what exactly the patient relatives have remedies? Yes, that can knock the door of the Justice and Consumer Court, CPA 2019, punitive action, where they urge that doctors should be, or hospitals should be penalized or prosecuted. They go into the police station, file a criminal complaint against you, and disciplinary action. Statutory bodies can take place action, especially with respect to state critical councils, and also they can complain to the State or National Human Rights Commission seeking justice and compensation as per the Constitution of India. This is, look at this. Is it necessary to inform the police whenever death occurs on the table? That's what I told you. There is always some conflicts between the medical legal experts, advocates, police people, and the forensic experts also. As per my knowledge, it is not necessary. Death on the table need not be necessary. There is no law or a judicial principle or pronouncement in support of the belief held by many doctors that every death on the table should be informed to the police. I'll tell you how exactly we should interpret. The basic principle is that doctors should inform the police as soon as he suspects foul play. So, foul play is a subjective phenomenon. It may be a foul play for me, it may not be for others. At that particular point, I felt the fault, I informed the police. Including the unnatural death, during the course of the duty, whether OPD or IPD, whatever it is. It goes without saying that every unnatural death should be informed to the police. You got it? Then, there is no reason for the doctors to inform the police unless the foul play is suspected. That's what I told you. It's a subjective matter. However, the relatives are within their rights to make the police staff will be there, plus the monitors, gadgets will be there. So, within the four walls of the center, what happened? The public relative may not be knowing it. Okay? And they may have a lot of allegations, doctor did not do like that. But they cannot prove it. So, hatch up things, usually we inform the police to safeguard ourselves. That's it. For them. So when PM is needed, PM is required by the investigation agencies, nobody else other than the police and the court. To find out the cause of death, everybody knows about it. Waiving, this is very important slide. Medical legal PM is done on request of the police, magistrates or court. Medical officers have no power to waive off the PM. he can play a role of the advisor in such cases, but final decision lies with the investigating officer, that is the police inspector. So once you decide to do the post-mortem or make an MLC, the signature of the relatives is not required as a consent. Taking away the patient or body of the medical legal case forcibly by the attendants. So ultimately many times what happens is you want to make it a MLC and relatives they don't want it. And ultimately they say that we do whatever we want. We want to take the body for criminal because of our ritual customs. It means that doctor cannot act here as custodian of the dead body. He cannot act as the security officer. In such cases, you may have to inform the police without hesitation, keeping records of that they are taking forcibly without your knowledge, or they are using some external force to take the body. So making the bad news to the bereaved family, this is again a communication skill which I don't want to go. Yeah, that's what I told you. Giving such certificates in such cases is remunerating for all the medical legal experts. Many times what happens is, again the negativity fits into your mind, you start calling here and there, you take the advice of them, again it will be rumbling in your brain whether to give it the question of the news panel. Everybody has a habit of going to the Facebook and screening these things and things. Even in India, 2-3 cases have occurred, I don't want to tell them because they may be our colleagues also. In this case, treat but don't tweet. In Texas, a 60-year-old lady, low cardiac risk, and SpO2 drastically reduced and died. In the court of law, anesthetist was in iPod or mobile phone throughout the procedure, which was testified by the surgeon. And they could see the record. There was a correlation between where the anesthetist was busy with the iPod and where the monitoring had failed. In that crucial period of 15 to 20, where there was a drastic fall in the SpO2, he did not notice and he was taxed with millions of dollars in Texas. Okay? And delegation of a crucial period to train the anesthetist. Again, if any mistake is done by PGs or internists, it is the responsibility of the supervising doctor or head of department to own that responsibility of doing negligence. In this is one more case, Uma Devi versus Yashoda Hospital 16, 42 years lady who had a jaundice, ERCP was to be done under sedation. The anesthetist gave propofol. By the time ERCP was over, patient had a brain death. As well, many questions are there, and also allowed to learn many things. Any medical experts or forensic expert can add to me. Thank you. If you have any questions, if I know, I'll tell you. Otherwise, I'll make a note of it and get back to you in 1 minute. Judiciary has no role. It is we who has to substantiate what is an emergency, what kind of the complications are expected. The question arises, what kind of a complications you also do not know. That's what I'm telling you. What is need to be brought to the patient and relatives is, if you know the relative complications. Relative complication means, if the complication rate is 10, more than 10, you will have to inform. If the relative consequences is 1 or 2%, you don't have to inform the relatives or to the patient. Because I know death on the table is 1 in 1,000. I cannot tell to the patient, you will run away from that. You got it? We should know what is to be told to the patient relatives in what capacity. We call it as a relative complications or rare complications, which should not be bring to notice. The other one is, what you said, the second part of the question is, unexpected complications do occur without our knowledge. Okay? On the table, we don't know how the patient will behave with the anesthetic procedure or surgical procedure. That time the documentation is very, very important. So whatever you document, inform to the patient. Whatever you inform to the patient, document with the case paper. That will save the life. The court will not interfere. Court will say that what is good, what is wrong. Probably they will take an expert opinion. Expert opinion may be anesthetic complication, only anesthetic colleague will be there. Surgical complication, surgical colleague will be there. There will be no more about it. Unless it is a gross contradictory of their treatment.
The doctor had the professional indemnity insurance. He filed the case. So notice was issued to the doctor. But the insurance company did not encourage it, because they said, they asked the doctor to tell the patient to include, the insurance company.
You need to write, you need to respond, at least with the help of the medical expert like me and Dr. Vinay Kumar, because few things are written illegibly. It's beyond anybody's capacity to read them in between the lines. So probably if we fall into the exclusion criteria, somewhere they must have written, if there is any notice, you please inform us. You would not have omitted, you would have omitted it. So if that becomes highlighted, this is exclusion criteria, we don't entertain it. So what I advise is, whenever you get a legal notice, even if you have a pan in a medical indemnity, they want it. Okay, if they reject it, kindly send it to me, I'll go through it.
You want to complete the surgery, you want to take the consent. How do you proceed? Patient will be anesthetized, you have opened the case, you see some other pathology, you want to operate and complete the procedure. How do you take the consent for that?
Yeah, nothing goes wrong. The question arises, why did we extend the surgery unless it was an emergency? Imagine that there was a aortic bleed or something bleed and you are following surgery, that is okay, life shield procedure. So in such situations, thinking, because you never ever do it, if at all you have taken a consent before that, I am anticipating so and so. Probably I may have to take a pathology opinion on the table. If you have already taken a consent, if it is contemporaneous, we can do that, sir. So prior consent would have been taken earlier. There's nothing wrong, you can take it. Now while doing consent, probably I may have to extend the surgery, I may have to call a second pathologist on table, and here.
of Surgery and District Surgeon of KODAGU Institute of Medical Science, MEDICAL.
LLB, PGD, MLE, National Law, School of India, University, and he is a professor of pediatrics at SS Institute, Davangere, and he is also a medical legal educator and advisor, and he is founder of Medical Legal Aid e-learning platform for doctors. So Dr. Vinay Kumar will be briefing us about how to write legally valid medical certificate and what are the essentials. So I hope all the doctors who are here, they find medical certification is a legally very important document.
Whatever certificate we write should be legally valid. Okay. So many of the patients will call us and ask, Doctor, I am not feeling well, could you please issue a medical certificate to just take a leave? Or can you recommend 20 days of bed rest? Or kindly mention in the certificate that so that I can extend my stay in India. Patients will only come out telling that I have some mention that it is disc prolapse, so that we get 20 days of certificate. Okay. And many mothers, I am a pediatrician, many mothers will come and tell, sir, write that my baby is sick so that I can extend my maternity leave. Or many now these MLC cases, many politicians will call us and ask, he has not got a bail act, let him be in your hospital for 20 days, just extend the stay in the hospital. Okay, so these are the most common scenarios what we face. So what are the legal implications of writing a certificate is, it has administrative implications like giving a leave, suspending someone if there is a misbehavior, something like that, or financial implication because salary has to be given, and judicial implications because whatever certificate we write is a legal document. And certificates are documentary evidence, as madam told already, and it is treated as an expert opinion in the court. Even if you don't go to the court, your certificate is treated as an expert opinion. So be prepared to testify under oath and defend whatever the content of the certificates which you write. Any scribble, any paper you write and give it to the patient, it can be used as a evidence in the court. So what are the consequences to the doctor? You can get a disciplinary action by the medical council if you write a false certificates. You can be punished under civil or criminal liability if your certificate is used to escape criminal law, or you can be punished under criminal law. These are the various sections, you don't have to know. So all medical certificates are legal document. Every certificate is a legal document, there is no exception. So because we doctors are tuned ourselves to learn through case scenarios, I am going to tell you the case scenarios which are really happened, so that you will know what are the mistakes doctors were doing. This is, I not put the name of the doctors because many are still practicing. Medical Council Disciplinary Committee's case, where concern was verification of 2 medical certificates issued by the doctor in 2013, issued to Srimina by Dr. XYZ. And doctor has appeared before the committee. Certificates were 22 days of leave for urinary tract infection and 62 days leave for upper respiratory tract infection and colitis. Whether it is there or not for any MBBS or any specialty person, you will come to know there is something wrong with this certificate, because no one gives so many days of leaves for him. So what has happened, we don't know. Finally, the certificate was questioned, and when the certificate is questioned in the court, sometimes courts direct medical council to take action, because courts don't want to directly take action on doctors because they are not experts in the field. So what they do, they refer it to the medical council. If it's a Karnataka, it will go to Karnataka Medical Council. And in the council, doctors were asked to produce the OPD register where when the patient was seen, or any supporting clinical documents supporting our diagnosis. Probably they would have asked, show me the case sheet or show me the urine culture report or whatever prescriptions which you have when you see the patient. So that was not there. And they were also give me a photocopy of the certificates which you have issued to the patient. That was also not there with the doctor. And committee noted casualness and unprofessionalism of behavior of the doctor in issuing a long duration certificate without basis, and his name was removed for 30 days from the Delhi Medical Council. Okay, because the certificate was issued in unprofessional manner, no documents were there with the doctor to cross-verify the certificates, and there were no OPD or IPD reports with the doctor. So 30 days of erasure, temporary professional erasure was done to the doctor. So you should always have a OPD or any supporting documents when you issue a certificate to a patient. Just patient comes to you and asks for a certificate, never issue a certificate. Ask them to get a OPD file. If it is an admitted patient, of course you will have an IPD file. If they're not, everyone not responsible for matter, then who do you think all these things stands in court? See, your duty is to explain the consent. You cannot tell them that you won't be held responsible. Of course you are responsible, that's why you are taking consent. So any certificate you write is a legal document. Just one line below telling that this is not valid for legal purpose will not stand in court. In this case, luckily a doctor finally pleaded with the judge and finally he was left out with a warning. He was not punished. Still, patient suspected fracture. No X-ray report was attached. Injury described grievous based on the visual appearance. And Karnataka, when they went to the court, the Karnataka court observed that clinical observation is not sufficient to prove the grievous injury. Radiological evidence was not there. So they cut down the injury from grievous to simple. Presuming that patient initially had a grievous injury, because doctor didn't take an X-ray, the accused got away with a minor punishment because we didn't take a X-ray. So conviction altered from previous 326 to 324, sentence was reduced accordingly. So prosecution has failed to prove the burden of grievous injury because of missing X-ray. So let me give an example. If you write a fracture femur certificate without an X-ray, anyone can question. So if you write a fracture femur certificate with an X-ray, of course no one will question. So whenever you write a fracture, please attach the X-ray report or attach the X-ray number to the certificate so that if they want, they can come back and take the X-ray from the case file. Okay. So whenever fracture is mentioned, please request for X-ray and include the X-ray number in the report. So this is the judgment where Teligi case where 2 doctors were sentenced to 7 years of imprisonment because of writing a fake certificate, or later they got out in the Supreme Court. But still, you remember, these certificates are not just for the patient purpose. You may also go to the jail if you write a fake certificates or false certificates, and those certificates are misused by the patient party or the especially in medical legal cases. Okay, so that possibility is also there. So what are the document? I will just summarize what should be the documentation standards when you write a certificate is. It should be clear, legible handwriting. So it may concern avoid writing detailed psychiatric diagnosis. Limit certificate to 15 days. Longer leave should be referred to a medical board. Never issue a certificate based on WhatsApp, SMS, verbal requests, phone call without seeing a patient. So this is one of the formal certificate which I have prepared. See, date is there, certificate number is there, so that you know you will have a reference copy with you, and you have a reference OP or IP number of the patient. So because you can always go back to the case sheet in the hospital in case the case goes to court. This is to certify that so and so wife. This can give a certificate, provided they are giving you the money and all.
But they need to take the OPD slip. We need to.
Sir, if they are paying for all those things, we can take extra pain of doing that. I know the humanitarian grounds or whatever it is, we can do, but we cannot issue a certificate without seeing the patient. That becomes a negligence. And whether that patient, see, I can give a scenario. What if that patient gets color blindness? Like a other person, we are not looking at color blindness. So it depends on. So best way is you ask them to bring the format. So that
the problem is what I said was there is a very gray area. It all depends on how the political, how judiciary interpret about this. Patient brought death. What next? Is a $1 million question. Okay. So patient brought death. Our patient dead on arrival. Okay. That's what I said. I have seen in front of me patient with the convulsions and MI. Going for a retake, immediately flatline. So that time we need to do resuscitation procedure and we will have it. But if you are not aware, I cannot label him as a medical legal case unless the patient releases a warrant for that. Because I know the cause of death. There is no question of medical legal case or emergency. Okay? In such situations, even if, as you rightly said, patient comes aggressively saying that, doctor, do something, whatever is the bill. So that time if you do not do on moral grounds or ethical grounds, and you are going to face a visit of the relatives. So that time, at least put oxygen, start IV line, do CPR measures, that declare death. So ultimately, for thinking of doing it as medical legal, you are not able to give a cause of death certificate. So so that time you have to inform the police and watch for that.
And all those things.
The person who is signing will be penalized.
Is that anything vicarious level of the establishment like a hospital?
Sir, this certification issuing vicarious liability doesn't come because a person is signing.
Chalapati. He is the founder and current president of Indian Academy of Pediatrics, Chikbalapur district. He is the state chairman of IAP for Medical Legal Chapter. Dr. Shivkumar Kambal, and Chandrasekhar HV, Inspector, Madikeri Rural Division.
Students, ಈಗಾಗಲೇ ನಿಮ್ಮ ಸೀನಿಯರ್ಸ್ ಏನೆಲ್ಲ ಫೋಕಸ್ ಮಾಡಿ ನಿಮಗೆ ತಿಳಿಸಿದ್ದಾರೆ, ಇದೆಲ್ಲ ಸ್ವಲ್ಪ ಗಂಭೀರವಾದಂಥ ವಿಚಾರ. ನಾವು ಪೊಲೀಸ್ ಆಗಿ ಆಸ್ ಎ ಪೊಲೀಸ್ ಆಗಿ ಎರಡು ವಿಚಾರಗಳನ್ನ ತುಂಬಾ ಅಟೆಂಟಿವ್ ಆಗಿ ಅದನ್ನು ಗಮನಿಸಿ ಅದರ ಬಗ್ಗೆ ಒತ್ತು ಕೊಟ್ಟು ಕೆಲಸವನ್ನು ಮಾಡ್ತೇವೆ. ಅದು ಒಂದು ಏನಂದ್ರೆ ಮೆಡಿಕೇರ್ ಪರ್ಸನಲ್ಸ್ ಮೇಲೆ ಯಾರಾದರೂ ಅಸಾಲ್ಟ್ ಮಾಡಿದಂಥ ಸಂದರ್ಭದಲ್ಲಿ ಅಥವಾ ಅವರಿಗೆ ಏನಾದ್ರು ತೊಂದರೆ ಮಾಡಿದಾಗ ಇಡೀ ಡಾಕ್ಟರ್ಸ್, ಅದು ಸ್ಟೇಟ್ ಲೆವೆಲ್ ಇರ್ಬೋದು ಅಥವಾ ನ್ಯಾಷನಲ್ ಲೆವೆಲ್ ಇರ್ಬೋದು, ಅಲ್ಲಿವರೆಗೆ ಒಂದು ಹೈ ಪಿಚ್ ಅಲ್ಲಿ ಸೌಂಡ್ ಆಗುತ್ತೆ. ನೀವೇನಾದ್ರೂ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡೋದನ್ನ ಒಂದು ದಿವಸ ನಿಲ್ಲಿಸ್ಬಿಟ್ರೆ ಎಷ್ಟು ಕಷ್ಟ ಆಗುತ್ತೆ ಅಂತ ಹೇಳೋದು ಎಲ್ರಿಗೂ ಗೊತ್ತಿರುವಂಥ ವಿಚಾರ. ಎಷ್ಟೋ ಪ್ರಾಣಗಳನ್ನ ಕಾಪಾಡಬೇಕಾದಂಥ ಒಂದು ಗುರುತರವಾದಂಥ ಒಂದು ಜವಾಬ್ದಾರಿ, ರೆಸ್ಪಾನ್ಸಿಬಿಲಿಟಿ ನಿಮ್ಮ ಮೇಲೆ ಇರುತ್ತೆ. ಸೊ ನಿಮಗೆ ತೊಂದರೆ ಆಗದಂಗೆ ನೋಡ್ಕೊಳ್ಬೇಕಾಗಿರೋದು ಸರ್ಕಾರದ ಜವಾಬ್ದಾರಿ, ನಮ್ಮಂತಹ ಇಲಾಖೆಯ ಜವಾಬ್ದಾರಿ. ಅದನ್ನು ನಾವು ಮಾಡಲೇಬೇಕಾಗತ್ತೆ. ಎರಡನೇದಾಗಿ ಲಾಯರ್ಸ್ ಇಲ್ಲೇ ಕೂತಿದ್ದಾರೆ. ಎಗೇನ್ಸ್ಟ್ ಲಾಯರ್ಸ್ ಏನಾದರೂ ಸ್ವಲ್ಪ ವಿಚಾರ ಆದರೂ ಕೂಡ ಅದು ಕೂಡ ಸ್ಟೇಟ್ ಲೆವೆಲಲ್ಲಿ ನ್ಯೂಸ್ ಆಗುತ್ತೆ. ಆಮೇಲೆ ಕೋರ್ಟ್ನ ಬಾಯ್ಕಾಟ್ ಮಾಡ್ತಾರೆ. ಕೋರ್ಟ್ ನಡೀಲಿಲ್ಲ ಅಂತಂದರೆ ತೊಂದರೆಗಳಾಗ್ತದೆ. ಅದರ ಹಿಂದೆ ಏನೇನೋ ಕೇಸ್ಗಳಾಗ್ಬೋದು, ನಂತರ ಮಾತುಕತೆಗಳಾಗ್ಬೋದು, ಆ ನಂತರ ಅದೊಂದು ನಾರ್ಮಲ್ಸಿಗೆ ಬರುತ್ತೆ. ಬಟ್ ದಿಸ್ ಟೂ ಸಿಚುವೇಶನ್ಸ್, ಈ ಎರಡು ಪ್ರೊಫೆಷನ್ಸ್ಗೆ ಸಂಬಂಧಪಟ್ಟ ಹಾಗೆ ತುಂಬ ನಾವು ಗಮನವನ್ನು ಕೊಟ್ಟು ಅದ್ರ ಬಗ್ಗೆ ನಾವು ಅಟೆಂಟಿವ್ ಆಗಿರಬೇಕಾಗುತ್ತೆ. ಸೊ ಮೆಡಿಕಲ್ ಪರ್ಸನ್ಸ್ ಮೇಲೆ ಪದೇ ಪದೇ ಗಲಾಟೆಗಳಾಗ್ತಿರೋದು, ಅವರ ಪ್ರಾಪರ್ಟಿಗಳನ್ನ ಡ್ಯಾಮೇಜ್ ಮಾಡ್ತಿರುವಂಥದ್ದು, ಇದನ್ನೆಲ್ಲ ನಿಯಂತ್ರಿಸಬೇಕು ಅಂತ ಹೇಳಿದ್ರೆ ಏನಾದ್ರು ಒಂದು ಆಕ್ಟ್ ಬೇಕು, ಒಂದು ಸ್ಪೆಷಲ್ ಆಕ್ಟ್ ಬೇಕು. ಮೊದಲೆಲ್ಲ ನಾವು IPC ಮಾಡ್ತೀವಿ, ಇವಾಗ BNS ಬಂದಿದೆ. ಮೊದಲೆಲ್ಲ IPC ಇರುವಂಥ ಜನರಲ್ ಸೆಕ್ಷನ್ಸ್ ಅಡಿಯಲ್ಲಿ ನಾವು ಪ್ರಕರಣಗಳನ್ನ ದಾಖಲಿಸ್ಕೊಳ್ತಿದ್ದು. ಏನು ಅವ್ರಿಗೇನೋ ಕರ್ತವ್ಯಕ್ಕೆ ನಾನು ಅಡ್ಡಿ ಮಾಡಿದ್ರೆ ಅವರ ಒಂದು ಕರ್ತವ್ಯಕ್ಕೆ ಡಿಸ್ಚಾರ್ಜ್ ಮಾಡುವಂಥ ಸಮಯದಲ್ಲಿ ಲೀಗಲ್ ಕರ್ತವ್ಯವನ್ನು ನಿರ್ವಹಿಸುವಾಗ ಯಾರಾದ್ರೂ ಅವ್ರಿಗೆ ತೊಂದರೆ ಮಾಡಿದ್ರೆ 353 ಅಂತ ಒಂದು ಸೆಕ್ಷನ್ ಇತ್ತು, ಅದರಲ್ಲಿ ನಾವು ಕೇಸನ್ನು ಬುಕ್ ಮಾಡ್ತೀವಿ. ಅಸಾಲ್ಟ್ ಮಾಡಿಬಿಟ್ಟಿದ್ರೆ ಅದು ಕೈಯಿಂದ ಹೊಡೆದ್ರು ಅಥವಾ ವೆಪನಿಂದ ಹೊಡೆದ್ರು 323 ಅದು ಇದೆ. ನಂತರ ಪ್ರಾಪರ್ಟಿ ಡ್ಯಾಮೇಜ್ ಅಂದ್ರೇನು ಅದು ಕೂಡ ಇದೆ. ನಂತರ ಈ ವೈಲೆನ್ಸ್ ಮಾಡೋರಿಗೆ ಮಾತ್ರ ಅಲ್ಲ, ಅದನ್ನ ಯಾರು ಪ್ರೊವೋಕ್ ಮಾಡ್ತಾರೆ, ಅಬೇಟ್ ಮಾಡ್ತಾರೆ ಅವರಿಗೂ ಕೂಡ ಇದರಲ್ಲಿ ಪನಿಷ್ಮೆಂಟ್ಸ್ ಇದೆ. ಆಮೇಲೆ ಇದನ್ನ ಸ್ಪೀಡಿ ಟ್ರಯಲ್ ಮಾಡಬೇಕು ಅಂತ ಕೂಡ ಕೋರ್ಟ್ ಇದೆ. ಜೊತೆಗೆ ಪ್ರಾಪರ್ಟಿ ಡ್ಯಾಮೇಜ್ ಮಾಡಿದ್ರೆ ಪ್ರೈಸ್ ಅದು ಎಷ್ಟು ಲಾಸ್ ಆಗಿದೆಯೋ ಅದರದ್ದು 2 ಪಟ್ಟು ಹಣವನ್ನ ಅವರನ್ನು ವಸೂಲಿ ಮಾಡಲಿಕ್ಕೆ ಅವಕಾಶ ಇದೆ. ಧನಂಜಯ ಸರ್ ನಾನು ತಪ್ಪಿದ್ರೆ ಕ್ಲಾರಿಫೈ ಮಾಡಿ. ನಂತರ ಲ್ಯಾಂಡ್ ರೆವಿನ್ಯೂ ಆಕ್ಟ್ ಅಂತ ಒಂದು ಆಕ್ಟ್ ಇದೆ ನಮ್ದೆಲ್ಲ ಸಿವಿಲ್ ಪ್ರೊಸೀಜರ್ ಕೋಡ್ ಅಲ್ಲಿ. ಲ್ಯಾಂಡ್ ರೆವಿನ್ಯೂ ಆಕ್ಟ್ ಅಲ್ಲಿ ನಾವೆಲ್ಲ ಲ್ಯಾಂಡ್ಸ್ಗೆ ಸಂಬಂಧಪಟ್ಟಂತೆ ಇದನ್ನೆಲ್ಲ ಮಾಡ್ತೀವಿ. ಅದರ ಅಡಿಯಲ್ಲಿ ಲ್ಯಾಂಡ್ ಅನ್ನು ಕೂಡ ಅವರಿಗೆ ಸಂಬಂಧಪಟ್ಟ ಅಕ್ಯೂಸ್ಗಳು ಯಾರಿದ್ದಾರೆ ಅವ್ರ ಮೇಲೆ ಕೂಡ ಅದನ್ನು ಕಾನ್ಫಿಸ್ಕೇಟ್ ಮಾಡ್ಕೊಳ್ಳಿಕ್ಕೆ ಒಂದು ಪ್ರೊಸೀಜರ್ನ ಕೂಡ ಇದರಲ್ಲಿ ಸ್ಟಾರ್ಟ್ ಮಾಡ್ಬೋದು. ಅಷ್ಟೊಂದು ಒಂದು ಸ್ಟ್ರಾಂಗ್ ಆದಂತ ಒಂದು ಆಕ್ಟ್ ಅನ್ನು ಮಾಡಿದ್ದಾರೆ. ಇದರಲ್ಲಿ ಸಿಂಪಲ್ ಆಗಿ ನಾನು ಹೇಳ್ಬಿಡ್ತೀನಿ. Registered medical practitioners working in medical institutions including those having provisional registration. ಅದರಲ್ಲೆಲ್ಲ ನರ್ಸಸ್ ಬರ್ತಾರೆ, ಸ್ಟೂಡೆಂಟ್ಸ್ ಬರ್ತಾರೆ, ನಂತರ ನರ್ಸಿಂಗ್ ಸ್ಟೂಡೆಂಟ್ಸ್ ಬರ್ತಾರೆ, ನೆಕ್ಸ್ಟ್ ಪ್ಯಾರಾಮೆಡಿಕಲ್ ವರ್ಕರ್ಸ್ ಇವರೆಲ್ಲರೂ ಸೇರಿ ಮೆಡಿಕಲ್ ಪರ್ಸನಲ್ಸ್ ಅಂತ ಹೇಳಿ ಆಗ್ತಾರೆ. ದಿ ಎಂಪ್ಲಾಯೀಸ್ ವರ್ಕಿಂಗ್ ಇನ್ ದಿ ಮೆಡಿಕಲ್ ಸರ್ವಿಸ್ ಇನ್ಸ್ಟಿಟ್ಯೂಷನ್ಸ್ ಇನ್ಕ್ಲೂಡಿಂಗ್ ಸೆಕ್ಯೂರಿಟಿ ಗಾರ್ಡ್ಸ್. ನಾವು ಬರೀ ಡಾಕ್ಟರ್ಸ್ ಅಂತ ತಿಳ್ಕೊಬೇಡಿ, ಸೆಕ್ಯೂರಿಟಿ ಗಾರ್ಡ್ಸ್ಗಳು ಕೂಡ ಇದರಲ್ಲಿ ಪ್ರೊಟೆಕ್ಷನ್ಸ್ ಅಂಡ್ ಮ್ಯಾನೇಜರಿಯಲ್ ಸ್ಟಾಫ್, ಆಂಬ್ಯುಲೆನ್ಸ್ ಡ್ರೈವರ್ಸ್ ಅಂಡ್ ಹೆಲ್ಪರ್ಸ್ ಇವರೆಲ್ಲರಿಗೂ ಕೂಡ ಇದರಲ್ಲಿ ಪ್ರೊಟೆಕ್ಷನ್ ಅನ್ನ ಕೊಡ್ಬೋದು. ಇವರಿಗೆ ಯಾರಿಗೆ ಕೂಡ ತೊಂದರೆ ಆದ್ರೂ ಕೂಡ ಈ ಆಕ್ಟ್ ಅಡಿಯಲ್ಲಿ ನಾವು ಕ್ರಮವನ್ನು ತಗೊಳ್ಬಹುದು. ನೆಕ್ಸ್ಟ್ ಪ್ರೊಹಿಬಿಷನ್ ಆಫ್ ವೈಲೆನ್ಸ್. ಏನೆಲ್ಲ ವೈಲೆನ್ಸ್ ಹಾಗಾದ್ರೆ? ಎನಿ ವೈಲೆನ್ಸ್ ಅಗೇನ್ಸ್ಟ್ ಮೆಡಿಕಲ್ ಸರ್ವಿಸ್ ಪರ್ಸನಲ್ ಆರ್ ಡ್ಯಾಮೇಜ್ ಟು ಪ್ರಾಪರ್ಟಿ ಇನ್ ಎ ಮೆಡಿಕಲ್ ಸರ್ವಿಸ್ ಇನ್ಸ್ಟಿಟ್ಯೂಷನ್ ಇಸ್ ಪ್ರೊಹಿಬಿಟೆಡ್. ಯಾವುದೇ ಒಂದು ಡ್ಯಾಮೇಜ್ ಇರ್ಬೋದು ಅಥವಾ ವೈಲೆನ್ಸ್ ಇರ್ಬೋದು ಮೆಡಿಕಲ್ ಪರ್ಸನಲ್ ಮೇಲೆ ಅಥವಾ ಪ್ರಾಪರ್ಟಿ ಮೇಲೆ, ಇದೆಲ್ಲವನ್ನು ಕೂಡ ನಾವು ವೈಲೆನ್ಸ್ ಅಂತಾನೆ ಇದರಲ್ಲಿ ಕರಿತೇವೆ. ಅದನ್ನ ಪ್ರೊಹಿಬಿಟ್ ಮಾಡಲ್ಲ. ಸೆಕ್ಷನ್ 3 ಪ್ರಕಾರ ಅದು ಪ್ರೊಹಿಬಿಟ್. ಯಾರು ಕೂಡ ಪ್ರಾಪರ್ಟಿ ಡ್ಯಾಮೇಜ್ ಮಾಡೋಂಗಿಲ್ಲ. ಡಾಕ್ಟರ್ಸ್ಗಾಗಲಿ, ನರ್ಸ್ಗಳಿಗಾಗಲಿ, ಸ್ಟೂಡೆಂಟ್ಸ್ಗಾಗಲಿ, ಆಂಬ್ಯುಲೆನ್ಸ್ ಡ್ರೈವರ್ಸ್ಗಾಗಲಿ ಅಥವಾ ಅಲ್ಲಿರುವಂಥ ಹೆಲ್ಪರ್ಸ್ಗಾಗಲಿ ಯಾವುದೇ ತೊಂದರೆಯನ್ನ ಮಾಡುವಂತಿಲ್ಲ. ಇದು ಸೆಕ್ಷನ್ 3 ಪ್ರಕಾರ ಇಟ್ಸ್ ಎನ್ ಅಫೆನ್ಸ್, ಇದು ಅಪರಾಧ. ನೆಕ್ಸ್ಟ್ ಪ್ರೊಹಿಬಿಷನ್ ಆಫ್ ಇಂಟೆನ್ಷನಲ್ ಇನ್ಸಲ್ಟ್. ಈಗ ಹೇಳ್ತೀವಿ ಡಾಕ್ಟರ್ನೆಲ್ಲ ಮುಂದೆ ಪಬ್ಲಿಕ್ಸ್ ಮುಂದೆ ಬಂದು ನೀನೆಂತ ಡಾಕ್ಟ್ರು, ನೀನು ಹಾಗೆ ಮಾಡ್ಬೋದಿತ್ತು, ಈಗ ಮಾಡ್ಬೋದಿತ್ತು, ಅಷ್ಟು ಗೊತ್ತಿಲ್ವ, ಎಷ್ಟು ಗೊತ್ತಿಲ್ಲ, ನಾನು ಗೂಗಲ್ ನೋಡಿದ್ದೀನಿ, ಗೂಗಲ್ ಅಲ್ಲಿ ಇದೇ ತರ ಇದೆ, ನೀವ್ಯಾಕೆ ಆ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಟ್ಟಿಲ್ಲ, ಇಂಟೆನ್ಷನಲ್ ಇನ್ಸಲ್ಟ್ ಮಾಡ್ತಾರೆ. ಸೊ ನಮಗೆ ಒಂದು ಪ್ರೊಫೆಷನಲ್ಲಿ ನಾವೊಂದು 10 ಜನ ಇರ್ತೀವಿ, ನಮ್ದು ಒಂದು ಡಿಗ್ನಿಫೈಡ್ ಪ್ರೊಫೆಷನ್ಸ್ ಇರ್ತೀವಿ, ಕಷ್ಟಪಟ್ಟು ಓದ್ಕೊಂಡ್ ಬಂದಿರ್ತೀವಿ, ನಮ್ಗೊಂದು ಮಾತು ಹೇಳ್ಬಿಟ್ಟು ಕೂಡ ತುಂಬಾ ನಮಗೆ ಬೇಸರ ಆಗುತ್ತೆ. ಸೊ ಇಂಟೆನ್ಷನಲ್ ಇನ್ಸಲ್ಟ್ ಯಾರು ಕೂಡ ಮಾಡಿದ್ರು ಕೂಡ ಅದನ್ನು ಕೂಡ ಇಲ್ಲಿ ಅಪರಾಧ. Any intentional insult of Medicare service personnel in a Medicare service institution is prohibited. ಆ ಇನ್ಸ್ಟಿಟ್ಯೂಷನ್ ಒಳಗಡೆ ಏನೇ ಬಂದ್ರು ನಿಮ್ಗೆ ಇನ್ಸಲ್ಟ್ ಮಾಡಿದ್ರೆ ಅದು ಕೂಡ ಅಪರಾಧ ಅಂತ ಹೇಳಿ ಆಗುತ್ತೆ. ಪೆನಾಲ್ಟಿ ಸೆಕ್ಷನ್ 4 ಅಲ್ಲಿ ಹೇಳಿದ್ದಾರೆ. ಸೆಕ್ಷನ್ 3 ಅಂಡ್ ಸೆಕ್ಷನ್ 3A ಗೆ ಪೆನಾಲ್ಟಿಯನ್ನ ಸೆಕ್ಷನ್ 4 ಅಲ್ಲಿ ಹೇಳಿದ್ದಾರೆ. ಏನ್ ಹೇಳಿದ್ದಾರೆ? Any person who commits any act in contravention of section 3 shall be punished with imprisonment for a period of not less than 3 years, which may extend up to 7 years, and also with fine, which shall not be less than rupees 25,000 and not more than rupees 2 lakhs. ಸೆಕ್ಷನ್ 3 ಮತ್ತು 3A ಅನ್ನ ಯಾರು ವೈಲೇಟ್ ಮಾಡಿ ಅಫೆನ್ಸ್ ಮಾಡ್ತಾರೆ ಅವರಿಗೆ ಸೆಕ್ಷನ್ 4 ಅಲ್ಲಿ ಪನಿಷ್ಮೆಂಟ್ ಅನ್ನ ಹೇಳಿದ್ದಾರೆ. ಸೊ ಇದ್ರ ಜೊತೆಗೆ ಬೇರೆನೂ ಬರುತ್ತೆ. ನಾವು ಜೊತೆಗೆ BNS ಎಲ್ಲ ಹಾಕೊಂಡು ಅಲಾಂಗ್ ವಿತ್ ಅಡಿಷನಲ್ ಸೆಕ್ಷನ್ಸ್ ಅನ್ನ ಹಾಕೊಂಡು ಇನ್ವೆಸ್ಟಿಗೇಷನ್ ಅನ್ನ ನಾವು ಸ್ಟಾರ್ಟ್ ಮಾಡಿರ್ತೀವಿ. ಆ ಸೆಕ್ಷನ್ಸ್ ಗಳಿಗೆ ಏನೇನು ಪನಿಷ್ಮೆಂಟ್ಸ್ ಇದೆಯೋ ಅದು ಕೂಡ ಇದಕ್ಕೆ ಅಪ್ಲೈ ಆಗುತ್ತೆ. ಸೊ ದಿಸ್ ಇಸ್ ಅ ಸ್ಪೆಷಲ್ ಆಕ್ಟ್. ಇದಕ್ಕೆ ಇಲ್ಲಿರುವಂತ ಸೆಕ್ಷನ್ ಬಹಳ ಮುಖ್ಯ ಆಗುತ್ತೆ. ಅಲಾಂಗ್ ವಿತ್ ಅಡಿಷನ್ಸ್ ಬೇರೆ ಸೆಕ್ಷನ್ಸ್ ಕೂಡ ಇದರಲ್ಲಿ ಬರುತ್ತೆ. ಸೊ ಇದನ್ನ 7 years ಗಂಟೆ ಕೂಡ ಅದನ್ನ ಎಕ್ಸ್ಟೆಂಡ್ ಮಾಡುವಂತ ಗ್ರಾವಿಟಿ ನೋಡಿ ಯಾವ ರೀತಿ ಇದೆ, ಆ ಕೇಸ್ ಯಾವ ರೀತಿ ಇದೆ, ಏನ್ ಅಫೆನ್ಸ್ ಮಾಡಿದ್ದಾನೆ, ಆ ಗ್ರಾವಿಟಿ ನೋಡಿ ಅದನ್ನ 7 years ಗಂಟೆ ಕೂಡ ನಾವು ಅದನ್ನ ಮ್ಯಾಜಿಸ್ಟ್ರೇಟ್ ಅವರಿಗೆ ಶಿಕ್ಷೆಯನ್ನು ಕೊಡ್ಲಿಕ್ಕೆ ಅವಕಾಶ ಇದೆ. ಸೊ ಸುಮ್ಮನೆ ಕೊಡಲ್ಲ ಯಾವುದೇ ಮ್ಯಾಜಿಸ್ಟ್ರೇಟ್ ಆಗಿರ್ಲಿ, ಕೇಸ್ ಹಿಯರಿಂಗ್ ಮಾಡಿದಾಗ ಅವರು ಡಾಕ್ಯುಮೆಂಟ್ಸ್ ಅನ್ನೆಲ್ಲ ಪರ್ಸೀವ್ ಮಾಡಿ ಸೊ ಅವರು ಕನ್ಕ್ಲೂಷನ್ ಬರಬೇಕು. ಒಬ್ಬ ಆರೋಪಿಗೆ ಇದು ಅಬ್ಸರ್ವ್ ದ ಡಾಕ್ಯುಮೆಂಟ್ಸ್, ಏನೇನು ಡಾಕ್ಯುಮೆಂಟ್ಸ್ ಅನ್ನ ನೀವು ಬಿಲ್ಡಪ್ ಮಾಡಿದಿರಿ, ಏನ್ ಸಿಚುವೇಶನ್ಸ್ ನಡೆದಿದೆ. ಕೋರ್ಟಲ್ಲಿ ನಿಮ್ಗೆಲ್ಲರೂ ಗೊತ್ತಿರ್ಬೋದು, ಕಲೆಕ್ಷನ್, ಪ್ಯಾಕಿಂಗ್, ನಂತರ ಅದನ್ನ ಡಾಕ್ಯುಮೆಂಟೇಶನ್ ಅನ್ನ ಮಾಡೋದು, ಪಿನ್ ಟು ಪಿನ್ ದೇ ಆರ್ ಅಬ್ಸರ್ವ್. ಯಾಕೆಂದ್ರೆ ಡಿಫೆನ್ಸ್ ಮಾಡಿ ಓಡಿ ಸರಿಯಾಗಿ ಓಡಿ, ಅದು ನೋಡಿ ಇದು ನೋಡಿ ಅಂತ ಹೇಳಿ ಕೊಡ್ತಾರೆ. ಅವ್ರಿಗೆ ಆ ಥರ ಅಲ್ಲ, ಒಂದು ಕೆಲಸ ಮಾಡಿ, ಅವ್ರ ಡ್ರೆಸ್ ಎಲ್ಲ ಬಿಡಿಸಿ, ಅವ್ರು ಡಾಕ್ಟರ್ ಅಲ್ಲ, ಅವ್ರು ಡಾಕ್ಟರ್ ಹಾಕಲಿ ಇದಿಲ್ಲ, ಅವ್ರದ್ದು ಡ್ರೆಸ್ಗೆಲ್ಲ ಅವ್ರದ್ದು ವೈಟ್ ಡ್ರೆಸ್ ಹಾಕ್ಬಾರ್ದು ಅವರು ಹೇಳ್ತಾರೆ. ಸೊ ದ ಅಪಾಯಿಂಟ್ಮೆಂಟ್ ಅಲ್ಲಿ ನಿಂತ್ಕೊಂಡು ಅಪಾಯಿಂಟ್ಮೆಂಟ್ ಮಾಡಿ ಅವ್ರಿಗೆ ಈ ಥರ ತೊಂದರೆ ಮಾಡಿದ್ರೆ ಅದು ಕೂಡ ಅಪರಾಧ, ಅದಕ್ಕೂ ಸೇಮ್ ಪನಿಷ್ಮೆಂಟ್. ಸೊ ಅಪಾಯಿಂಟ್ಮೆಂಟ್ ಮಾಡಿದ್ದೀನಿ, ನಾನು ಅವ್ರನ್ನ ಮುಟ್ಟಿಲ್ಲ, ನಾನು ಹೊಡೆದಿಲ್ಲ ಅಂತ ಹೇಳೋಂಗಿಲ್ಲ. ಸೇಮ್ ಪನಿಷ್ಮೆಂಟ್ ಅನ್ನ ಏನ್ ಸೆಕ್ಷನ್ 4 ಅಲ್ಲಿ ಹೇಳಿದ್ದಾರೆ ಅದು ಎರಡೂ ಸೆಕ್ಷನ್, ಸೆಕ್ಷನ್ 3, ಸೆಕ್ಷನ್ 3A, ಸೆಕ್ಷನ್ 4 ಅಲ್ಲಿ ಅಬೇಟ್ಮೆಂಟ್ ಕೂಡ ಅದೇ ಪೆನಾಲ್ಟಿಯನ್ನ ಹಾಕಿದ್ದಾರೆ. ಅದರಿಂದ ಅಲ್ಲೂ ಕೂಡ ನಿಮಗೆ ಪ್ರೊಟೆಕ್ಷನ್ ಇದೆ. ಅದನ್ನ ಅಬೇಟ್ಮೆಂಟ್ ಅನ್ನ ಯಾರೇ ಬಂದ್ ಮಾಡಿದ್ರು ಕೂಡ ಅದು ಅಪರಾಧ ಅಂತ ಆಗುತ್ತೆ. ಆಮೇಲೆ ಸೋಷಿಯಲ್ ಮೀಡಿಯಾದಲ್ಲೂ ಕೂಡ ಕಳಿಸಿ, ನಂತರ ಸೋಷಿಯಲ್ ಮೀಡಿಯಾದಲ್ಲೂ ಸಹ ಡಾಕ್ಟರ್ ಬಗ್ಗೆ ಅವಹೇಳನಕಾರಿಯಾಗಿ ಬರೆಯುವಂಥದ್ದು, ನಂತರ ಅವ್ರ ಬಗ್ಗೆ ಪೋಸ್ಟ್ಗಳನ್ನು ಹಾಕುವಂಥದ್ದು. ಇನ್ವೆಸ್ಟಿಗೇಷನ್ ಮಾಡಲಿಕ್ಕೆ ಒಬ್ಬ ಇನ್ಸ್ಪೆಕ್ಟರ್ಗೆ ಹೇಳಿದ್ದಾರೆ. ಇನ್ಸ್ಪೆಕ್ಟರ್ ಅಂದ್ರೆ ಅವರಿಗೆ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಇರ್ತದೆ, ಮಿನಿಮಮ್ 15 years ಅಥವಾ 10 years ಒಂದು ಸರ್ವಿಸ್ ಆಗಿರುತ್ತೆ. ಅವರೆಲ್ಲ ಎಲ್ಲೆಂಡೋ ವಿಚಾರಗಳನ್ನ ನೋಡಿರ್ತಾರೆ, ಕ್ರೈಮ್ಸ್ ಅನ್ನ ಸ್ವಲ್ಪ ತಿಳ್ಕೊಂಡಿರ್ತಾರೆ. ಆ ಉದ್ದೇಶಕ್ಕಾಗಿ ಒಬ್ಬ ಇನ್ಸ್ಪೆಕ್ಟರ್ ಇದನ್ನ ಇನ್ವೆಸ್ಟಿಗೇಷನ್ ಮಾಡಬೇಕು ಅಂತ ಹೇಳ್ತಾರೆ. ನೀವು ಬೇರೆ ಬೇರೆ ಕೇಸ್ಗಳಲ್ಲೂ ಕೂಡ ಅಷ್ಟೇ, ಬೇಕಾದ್ರೆ SIT ಕೇಸ್ ಅಂತ ಇದೆ, ಅದನ್ನು ಕೂಡ ಇನ್ಸ್ಪೆಕ್ಟರ್ ಮಾಡ್ತಾರೆ. ನಂತರ IT ಆಕ್ಟ್ ಅಲ್ಲಿ ಏನ್ ಕೇಸ್ ರಿಜಿಸ್ಟರ್ ಮಾಡ್ತಾರೆ ಅದನ್ನು ಇನ್ಸ್ಪೆಕ್ಟರ್ ಮಾಡಬೇಕು ಅಂತಿದೆ. ಸೊ ಗ್ರಾವಿಟಿ ಆಫ್ ದ ಕೇಸ್ ಇರೋದ್ರಿಂದ ಇಲ್ಲೊಬ್ಬ ಇನ್ಸ್ಪೆಕ್ಟರೇ ಇದನ್ನ ತನಿಖೆ ಮಾಡಬೇಕು, ನಾಟ್ ಬಿಲೋ ದಿ ರ್ಯಾಂಕ್ ಆಫ್ ಪೊಲೀಸ್ ಇನ್ಸ್ಪೆಕ್ಟರ್ ಅಂತ ಹೇಳಿದ್ದಾರೆ. ಅಂದ್ರೆ ಸಬ್ ಇನ್ಸ್ಪೆಕ್ಟರ್ ಇನ್ವೆಸ್ಟಿಗೇಷನ್ ಮಾಡಂಗಿಲ್ಲ. ಸೊ ಪೊಲೀಸ್ ಇನ್ಸ್ಪೆಕ್ಟರೇ ಇದನ್ನ ತನಿಖೆಯನ್ನ ಮಾಡಬೇಕು, ಇನ್ವೆಸ್ಟಿಗೇಷನ್ ಮಾಡಬೇಕು, ನಂತರ ಕೋರ್ಟ್ಗೆ ಅವರೇ ಫೈನಲ್ ಚಾರ್ಜ್ ಶೀಟ್ ಅನ್ನ ಕೊಡಬೇಕು. ಸೊ ಗ್ರಾವಿಟಿ ನೀವು ಯೋಚನೆ ಮಾಡಬಹುದು. ನಂತರ ಇಲ್ಲಿ ಇದನ್ನ ಒಬ್ರು CJM ಕೋರ್ಟ್, ನಮ್ಮ ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಗಳಲ್ಲಿ CJM ಕೋರ್ಟ್ ಅವರು ನಡೆಸಬೇಕು ಅಂತಿದೆ. ಬೇಗನೆ ಸ್ಪೀಡಿ ಟ್ರಯಲ್ ಮಾಡಬೇಕು ಅಂತ ಹೇಳಿ ಸ್ಪೆಷಲ್ ಇಂಟೆನ್ಷನ್ ಕೊಟ್ಟು ಇಂಪಾರ್ಟೆನ್ಸ್ ಕೊಟ್ಟಿದೆ, ನಡೆಸ್ತಾರೆ. ನಂತರ ಇಲ್ಲಿ ಈ ತರ ಕೇಸ್ಗಳಲ್ಲಿ ಕೇವಲ ಮ್ಯಾನ್ ಹ್ಯಾಂಡ್ಲಿಂಗ್ ಮಾತ್ರ ಮಾಡೋದಲ್ಲ, ಡಾಕ್ಟರ್ಸ್ಗಳಿಗೆ ಮ್ಯಾನ್ ಹ್ಯಾಂಡ್ಲಿಂಗ್ ಆಗಿರ್ಬೋದು, ಅಥವಾ ಸೆಕ್ಯೂರಿಟಿ ಆಗಿರ್ಬೋದು, ಅಥವಾ ನರ್ಸ್ಗಳಿಗೆ ಆಗಿರ್ಬೋದು, ಅಥವಾ ಹೆಲ್ಪರ್ಸ್ಗೆ ಆಗಿರ್ಬೋದು, ಆಂಬ್ಯುಲೆನ್ಸ್ನವ್ರಿಗೆ ಆಗಿರ್ಬೋದು, ಮ್ಯಾನ್ ಹ್ಯಾಂಡ್ಲಿಂಗ್ ಮಾಡ್ಬಿಡ್ತಾರೆ. ಜೊತೆಗೆ ಪ್ರಾಪರ್ಟಿ ಡ್ಯಾಮೇಜ್ ಮಾಡ್ಬಿಡ್ತಾರೆ. ಬಂದು ಗ್ಲಾಸ್ ಹೊಡೆದಾಕೋದು, ಅಥವಾ ಡಾಕ್ಟರ್ ಚೇಂಬರ್ ಒಳಗೆ ಬಂದು ಎಲ್ಲ ಎಲ್ಲನೂ ಆಚೆ ಪುಸ್ತಕ ಎಲ್ಲ ಬಿಸಾಡಿಸೋದು, ಎಲ್ಲ ತಳ್ಳ ಹಾಕೋದು, ಉಳಿದಿರುವಂಥ ಪೇಷಂಟ್ಗಳಿಗೆ ತೊಂದರೆ ಮಾಡುವಂಥದ್ದು, ಅಥವಾ ಇನ್ನೇನಾದರೂ ಗೌರ್ಮೆಂಟ್ ಅಲ್ಲಿ ಏನು ಪ್ರಾಪರ್ಟಿ ಇರ್ತದೆ ಅದಕ್ಕೆ ಡ್ಯಾಮೇಜ್ ಮಾಡುವಂಥದ್ದು, ಇದನ್ನೆಲ್ಲ ಮಾಡ್ತಾರೆ. ಒಬ್ಬರಿಬ್ಬರು ಇದ್ರೆ ಕಡಿಮೆ, ಜಾಸ್ತಿ ಜನ ಬಂದ್ರೆ ದಾಂಧಲೆನೇ ಮಾಡ್ಬಿಡ್ತಾರೆ. ಸೊ ಇಂಥವ್ರ ಮೇಲೆ ನಿರ್ದಾಕ್ಷಿಣ್ಯವಾಗಿ ಕ್ರಮ ಆಗ್ಬೇಕು ಅಂತ ಹೇಳೋದು ಉದ್ದೇಶಕ್ಕೆ ಅವರಿಂದನೇ ಅದನ್ನ ವಸೂಲಿ ಮಾಡಬೇಕು. ಪೈಸ್ ಈಗ ಏನಾದ್ರು ಒಂದು ಹಾಸ್ಪಿಟಲ್ ಅಥವಾ ಯಾವ್ದು ಮೆಡಿಕಲ್ ಪ್ರೆಸ್ಟೇಷನ್ಸ್ ಒಳಗಡೆ ಹೋಗಿ ಏನಾದ್ರು ತೊಂದರೆ ಮಾಡಿದ್ರು, ಪ್ರಾಪರ್ಟಿ ಡ್ಯಾಮೇಜ್ ಮಾಡಿದ್ರೆ, ಏನ್ ಪ್ರಾಪರ್ಟಿ ಡ್ಯಾಮೇಜ್ ಮಾಡಿದ್ದಾರೆ, ಅದು ವ್ಯಾಲ್ಯೂ ಏನು, ಪೈಸ್ ಅದನ್ನ ಅವರ ಪಾಕೆಟ್ ಇಂದಾನೆ ಅದೇ ಅವಕಾಶ ಇಲ್ಲ. ಓನ್ಲಿ ಥಿಂಗ್ ಇಸ್ ನಾವು ಅದನ್ನ ಹೇಳಿದ್ವು, CC ಫುಟೇಜ್ ಅಂತ ಹೇಳ್ತಾನೆ ಇರ್ತೀವಿ. ಅದನ್ನ ಹಾಕಿ CC ಕ್ಯಾಮರಾವನ್ನ ನೀವು ಚೆನ್ನಾಗಿ ಇಟ್ಕೊಳ್ಬೇಕಾಗಿರೋದು, ಎವ್ರಿ ಡೇ ಇಟ್ ಈಸ್ ವರ್ಕಿಂಗ್ ಆರ್ ನಾಟ್ ಅಂತ ನೋಡ್ಕೊಳ್ಬೇಕಾಗಿರೋದು ನಿಮ್ಮ ಒಂದು ಜವಾಬ್ದಾರಿ ಇರ್ತದೆ. ಇಲ್ಲಿ ರಿಕವರಿ ಕೂಡ ಅವಕಾಶ ಇದೆ ಅಂತ ಹೇಳಿದೆ. ಆಮೇಲೆ ಲ್ಯಾಂಡ್ ರೆವಿನ್ಯೂ ಆಕ್ಟ್ ಪ್ರಕಾರ ಇಲ್ಲಿ ಕೆಲವು ಪ್ರೊಸೀಡಿಂಗ್ಸ್ ನ ಕೂಡ ಮಾಡ್ಲಿಕ್ಕೂ ಕೂಡ ಅವಕಾಶ. ನಾವೀಗ ಕೋರ್ಟ್ ಮುಂದೆ ಪ್ರೊಡ್ಯೂಸ್ ಮಾಡ್ಬೋದಾ ಮಾಡಬಾರ್ದಾ ಅಂತೇಳಿ ನಾವು ಕೇಸ್ಗಳನ್ನ ಪ್ರೊಡ್ಯೂಸ್ ಮಾಡಬಾರ್ದು ಅಂತ ಹೇಳಿಲ್ಲ. ಅದು ಜಡ್ಜ್ಮೆಂಟ್ ಅಲ್ಲಿ ಹೇಳಿದೆ, 7 years ಗಿಂತ ಬಿಲೋ ಇರುವಂತಹ ಕೇಸ್ಗಳಿಗೆ 3 years ಪನಿಷ್ಮೆಂಟ್, ಅಪ್ ಟು 7 years ಗಂಟ ಪನಿಷ್ಮೆಂಟ್ ಯಾವ ಕೇಸ್ ಇದೆ ಆ ಕೇಸ್ಗಳಿಗೆ ನೀವು ಸ್ಟೇಷನ್ ಬೇಲಲ್ಲಿ ಬಿಡಿ, ಇನ್ವೆಸ್ಟಿಗೇಷನ್ ಕೋಆಪರೇಟ್ ಮಾಡುವಾಗ ನೀವು ಯಾಕೆ ಬಿಡಲ್ಲ ಅಂತ ಹೇಳುವಂತಹ ಪ್ರಶ್ನೆಗಳು ರೈಸ್ ಆಗುತ್ತೆ. ಸೊ ಎಲ್ಲ ಕೇಸಲ್ಲಿ ಆ ಥರ ಮಾಡಬೇಕು ಅಂತ ಏನಿಲ್ಲ. ಸೊ IO ಯಾರು ಇನ್ವೆಸ್ಟಿಗೇಷನ್ ಆಫೀಸರ್ಸ್ ಇರ್ತಾರೆ ಅವ್ರಿಗೆ ಕೋರ್ಟ್ಗೆ ಕನ್ವಿನ್ಸ್ ಮಾಡಬೇಕು ಬೈ ರೈಟಿಂಗ್, ನಾನು ಯಾಕೆ ಇವ್ರನ್ನ ಬಿಡ್ತಾ ಇಲ್ಲ ಸ್ಟೇಷನ್ ಅಲ್ಲಿ, ಯು ಶುಡ್ ರೈಟ್, ನೀವು ಬರಿಬೇಕು ಯಾವ ರೀಸನ್ಸ್ಗೋಸ್ಕರ ನಾನು ಅವ್ರನ್ನ ಬಿಡ್ತಾ ಇಲ್ಲ, ಯಾವ ರೀಸನ್ಸ್ಗೋಸ್ಕರ ನಾನು ಅವ್ರನ್ನ ಪ್ರೊಡ್ಯೂಸ್ ಮಾಡ್ತಿದ್ದೀನಿ, ಸೊ ಅಂಡ್ ಸೊ ರೀಸನ್ಗೋಸ್ಕರ ನಾನು ಅವ್ರನ್ನ ಪ್ರೊಡ್ಯೂಸ್ ಮಾಡ್ತೀನಿ. ದಿಸ್ ಇಸ್ ನಾಟ್ ಎ ನಾರ್ಮಲ್ ಕೇಸ್, ದಿಸ್ ಇಸ್ ಎ ಸ್ಪೆಷಲ್ ಕೇಸ್ ಇದೆ. ನಾಳೆ ದಿವಸ ಹಿಂಗೇನೆ ಡಾಕ್ಟರ್ಸ್ನ ಬಂದು ಹೊಡಿತಾ ಇದ್ರೆ ಬಡಿತಾ ಇದ್ರೆ ಅವ್ರಿಗೆ ಮೈಂಡಲ್ಲಿ ಬಂದ್ಬಿಡುತ್ತೆ, ಏನಾಗಲ್ಲ, ಎಂಥದ್ದು ಆಗಲ್ಲ ಅಂತ ಹೇಳೋಂಥದ್ದು ಅವ್ರ ಮೈಂಡ್ ಸೆಟ್ಟಿಗೆ ಬಂದ್ಬಿಟ್ರೆ, ಅವರು ಲಾ ಇಷ್ಟೇನಾ ಅಂತ ಅನ್ಸೋದು ಅವ್ರಿಗೆ ಬಂದ್ಬಿಟ್ರೆ ಅವರು ಅದನ್ನ ಕಂಟಿನ್ಯೂ ಮಾಡೋಂಥ ಚಾನ್ಸಸ್ ಜಾಸ್ತಿ. ಆದ್ರಿಂದ ಅವ್ರ ಮೇಲೆ ಕಂಪ್ಲೇಂಟ್ ಅನ್ನ ಯಾವ ಸಂದರ್ಭದಲ್ಲಿ ಕೊಡಲೇಬೇಕು ಅಂತ ಸಂದರ್ಭದಲ್ಲಿ ಯಾವುದೇ ಹೆಸಿಟೇಷನ್ಸ್ ಇಲ್ಲದೆ ಅದಕ್ಕೆ ಸಂಬಂಧಪಟ್ಟಾಗೆ ಸರ್ ಹೇಳಿದ್ರು ಲೆಜಿಬಲ್ ಹ್ಯಾಂಡ್ ರೈಟಿಂಗ್ ಅಂತ ಹೇಳಿ. ನಮಗೆ ಡಾಕ್ಟರ್ಸ್ ಹ್ಯಾಂಡ್ ರೈಟಿಂಗ್ ಅನ್ನ ಸ್ವಲ್ಪ ಓದೋದು ಕಷ್ಟ ಆಗುತ್ತೆ. ನಾವು ಮತ್ತೆ ಮೇಡಮ್ ಇದೇನಿದೆ ಕಳಿಸ್ತೀವಿ, ಇದೇನಿದೆ ಒಂಚೂರು ಡಾಕ್ಟರ್ ಹತ್ರ ಒಂಚೂರು ನೋಡಿ ಹೇಳ್ಕೊಂಡು ಇದೊಂದು ವರ್ಡ್ಸ್ ನನಗೆ ಅರ್ಥ ಆಗ್ತದೆ. ಯಾಕೆಂದ್ರೆ ನಿಮ್ದು ಕೂಡ ಮೆಡಿಕಲ್ ಟರ್ಮ್ಸ್ ಎಲ್ಲ ಇರ್ತದೆ, ನಮ್ಗೆ ಅಷ್ಟೊಂದು ದೊಡ್ಡ ಅರ್ಥ ಆಗಲ್ಲ. ಬಟ್ ಅದನ್ನೊಂದ್ಸಲ ನಾವು ಆ ವರ್ಡ್ ಗೊತ್ತಾಗಲ್ಲ ಒಂದ್ಸಲ ಗೂಗಲಲ್ಲಿ ನೋಡ್ತೀವಿ, ಈ ಥರನೇ ಇದೆ, ಹೌದಾ ಈ ಥರ ಇರ್ಬೋದು ಅಂತೇಳಿ. ಆಮೇಲೆ ಕಳಿಸಿ ನಿಮ್ಮ ಹತ್ರ ಒಪಿನಿಯನ್ಗೆ ಕೇಳ್ತೀವಿ. ಆ ಲೆಜಿಬಲ್ ಹ್ಯಾಂಡ್ ರೈಟಿಂಗ್ ಇರಬೇಕು ಅಂತ ಸತ್ಯ, ನಾನು ಅದನ್ನ ಒಪ್ಕೊಳ್ತೀನಿ. ನಮ್ಮ ಹ್ಯಾಂಡ್ ರೈಟಿಂಗ್ ಆದ್ರೂ ಕೂಡ ಅಷ್ಟೇ, ನಾವು ಜಿಡಿ ಬರಿತೀವಿ, ನಮ್ಮ ಜಿಡಿನೇ ತಗೋತಾರೆ. ಸ್ಟೇಷನ್ ಹೌಸ್ ಡೈರಿನ ಕಾಲ್ ಮಾಡ್ತಾರೆ, ಬರ್ದಿದಾರ ಅವರು, ಹೌದು ನಿಜಾನ, ಅವ್ನು ಇಷ್ಟು ಗಂಟೆಗೆ ಅರೆಸ್ಟ್ ಆಗಿದ್ನ, ಸ್ಟೇಷನ್ ಅಲ್ಲಿ ಬಂದ, 24 hours ನಮ್ದು ಅಡ್ಮಿನಿಸ್ಟ್ರೇಷನ್ ಇದನ್ನ ನಾವು ಸ್ಟೇಷನ್ ಜಿಡಿಲಿ ರೆಕಾರ್ಡ್ ಮಾಡಬೇಕು. ಸೊ ಎಲ್ಲ ಕೇಸ್ಗಳು ಅದು ಇಂಪಾರ್ಟೆಂಟ್ ಅಲ್ಲ, ಬಟ್ ಇನ್ ಗ್ರೇವಿಯಸ್ ಕೇಸಸ್, ಹೈ ಪೊಟೆನ್ಷಿಯಲ್ ಕೇಸ್ಗಳಲ್ಲಿ ನಾವು ಎಲ್ಲಾನು ಕೂಡ ಕೇಳುವಂತ ಅವಕಾಶ ಇರ್ತದೆ. ಅದನ್ನ ನಾವು ಜಿಡಿಲಿ ಬರಿತೀವಿ. ನಮ್ಮ ಹ್ಯಾಂಡ್ ರೈಟಿಂಗ್ ಕೂಡ ಲೆಜಿಬಲ್ ಇರಬೇಕು. ಅದು ಮ್ಯಾಜಿಸ್ಟ್ರೇಟು, ಡಿಫೆನ್ಸ್ ಕೌನ್ಸಿಲ್, ಅಕ್ಯೂಸ್ಡ್, ಆಮೇಲೆ ಪಬ್ಲಿಕ್ ಪ್ರಾಸಿಕ್ಯೂಟರ್ಸ್ ಎಲ್ಲರೂ ಕೂಡ ಓದುವ ರೀತಿಯಲ್ಲಿ ಇರಬೇಕು, ಅವ್ರಿಗೆ ಗೊತ್ತಾಗ್ಬೇಕು. ಇದನ್ನ ನಾವು ಫಾಲೋ ಮಾಡಬೇಕು. ಜೊತೆಗೆ ಡಾಕ್ಟರ್ಸ್ಗಳಾದ ನೀವುಗಳು ಕೂಡ ಅದನ್ನ ಫಾಲೋ ಮಾಡಬೇಕಾಗತ್ತೆ. ಆಮೇಲೆ ಇನ್ನೊಂದು, ಸಾಮಾನ್ಯ ಪಿಪಿಗಳು ನಮ್ಮ ಜೊತೆ ಡಿಸ್ಕಷನ್ ಮಾಡಿದಾಗ ಬ್ಲಡ್ ಸ್ಟೈನ್ ಅನ್ನ ನಾವು ಕರೆಕ್ಟ್ ಮಾಡ್ಕೊಡಿ ಸರ್ ಅಂದಾಗ, ಬ್ಲಡ್ ಸ್ಟೈನ್ ಅನ್ನ ಲಿಕ್ವಿಡ್ ಇದರಲ್ಲಿ ಕರೆಕ್ಟ್ ಮಾಡ್ಬಿಡ್ತಾರೆ. ಅದನ್ನ ಇಟ್ ಈಸ್ ವೆಲ್ ಅಂಡ್ ಗುಡ್, ಚೆನ್ನಾಗಿ ಎಲ್ಲನೂ ಕೂಡ ಸೀಲ್ ಆಗಿ ನಮ್ಮ ಹಾಸ್ಪಿಟಲ್ಗಳಿಂದ ಬರ್ತಾ ಇದೆ, ನೀಟಾಗಿ ನೋಟ್ ಆಗ್ತಾ ಇದೆ, ಇದೆಲ್ಲವೂ ಕೂಡ ಗುಡ್, ನೀಟಾಗಿ ಬರ್ತಾ ಇದೆ. ಕೆಲವೊಂದು ಸಂದರ್ಭದಲ್ಲಿ ಏನಾಗುತ್ತೆ ಅಂತ ಹೇಳಿದ್ರೆ, ನಾನು ಡಾಕ್ಯುಮೆಂಟೇಶನ್ ನೋಡದೇ ಇದ್ದಾಗ ಏನ್ ಸಮಸ್ಯೆ ಆಗುತ್ತೆ ಅಂತ ಹೇಳೋದನ್ನ ಒಂದು ಸಣ್ಣ ಉದಾಹರಣೆಯಲ್ಲಿ ಹೇಳ್ತೀನಿ. ನಾನೇ ಸಬ್ ಇನ್ಸ್ಪೆಕ್ಟರ್ ಆಗಿದ್ದೆ ಒಂದು ಸ್ಟೇಷನ್ ಅಲ್ಲಿ. ಅಲ್ಲಿ ಏನಾಯ್ತು ಅಂತ ಹೇಳಿದ್ರೆ, ಒಂದು RTI ಇಂಟಿಮೇಷನ್ ಬರುತ್ತೆ, ರೋಡ್ ಟ್ರಾಫಿಕ್ ಆಕ್ಸಿಡೆಂಟ್. ಬಟ್ ಅದ್ರಲ್ಲಿ ಏನಾಗುತ್ತೆ ಅಂತ ಹೇಳಿದ್ರೆ, RTI ಇರ್ಲಿಲ್ಲ, ಅದರಲ್ಲಿ ಫಾಲ್ ಫ್ರಮ್ ಟ್ರೀ ಇತ್ತು. ಆಕ್ಚುಲಿ ಅವರು ಗಾಡಿಗೆ ಇನ್ಶೂರೆನ್ಸ್ ಇರ್ಲಿಲ್ಲ, ಆಕ್ಸಿಡೆಂಟ್ ಆಗ್ಬಿಡ್ತಿದ್ದು, ಇನ್ಶೂರೆನ್ಸ್ ಇರ್ಲಿಲ್ಲ. ಅವ್ರು ಏನ್ ಮಾಡಿದ್ರು, ಓನರ್ಸ್ ಎಲ್ಲ ಮಾತಾಡ್ಕೊಂಡು ಫಾಲ್ ಫ್ರಮ್ ಟ್ರೀ ಅಂತ ಮಾಡ್ಬಿಟ್ಟು ಡಾಕ್ಟರ್ಗೆ ಅವ್ರು ಏನ್ ಹೇಳಿದ್ರೆ, ಡಾಕ್ಟರ್ ಆಸ್ ಇಟ್ ಈಸ್ ಅವ್ರು ಏನ್ ಹೇಳಿದ್ರೆ ಅದನ್ನೇ ರೆಕಾರ್ಡ್ ಮಾಡಿದ್ದಾರೆ. ಅವ್ರ ಸೈಡಿಂದ ಕರೆಕ್ಟ್. ಅಲ್ಲಿಂದ ಬಂದ್ರು, ಅಲ್ಲಿ ಪ್ರೈಮರಿ ಟ್ರೀಟ್ಮೆಂಟ್ ಆಯ್ತು. ನೆಕ್ಸ್ಟ್ ಬೇರೆ ಹಾಸ್ಪಿಟ್ಲಿಗೆ ಹೋದ್ರು, ಅಲ್ಲಿ ಏನ್ ಹೇಳಿದ್ರು ಇವರು ಸರಿಯಾಗ್ಲಿಲ್ಲ ಮಾತುಕತೆ. ಅಲ್ಲಿ ಹೋದಾಗ ರೋಡ್ ಆಕ್ಸಿಡೆಂಟ್ ಅಂತ ಹೇಳಿ ಕೊಟ್ಟರು. ಅಲ್ಲಿ ರೋಡ್ ಆಕ್ಸಿಡೆಂಟ್ ಅಂತ ಆಯ್ತಾ, ಫಸ್ಟ್ ಡಾಕ್ಟರ್ ಸರ್ ಏನ್ ಬಂದ್ರು, ಫಾಲ್ ಫ್ರಮ್ ಟ್ರೀ ಅಂತ ಆಯ್ತಾ, ಆಯ್ತು. ಇನ್ವೆಸ್ಟಿಗೇಷನ್ ನಮಗೆ ಬಂತು. ನಾವು ಅವಾಗ ಬೆಳಿ ಕಂಡುಬಿಡ್ತಾ ಇದ್ವಿ ಸಬ್ ಇನ್ಸ್ಪೆಕ್ಟರ್ ಆಗಿ, ಆಯ್ತಾ. ಏನ್ ಗೊತ್ತಿರೋದು, ದೊಡ್ಡವರು ಯಾರು ಹಿರಿಯರು ಯಾರು ಇರ್ತಾರೋ ಅವ್ರು ಮಾಡಿದ್ರೆ ಸರಿ ಅಂತ ಹೇಳೋ ಲೆಕ್ಕದಲ್ಲಿ ಕಲಿತಾ ಇತ್ತು ಅವಾಗ ಕೆಲಸ. ನಾವೇನ್ ಮಾಡ್ದು, ಎಲ್ಲ ಆಯ್ತು, ಇನ್ವೆಸ್ಟಿಗೇಷನ್ ಎಲ್ಲ ಆಯ್ತು, RTO ಹತ್ರ ಹೋಯ್ತು, ಗಾಡಿ RTO ಇನ್ಸ್ಪೆಕ್ಷನ್ ಆಯ್ತು, ದಿಸ್ ಇಸ್ ನಾಟ್ ಮೆಕ್ಯಾನಿಕಲ್ ಫಾಲ್ಟ್, ದಿಸ್ ಇಸ್ ಮ್ಯಾನ್ಯುವಲ್ ಫಾಲ್ಟ್ ಅಂತ ಕೊಟ್ಟು ಹೋಯ್ತು ರಿಪೋರ್ಟು. ನಾವು ರಿಸೀವ್ ಹಾಕೊಂಡು ಆಯ್ತು. ಡಾಕ್ಟರ್ ಹತ್ರ ಒಪಿನಿಯನ್ ತಗೋಬೇಕಲ್ಲ, ಓನ್ ಸರ್ಟಿಫಿಕೇಟ್ ಬರ್ದು. ಡಾಕ್ಟರ್ ಫಾಲ್ ಫ್ರಮ್ ಟ್ರೀ ತಾನೇ ಕೊಟ್ಟಿದ್ದಾರೆ, ಬಂದು ಆಯ್ತು. ನಾವು ಕಣ್ಣು ಮುಚ್ಕೊಂಡು ಅದಕ್ಕೆ ರಿಸೀವ್ ಮಾಡಿ ಆಯ್ತು, ಚಾರ್ಜ್ ಶೀಟ್ ಮಾಡಿ ಕಳಿಸು ಆಯ್ತು. ಹೋಯ್ತು. ಹೋಗಾದ್ಮೇಲೆ ಡಿಫೆನ್ಸ್ ಲಾಯರ್ ಅದನ್ನ ಹಿಡ್ಕೊಂಡ್ರು. ಇದ್ರಲ್ಲಿ ನೋಡಿ, ಫಾಲ್ ಫ್ರಮ್ ಟ್ರೀ ಅಂತಿದೆ, ನೀವು ನೋಡಿದ್ರೆ ಆಕ್ಸಿಡೆಂಟ್ ಕೇಸಿಗೆ ಚಾರ್ಜ್ ಶೀಟ್ ಮಾಡಿದ್ರೆ ಅವ್ರು ಅದನ್ನೇ ವಾದ ಮಾಡಿದ್ರು. ನಂತರ MECC ಕ್ಲೈಮ್ಗೆ ಅಲ್ಲಿ ಆಗ್ಲಿಲ್ಲ ಅಂತೇಳಿ MECC ಕ್ಲೈಮ್ಗೆ ಬೆಂಗಳೂರಿಗೆ ಹಾಕೊಂಡ್ರು. ಬೆಂಗಳೂರಿಗೆ ಹಾಕಿದ್ಮೇಲೆ ಒಂದು ಎಂಕ್ವೈರಿ ಸ್ಟಾರ್ಟ್ ಆಯ್ತು. ಆ ಎಂಕ್ವೈರಿಲಿ ನಾವು ಮಾಡಿರೋ ಮಿಸ್ಟೇಕ್ ನಮಗೆ ಗೊತ್ತಾಯ್ತು. ಫಸ್ಟ್ ಟೈಮ್ ಅಂತ ಹೇಳಿ ನನಗೆ ಒಬ್ರು ಸುಧೀರ್ ಕುಮಾರ್ ಮುರೊಳ್ಳಿ ಇದ್ದಾರೆ, ಅಡ್ವೊಕೇಟ್. ನೀವು ಇದರಲ್ಲಿ ಫೇಸ್ಬುಕ್ ಅಲ್ಲಿ ಹೊಡೆದ್ರೆ ಬರ್ತಾರೆ, ಸುಧೀರ್ ಕುಮಾರ್ ಮುರೊಳ್ಳಿ ಅಂತ ಒಬ್ರು ಇದ್ದಾರೆ ಚಿಕ್ಕಮಗಳೂರಲ್ಲಿ. ಅವರೇ ಲಾಯರ್. ನಾನು ಅವ್ರನ್ನ ಪ್ಲೀಸ್ ಮಾಡಿ, ಸರ್ ನಮ್ಮಿಂದ ತಪ್ಪಾಗ್ಬಿಟ್ಟಿದೆ, ದಯವಿಟ್ಟು ನಮ್ಮಿಂದ ಅವರಿಗೆ ಇದಾಗೋದು ಬೇಡ, ನಾನೇ ಮಾತಾಡಿಸಿ ಸರಿ ಮಾಡಿಸ್ತೀನಿ ಅಂತೇಳಿ ನಂತರ ಎರಡೂ ಪಾರ್ಟಿಗಳನ್ನ ಕೂರಿಸಿ ಸರಿ ಮಾಡಿಸಿ, ಹಣ ಎಲ್ಲ ಕೊಡಿಸಿ ಸರಿ ಮಾಡಿಸ್ತೀನಿ. ಸೊ ಈ ಥರ ಮಿಸ್ಟೇಕ್ಸ್ ಆಗ್ಬಿಡ್ತದೆ. ಬಟ್ ಎಲ್ಲ ಸಂದರ್ಭದಲ್ಲಿ ನಮ್ಮ ಸ್ಕಿನ್ ಸೇವ್ ಆಗುತ್ತೆ ಅಂತ ನಾವು ಅನ್ಕೋಬಾರ್ದು. ಎವ್ರಿ ಡೇ ಇಸ್ ನಾಟ್ ಸಂಡೇ. ಕೆಲವೊಂದು ಸಂದರ್ಭದಲ್ಲಿ ನಾವು ಮಾಡೋ ಕೆಲವು ಮಿಸ್ಟೇಕ್ಗಳಿಂದ ನಾವು ನ್ಯಾಯ ಕೊಡೋಕೆ ಆಗಲ್ಲ. ನಿಜವಾಗ್ಲೂ ನನಗೆ ಸ್ಪೆಷಲ್ ಆಕ್ಟೇ ಮಾಡಿದೆ. ಸೊ ಇದರ ಇಂಪಾರ್ಟೆನ್ಸ್ ನೀವು ಖಂಡಿತವಾಗ್ಲೂ ಅರ್ಥ ಮಾಡ್ಕೊಳ್ತೀರಾ ಅಂತ ನಾವು ಅನ್ಕೊಂಡಿದೀವಿ. ಪೊಲೀಸಿಂದ ಬರುವಂತ ರಿಕ್ವೆಸ್ಟ್, ಒಂದು ಅಕ್ಯೂಸ್ ನ ಅರೆಸ್ಟ್ ಮಾಡಿದಾಗ ಅವನ್ನ 24 hours ಒಳಗಡೆ ಅವನ್ನ ಪ್ರೊಡ್ಯೂಸ್ ಮಾಡಬೇಕಿರ್ತದೆ ಒಂದು. ಎರಡನೇದಾಗಿ ಅಕ್ಯೂಸ್ಡ್ ಮೇಲೆ ಏನಾದರೂ ಎವಿಡೆನ್ಸಸ್ಗಳಿದ್ರೆ ಅದನ್ನ ಕಲೆಕ್ಟ್ ಮಾಡ್ಲಿಕ್ಕೆ ಒಂದು ಕೊಡ್ತೀವಿ. ಆಮೇಲೆ ರೇಪ್ ವಿಕ್ಟಿಮ್ ಯಾರಾದ್ರೂ ಬಂದರೆ ಅದು ತುಂಬ ಪ್ರಯಾರಿಟಿ. ಅದನ್ನು ನೀವು ಏನೇನು ಮಾಡಬೇಕು ಅಂತ ಹೇಳೋದ್ರ ಬಗ್ಗೆ ನಿಮಗೆ ಗೈಡ್ಲೈನ್ಸ್ ಇರುತ್ತೆ. ಸೊ ಅದರಲ್ಲಿ ಯಾವುದೇ ಗೈಡ್ಲೈನ್ಸನ್ನು ಒಂದು ವೈಲೇಟ್ ಆಗದೆ ಕೂಡ ನೀವು ಮಾಡಿಕೊಡ್ಬೇಕಾಗುತ್ತೆ. ಆಮೇಲೆ ಪೋಕ್ಸೋ ಆ್ಯಕ್ಟಿಗೆ ಸಂಬಂಧಪಟ್ಟಾಗೆ ಸೆಪರೇಟಾಗಿ ಸೆಕ್ಷನ್ 27 ಕೂಡ ನಿಮಗೆ ಹೇಳಿದ್ದಾರೆ ಏನು ಮಾಡಬೇಕು, ಎಂತ ಮಾಡಬೇಕು ಅಂತ ಹೇಳಿ ಪ್ರತಿಯೊಂದನ್ನು ಕೂಡ ನಿಮಗೆ ರೈಟಿಂಗಲ್ಲೇ ಆ್ಯಕ್ಟಲ್ಲೇ ಇದೆ. ಸೊ ಎಲ್ಲವನ್ನು ಕೂಡ ನೀವು ಫಾಲೋ ಮಾಡಬೇಕು. ಹಾಗೆಯೇ ನಿಮಗೆ ನಿಮ್ಮ ಮೆಡಿಕಲ್ ವಿಚಾರದ ಜೊತೆಗೆ ಈ ಆ್ಯಕ್ಟ್ ಮತ್ತು ನಿಮಗೆ ಸಂಬಂಧಪಟ್ಟಂಥ ಯಾವುದಿದೆ ಸೆಕ್ಷನ್ಸ್ಗಳು ಅದನ್ನು ಓದಿ ತಿಳ್ಕೊಳ್ಬೇಕು ಅಂತೇಳಿ ಹೇಳ್ತಾ ನನಗೆ ಇಲ್ಲಿ ಮಾತನಾಡಲಿಕ್ಕೆ ಅವಕಾಶ ಕೊಟ್ಟಿದ್ದಕ್ಕೆ, ನಿಮ್ಮ ಜೊತೆ ಈ ಒಂದೆರಡು ವಿಚಾರಗಳನ್ನು ಶೇರ್ ಮಾಡಲಿಕ್ಕೆ ಅವಕಾಶ ಕೊಟ್ಟಿದ್ದಕ್ಕೆ ನಿಮಗೆಲ್ಲರೂ ಕೂಡ ಧನ್ಯವಾದಗಳು.
A token of appreciation to
the presumption is always in favor of innocence, not guilt. So even if the one material witness turns hostile, the entire case turns on the neck. See, the problem is most of the witnesses who are from the medical fraternity, they themselves are not ready when the police are called to be a major witness, or even if they become a major witness, they may turn hostile. Material witness turns hostile. So we have to see that once the investigation is properly done, the witnesses are well prepared, and see that the conviction rate goes up. At least 2 or 3 convictions from court will send a
department, including at the constable level, so that some awareness implementation should be done, I think, sir. For people sensitize.
Yes, sir. Yes, sir. That is not for the police people to get themselves equipped with how to go about when there is a violence, all those things. And problem, we have to admit that we doctors fail to go and give complaint. In spite of having 70% of the violence against doctors, starting from murder that happened, where a house surgeon was stabbed to death in Kerala, to instigating and abetting suicide at Rajasthan by Archana Sharma, we all have kept quiet and made only a token representative from the doctors, from the medical students, to the public and the police officers. The awareness is lacking, and I think we have to work somewhere to bring about this awareness. I think with that, I think things should fall in line. Thank you so much.
He is worried about his career, so he is not ready to give complaint. Next thing, the hospital administrators, my principal or the medical director, whoever gives a complaint, that is a statutory body. So he will be there for a long time. If he is not there, the successor will continue with the complaint. So whether in that act, whether only the victim should give complaint or the administrator can give complaint without the victim involvement. So second question is, whenever we go to the complaint, whether we should take advocate along with that so that the sections are properly incited. So that's what, because none of the students give complaint because they know they will not get NOC from KMC if they want to go abroad later. So
students, this is a take-home message. If there is violence in any of the institutions, the veracity or violence liability falls on the institution also. They have to file a case against that particular violator on behalf of the student. Okay, it's an institutional.
ವಿಕ್ಟಿಮ್ ಡೈರೆಕ್ಟ್ ಆಗು ಕೊಡ್ಬೋದು. ನಂತರ ಅವರು ಕೌಂಟರ್ ಕೇಸ್ ಕೊಡ್ತಾರೆ ಅಂತ ಹೇಳಿದ್ರೆ ಸರ್ ಇನ್ನೊಂದು ಪ್ರಶ್ನೆ. ದೇ ಆರ್ ಗೋಯಿಂಗ್ ಟು ರಿಜಿಸ್ಟರ್ ಅ ಕೌಂಟರ್ ಕೇಸ್ ಅಗೇನ್ಸ್ಟ್ ಅ ಡಾಕ್ಟರ್. ಡಾಕ್ಟರ್ ಈಸ್ ವೈಲೇಟಿಂಗ್ ಅಸ್ ತೆಪ್ಪ ಕೊಡ್ತಾರೆ ಅಂತ ಹೇಳಿ. ಸೊ ವಿ ವಿಲ್ ಇನ್ವೆಸ್ಟಿಗೇಟ್. ದಿಸ್ ಈಸ್ ವಾಟ್ ಇನ್ ಕುಶಾಲನಗರ ವಾಸ್ ಹ್ಯಾಪನ್. ಕರೆಕ್ಟ್ ಅನ್ಕೊಳ್ತೀನಿ. ಅಟ್ರಾಸಿಟಿ, ದೇ ಆರ್ ವರ್ಕಿಂಗ್ ಅಟ್ರಾಸಿಟಿ ಅಗೇನ್ಸ್ಟ್ ಡಾಕ್ಟರ್ಸ್ ಆಗಿದೆ, ಒಂದು ಕೇಸ್ ಆಗಿದೆ. DCR ಇನ್ಸ್ಪೆಕ್ಟರ್ ಅವರು ಅದನ್ನ ತನಿಖೆ ಮಾಡ್ತಾ ಇದ್ದಾರೆ, ಇನ್ವೆಸ್ಟಿಗೇಷನ್ ಆಗ್ತಾ ಇದೆ. ಸೊ ನೀವು ಅದಕ್ಕೆ ಎದುರ್ಕೊಂಡು ಅವರು ನಮ್ಮನ್ನು ಕೊಡ್ತಾರೆ ಅಂತ ಹೇಳಿ ನೀವು ಅದನ್ನ ಹೆಸಿಟೇಟ್ ಮಾಡಬಾರ್ದು. ಯು ಕಮ್ ಫಾರ್ವರ್ಡ್ ಫ್ರೀಲಿ ಅಂಡ್ ಗಿವ್ ದಿ ಕಂಪ್ಲೇಂಟ್, ವೆದರ್ ಯು ಆಸ್ ಎ ವಿಕ್ಟಿಮ್ ಆರ್ ಆಸ್ ಎ ಇನ್ಸ್ಟಿಟ್ಯೂಷನಲ್ ಆರ್ ಯುವರ್ ಫ್ರೆಂಡ್ಸ್ ಹೂ ಆರ್ knowing the information about the ಅದನ್ನೆಲ್ಲ ಅಥವಾ ಸೀನಿಯರ್ ಯಾರು ಕೂತಿದ್ದಾರೆ ಅವ್ರಿಗೆಲ್ಲರೂ ಕೂಡ ಗೊತ್ತಿರುತ್ತೆ. ದೇ ವಿಲ್ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಆಗಿರುತ್ತೆ, ಅವ್ರಿಗೆ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಆಗಿರುತ್ತೆ.
Sir, I do agree. And for the last 2 or 3 decades, okay, Indian Medical Association of fighting with the central government, stating that we don't have a central law to prevent the violence against the doctors. Because whatever the laws implemented in 28 states out of 31 states, everybody knows it, but the police also know that there is a laxity in the enforcement body. Maybe many times I have come across cases where doctors have been told when they went to give a complaint.
ಯಾವುದೇ ಕಂಪ್ಲೇಂಟ್ ಸಂಬಂಧಪಟ್ಟಾಗಿ ಆಕ್ಟಿಗೆ ಸಂಬಂಧಪಟ್ಟಾಗ ಬಂದ್ರೆ ವಿ ವಿಲ್ ರಿಜಿಸ್ಟರ್ ಕೇಸ್. ಫಸ್ಟ್ ಆಫ್ ಆಲ್ ಕೇಸ್. ಆಮೇಲೆ ಯಾರು ಅದನ್ನ ಪೊಲೀಸ್ನವ್ರು ಇಲ್ಲ ಹಾಗೆ ಹೇಳ್ಬಿಟ್ರು ಅದನ್ನ ಈ ತರ ಮಾಡ್ಕೊಳ್ಳಿ ಕಾಂಪ್ರಮೈಸ್ ಸಾರಿ ಹೇಳ್ಬಿಟ್ಟು, ದಟ್ ಈಸ್ ನಾಟ್ ಪರ್ಸನಲ್ ಪ್ರೊಫೆಷನಲ್ ಪಾಲಿಸಿ. ದಟ್ ಈಸ್ ರಾಂಗ್. ಯಾರೇ ಬಂದಾಗ ನಾವು ಅದು ನಮ್ಮ ಡ್ಯೂಟಿ ಏನು ವೆದರ್ ಅವರು ರೈಟಿಂಗ್ ಅಲ್ಲಿ ತಗೊಂಡ್ಬಂದಿದ್ದಾರೆ ಕಾಂಗ್ರೆಸ್ ಕಾಣ್ತಾ ಇದೆ, ಯು ಶುಡ್ ಗೋ ಫಾರ್ FIR ಓನ್ಲಿ, ಮಾಡಲೇಬೇಕು. ಅದು ಮಾಡಲಿಲ್ಲ ಅಂತ ಹೇಳಿದ್ರೆ ಅದು ಪ್ರೊಫೆಷನಲ್ ಪೊಲೀಸಿಂಗ್ ಅಲ್ಲ, ಮಾಡಲೇಬೇಕು. ಇನ್ನೊಂದು ಹೇಳ್ತೀನಿ, ನಮಗೆ ಕಂಪ್ಲೇಂಟ್ ಬಂದು ಅವ್ರು ಇಂಟೆನ್ಷನಲಿ ಡಿನೇ ಮಾಡಿದ್ರೆ ಅದು ನಮ್ದು ತಪ್ಪು, ನಮ್ಮ ಮೇಲೆ ಎನ್ಕ್ವೈರಿ ಆಗುತ್ತೆ. ಕಂಪ್ಲೇಂಟ್ ಅನ್ನ ಕೊಡ್ಲಿಕ್ಕೆ ಫಾರ್ವರ್ಡ್ ಬಂದಾಗ ಖಂಡಿತವಾಗ್ಲೂ ಯಾವುದೇ ಕಾರಣಕ್ಕೆ ಅದು FIR ಆಗದೆ ಉಳಿಯಲ್ಲ, FIR ಆಗೇ ಆಗುತ್ತೆ. ತಾವು ಹೇಳಿದ್ರಿ ಸರ್ ಈಗ ಮತ್ತೆ ಅದ್ರದ್ದು ವಯಸ್ಸನ್ನ ಇದನ್ನ ಮಾಡ್ಲಿಕ್ಕೆ ಅವಕಾಶ ಇದೆ ಅಂತ ಹೇಳಿ, ಬಟ್ ಅದಕ್ಕೆ ನಾನು ಯಾವ ರೀತಿ ಹೇಳ್ತೀನಿ ಅಂತ ಹೇಳಿದ್ರೆ ಅವ್ರಿಗೆ ಮಾಡ್ಲಿಕ್ಕೆ ಶಕ್ತಿ ಇಲ್ಲ ಅಂತ ಹೇಳಿದ್ರೆ ಯು ಶುಡ್ ಡೆಫಿನೆಟ್ಲಿ ಗೋ ಫಾರ್ ಚೈನ್. ಬಟ್ ಅದಕ್ಕೆ ಸರ್ಕಾರನೇ ಹೇಳ್ಬೇಕು. ಈಗ ಅವ್ರಿಗೆ ಅವ್ರ ಇಲ್ಲ ಅದನ್ನ ಕೊಡ್ಲಿಕ್ಕೆ ಶಕ್ತಿ ಇಲ್ಲ ಅಂತ ಹೇಳಿದ್ರೆ ಅದಕ್ಕೆ ಇಲ್ಲ ಅಂತ ಹೇಳಿದ್ರೆ ಅಡಿಷನಲ್ ಇದಾಗುತ್ತೆ. ಈಗ ಆಕ್ಸಿಡೆಂಟ್ ಕೇಸ್ಗಳಲ್ಲಿ ತೀರ್ಕೊಂಡ್ಬಿಡ್ತಾನೆ, ಗಾಡಿಗೆ ಇನ್ಶೂರೆನ್ಸ್ ಇರಲ್ಲ, ಅವ್ನ ಮನೆ ಮಠ ಮಾರಿ ಅಥವಾ ಇದನ್ನ ಕೊಟ್ಟು ಮಾರಿ ಅವನು ಕೊಡ್ಬೇಕು. MECC ಕ್ಲೈಮ್ ಕೋಟಿಗಟ್ಟಲೆ ಕ್ಲೈಮ್ಸ್ ಆಗುತ್ತೆ, ಅಷ್ಟು ಕೊಡ್ಬೇಕು. ಅದು ಕೊಡ್ಲಿಕ್ಕೆ ಆಗಲ್ವಾ? ಅವರು ಟಿಲ್ ಏನು ಕೋರ್ಟ್ಗೆ ಕನಿಷ್ಠ ಗಂಟನೂ ಕೂಡ ಅವರಿಗೆ ಏನು ಅವರಿಗೆ ಕೊಡ್ಬೇಕು ಅಮೌಂಟ್, ಅದು ರೆಡಿ ಆಯ್ತು ಕಂಪ್ಲೇಂಟ್ ಆದ್ಮೇಲೆ 2 ಗವರ್ಮೆಂಟ್ ಪಂಚಾಯಿಸ್ಬೇಕು, ಕರ್ಕೊಂಡು ಗವರ್ಮೆಂಟ್ ಪಂಚಾಯಿಸ್ ಅಥವಾ ಯಾರು ನಿಮ್ಮ ಪರವಾಗಿ ಹೇಳಬೇಕು.
ಆಲ್ ಸ್ಪೇರ್ಸ್ ಆಫ್ ಲಾ. ಹಾಗಾಗಿ ನಾನು ಹೇಳೋದೇನಂದ್ರೆ ಹೆದರ್ಕೊಳ್ಬೇಡಿ, ಯಾಕಂದ್ರೆ ಇನ್ ಆಲ್ ರೆಸ್ಪೆಕ್ಟ್ ಐ ಸೇ ದ ಫಸ್ಟ್ ಡ್ಯೂಟಿ ಆಫ್ ದ ಡಾಕ್ಟರ್ and the oath you take is to treat the people in distress, emergency cases. So at what best you can give to the patient, you please do it. And as far as the assault and violence against it, definitely we should send a message to the society at large. More than that, the hospital establishment and the association should strongly stand as a group so that incident.
What I would say that a strong association rooted in judiciary in India, advocates are rejected with the Consumer Protection Act.
We are very much for the deficiency of service of the advocate also, they are liable under the consumer law.
No sir, one second, I'll tell you. Before that, Sridevi, Supreme Court Judge, okay, 2024, that said that the advocates are exempted from the Consumer Protection Act, but however, VP Chanda versus IMA, case has to be relooked. No, one second. She had written it, but a subsequent Chief Justice of India, he did not mind to revisit or reconsider it. It's a big place for in the remote places where we work.
Okay, is it under medical legal case irrespective of age? Irrespective of age, is it medical legal? If it is yes, it goes as MLC. If it is no, does the attending doctor is in a position to ascertain the cause of death? So if you are in a position to cause of death, if it is yes, formulate the cause of death. It is after you are registered as a doctor, at your level of knowledge, are you able to, if it is elderly, once then this protocol, this is AIMS Gopal protocol, it is followed in almost all the AIMS. Okay, so we gave lot, along with students, teachers, everybody came. So we just started giving a CPR. It was a plenty lot of CPR. It was a 34 years old young man. The cause of death was not known. Coloring, for example, if it is a case of cyanide poisoning, we have got some cases where cyanide poisoning is there. I think it is cherry red color postmortem staining. So if such things are there, either you have to read it, revise it, or see those albums and get used to it.
It is not
sir, the police personnel is here, but police will not agree for that.
No, just wait. So it is up to the blood, there will be pressure. So especially in rural setup when you are alone, you don't jump and don't declare death. Okay, so you wait for some time, then you repeat if possible. Now ECG machine is available everywhere, I think you have to do a ECG document, then declare death. Don't say it once, because after that if something happens, they'll create trouble. So to escape from that, I think last time there was a. So you have to do like that, and you have to address it little tactfully. So it is not.
If not, if there's no any doubt of foul play, I think the police officers can answer that. We have to make it as MLC, as far as I know. All brought cases has to be made MLC. Ball will be in the court of the police people to investigate and find out whether it has to be made MLC or autopsy has to be done.
With Panchana only they can release information or something.
No, just one human. It happened to me. Of the mother, the blood cannot be drawn, and the court immediately asks the mother if she does not give consent. Immediately this you have to go back. There is no option.
Narcotic drugs and ಸೈಕೋಟ್ರಾಪಿಕ್ ಸಬ್ಸ್ಟೆನ್ಸಸ್ ಆ್ಯಕ್ಟಲ್ಲಿ ಕೇಸ್ ಮಾಡಿದ್ದೀನಿ. ದಯವಿಟ್ಟು ಯಾರು ಆ ಥರ ಬ್ಯಾಡ್ ಹ್ಯಾಬಿಟ್ಸ್ಗಳಿಗೆ ಒಳಗಾಗ್ಬಿಡಿ. ಅಂಥವ್ರು ಯಾರಾದರೂ ನಿಮ್ಮನ್ನ ಎಂಟರ್ಟೈನ್ ಮಾಡ್ತಾರೆ ಅಂತಂದರೆ ನಾವು ಖಂಡಿತವಾಗ್ಲೂ ಕೇಸ್ ಬುಕ್ ಮಾಡ್ತೀವಿ. ಆಮೇಲೆ ಕೆರಿಯರ್ ಹಾಳಾಗೋಗ್ಬಿಡುತ್ತೆ.
Give away the proper assistant and head Department of Emergency Medicine to give away the proper